Assalamu alaikum, ladies and gentlemen. I'm Dr. Zara Jahangir, postgraduate resident in rheumatology at Shaikh Zayed Hospital, Lahore, and it's my pleasure to moderate the Rheumacon Pakistan 2025 with Dr. Komal Khan. It is my heartfelt pleasure to welcome you all to our 6th annual international conference, bringing together a distinguished gathering of experts in rheumatology. This year's conference was preceded by a pre-conference workshop that was held yesterday and was attended by our residents. I hope it was a good learning experience for all of the participants. Today, we're anticipating a day of insightful discussions, knowledge sharing, and collaboration aimed at advancing our understanding of rheumatological diseases and treatments. Like last year, this year's conference will again be held in a hybrid format, offering both virtual and live participation. Building on the success of the previous Rheumacons, we expect this year's event to excel in both intellectual rigor and social engagement. Today's program features 3 scientific sessions with in-depth talks by renowned national and international speakers, followed by an interactive question and answer session. Dr. Komal Khan will be taking you through the first scientific session. Over to you, Dr. Komal.
Thank you so much. Assalamu alaikum, everyone, and thank you for joining us today. We look forward to a productive and enriching conference. The first scientific session comprises of 3 lectures that will be followed by an inauguration ceremony, and there will be 2 more scientific sessions. Moving towards our first scientific session without any delay, the speakers of this session are Dr. Maisam Afzal, Dr. Sumaira Farman Raja, and Dr. Hafiz Mahmood Riaz. At the end of each session, there will be question and answers with our panelists. The first presentation of our session is about obstructive uropathy and its related autoimmune diseases. As we all know, there are increasing number of cases involving retroperitoneal fibrosis and obstructive uropathy, highlighting the importance of this topic. Dr. Maisam Afzal, who will share his expertise illuminating the key aspects of this disease. He is the head of Department of Rheumatology at Gulab Devi Hospital, Lahore. He brings extensive expertise, having completed his postgraduate medical training and specialization in rheumatology in UK. Notably, Dr. Maisam Afzal also is a distinguished member of Royal College of Physicians of UK and Royal College of Physicians of Glasgow. He additionally holds a master's degree in rheumatology from Manchester University. Please welcome Dr. Maisam Afzal on the stage.
फुल स्क्रीन कर दें क्योंकि दिखा तो कुछ हुआ नहीं मैंने ओके अस्सलाम वालेकुम Thank you very much for giving me the opportunity to discuss this interesting topic. So let's start with the pool. Who thinks that obstructive uropathy is an autoimmune problem? Can you raise your arm? Raise your hands. Okay. And who thinks it's a mechanical problem? Can you raise your hands? Okay. And who thinks it's both? Can you raise your both hands? Okay, thank you. Fine. So this is the theme of my presentation, and you can see that whatever you see on the surface is not always true. Diseases can behave differently, and we need to dig a little more. So this is the introduction of my. Now, if you see this slide, you can find that common causes are always common, but there are uncommon causes as well. For example, in case of obstructive uropathy, what we are discussing here is autoimmune problem related obstructive uropathy can be caused by IgG4 related diseases, lupus, GPA, sarcoidosis, and Sjogren's syndrome. So let's start with the case presentation. So 65 years old male presented with dysuria and flank pains, and on examination, there is abdominal tenderness and elevated renal functions, anemia, and mild proteinuria. MSU is negative. Ultrasound showed mild to moderate bilateral hydronephrosis. So what's the next investigation would you like to do? Anybody? We have already ruled out infection. Sorry. Okay, the CT scan was done. Can anybody tell any findings here? On the CT scan A. So you can see a mass encasing the aorta and iliac vessels, and you can see a large kidneys here. On the B, it's a normal CT scan with a normal pancreas. So this patient was diagnosed with the idiopathic retroperitoneal fibrosis, was treated with the steroids for the period of 6 months, and gradually steroids were reduced and stopped. And after 1.5 years, in a follow-up, he had another CT scan. What do you see here? Anybody? Okay, fine. So you can see the mass has been reduced in size significantly here in A, and hydronephrosis improved. However, in this picture, you can see the pancreas, sausage-shaped type pancreas, edematous, enlarged. So what other investigation you would like to do here? Any comments on anything? Yes, you are right, absolutely right. So we did the amylase, lipase, which was mildly raised, ANA, ENA was negative, and IgG4 level were raised. So the diagnosis of IgG4 related retroperitoneal fibrosis with autoimmune pancreatitis complicated with obstructive uropathy was made. Patient was treated again with the steroids, and it made a remarkable improvement. So what is IgG4 related diseases? IgG4 related disease is a systemic fibroinflammatory disorder characterized by IgG4 positive plasma cell infiltration, fibrosis, and elevated serum IgG4 level. This disease can affect any organ of the body. So it's a systemic disease, it can affect one organ or can affect multiple organs at a time. And in this disease, there will be the development of the mass around the organ, and it will cause the pressure effects on the organ or can increase the size of the organ. So that's why sometimes it's very difficult to differentiate between the malignancies, infections, and the IgG4 related retroperitoneal fibrosis. So let's discuss a little bit of history, and it's a journey from retroperitoneal fibrosis to IgG4 related retroperitoneal fibrosis. So in early 1900s, this disease was thought to be idiopathic, and Albaran was the first who observed the ureteric obstruction because of the retroperitoneal fibrosis. Fast forward to 1948, Ormond's disease, named at the name of John Ormond, who first identified and described it as the idiopathic retroperitoneal fibrosis. Between 1950 and 1990s, doctors, they identified an interesting immune connection. Some of the cases with the retroperitoneal fibrosis, they responded very well with the steroids. So there was a question whether it's an immune-related disease. So in 2001, some of the researchers who were studying autoimmune pancreatitis, they made a remarkable discovery. They found that IgG4 positive plasma cells actually causing the fibrosis. So that raised another question whether retroperitoneal fibrosis is also associated with or also driven by the IgG4 related plasma cells, which was confirmed in 2006, and by 2011, IgG4 related disease officially classified as systemic immune disorder. And in 2017, multiple studies confirmed that about 30 to 60% of the patients, they are with the retroperitoneal fibrosis, they are actually IgG4 related. So that remarkably changed our understanding about the fibrotic disease, because previously we used to put the stents and other things to relieve the obstruction. Now we knew that this disease is steroid responsive, and we can use the immune suppression rather than to do the unnecessary surgeries. So about epidemiology, in 2023 studies found, in the studies we found the overall incidence of retroperitoneal fibrosis was between 0.78 to 1.38 per 100,000 people. Male affected more than female, and interestingly, there is a geographically variation in the prevalence. So it's higher in Japan as compared to other countries. So I don't know why this slide is like that. Okay, fine. So the frequency of retroperitoneal fibrosis in IgG4 related diseases. This table summarizes the data from multiple studies, especially in the patient of autoimmune pancreatitis. The frequency of IgG4 related retroperitoneal fibrosis was between 3 to 15%, and overall frequency of retroperitoneal fibrosis in IgG4 related disease was 9.9%. Fine. So etiology, ये इस तरह क्यों आ रहा है सारा? एक्चुअली प्रेजेंटेशन इस तरह तो नहीं थी. अच्छा, ठीक है. So as I already said that 30 to 60% of the cases are IgG4 related in case of idiopathic retroperitoneal fibrosis. The secondary causes can be drugs, malignant diseases like lymphomas, and it can be caused by the radiotherapy and surgery, etc. So a little bit about the pathogenesis. The trigger can be infection, can be environmental factors, or molecular mimicries will affect on a genetically susceptible individual like HLA-DR-B1 or CTLA-4 mutation individuals. It will stimulate the abnormal immune system, which will activate the B cells and IgG4 class switching, which will produce the plasma cells. And it will also cause the stimulation to T helper cells and T regulatory cells, which will further cause the cytokine activation and causing the inflammation. And later, T regulatory cells will produce the collagen and cause the fibrosis. And like that, it will cause the obstruction of the ureters or neighboring organs. Now, it's very important to understand the subtypes of IgG4 related diseases, because the management will differ between two. So there's a proliferative subtype and there's a fibrotic subtype. So fibrotic subtype will have dense lymphoplasmacytic infiltrate, there will be more inflammation, and it is responsive to steroids. However, in comparison to that, fibrotic subtype, it's less responsive, lacks plasma cells, and poor response to steroids. So now have a look on this slide. On the left top corner, you can see the lymphoplasmacytic infiltrate. And here it is the immunohistochemistry slide. And you can see this brown IgG4 stained plasma cells, and IgG4 to IgG ratio should be more than 40 to say it's strongly say that it is a IgG4 related disease. And this is the fibrotic area. It's a classical woven mat type fibrosis, which is known as storiform fibrosis. Storiform came from the term storia, which means woven mat or cartwheel type fibrosis. If you look at this slide, you can see that there is obliterative phlebitis. Veins are obstructed by the plasma cells. You will see this in more chronic phase, like a fibrotic phase. So the clinical presentation is often asymptomatic. You will find diagnose these type of cases when you do the CT scan or MRI scans. However, presentation can be like a flank pain, lower abdominal pain, or back pain. Fever is very uncommon. So if you are suspecting IgG4 related retroperitoneal fibrosis and patient presents with the fever, then it's very, very important to rule out malignancies or lymphomas or infections. So how we'll diagnose? So we'll do the serum IgG4 levels. It will be raised in proliferative subtype. However, it can be normal it's normally normal in the fibrotic subtype. But it's important to note that IgG4 related, serum IgG4 level can be raised in lymphomas and like Castleman disease and also in autoimmune pancreatitis. So we need to do a CT scan or MRI scan to diagnose it. In MRI scan or CT scan, you'll see that a mass formation will be encasing the aorta or iliac vessels or ureters. So it's a typical location. So if you find the typical location of the mass, then you can somehow treat the patient without doing a biopsy. Even though the histopathology or biopsy is a gold standard, but sometimes radiologists are understandably reluctant to do the biopsies because of the location of the mass. So that means that if the location is typical like this, you can see this mass enclosing the aorta, and you can see the mass is a typical location of IgG4 related retroperitoneal fibrosis. However, I will be very worried about this type of mass. It's irregular margins and location is not very typical, so I would definitely do the biopsy first to differentiate it from the malignancies or infection. And it's also important that we should take a proper chunk of biopsy. You will take the biopsy from the peritumoral region. It can be similar to like IgG4 related disease, and then we can wrongly treat the patient. So this is a differential diagnosis we have already discussed, and especially in Pakistan, we need to always rule out tuberculosis. So the first line management will be corticosteroids, 40 milligram methylprednisolone, which we will taper down gradually, and we will expect the response within 4 weeks. However, if somebody got the stent put in, I will remove the stent like in 2 to 3 months' time on the safe side. And there are steroid-sparing medicine will be mycophenolate, Moftel, azathioprine, and methotrexate. For relapse or even for the fibrotic disease, the rituximab has a very good results. A study was performed in the patient with the fibrotic subtype, 19 patients treated with the rituximab and no steroids. All 19 had symptomatic improvement. 40% of the patients with ureteral stents had successful stent removal. We have surgical options like put the stents in a severe cases, and where it's difficult to put the stent in, then we can do the nephrostomies. And interestingly, with the treatment, you will see that we will be able to remove the stents and nephrostomy, reverse back the nephrostomies. Now the second case. This case is about 30 years old female with dysuria and GI upset and flank pain. On examination, there is mild abdominal tenderness, anemia, elevated inflammatory markers, high creatinine, low complements, and urine analysis show proteinuria and hematuria, and patient is known to have lupus nephritis. Ultrasound scan done, which showed hydronephrosis and thickened bladder walls. So a CT scan done, what do you see in the CT scan, anybody? So you can see this reduced bladder capacity and thickness of the bladder wall, this one. And this CT will show you the hydronephrosis, and you can see that this intestine with the thickened intestinal wall. So what's the next step of management? What do you think? What should we do? Do we treat the patient with immune suppressions, or do we do something else? We'll investigate, yes. So even though we have already done the MSU and ruled out some infection, but in countries like Pakistan, we'll definitely do urine cultures for Mycobacterium tuberculosis, which was negative, gene expert, negative. So we have ruled out, because if we'll treat the patient with the tuberculosis, obviously it will just worse the things. And then cystoscopy and biopsy, and you will find the chronic inflammatory infiltrate in subepithelium. Oh. So this is the case of obstructive uropathy secondary to the lupus cystitis. So lupus cystitis is a rare but serious manifestation of SLE. It's immune complex mediated bladder inflammation leading to fibrosis and uterine obstruction. So you'll see these type of cases, especially in patients who got like a severe uncontrolled SLE, and people will present, and interestingly, lupus nephritis coexist sometime with the lupus enteritis. Pathophysiology is not clearly understood, but the studies showed the deposition of immune complexes, immunoglobulins, complements, and it will basically mediate the vasculitis on the bladder wall, cause the arteriolar damage. And it has been noticed that there is an increase of IL-8 and chemokines, and also anti-intermediate filament antibodies on the bladder wall also seen. And interestingly, with the treatment, the level of these antibodies gone down, though there is no clear relationship with that. However, that's what the studies has noticed, and the further research is required. So these are the risk factors, and you can see that patient with the lupus nephritis and enteritis, you see in clearly in the active disease and uncontrolled disease like raised dsDNA, low complement, high SLEDAI count score. So it's very important to control the disease early. Diagnosis on the basis of, obviously, do the blood like complements, see the disease activity, and urine analysis to rule out infection, abdominopelvic CT scan to differentiate from the other causes of obstructive uropathies, and then cystoscopy and biopsy. Oh, sorry. So this is data from multiple studies that how they treated. So mainstay treatment remained the high-dose corticosteroid, and depending upon the complexity of the cases, combined with the mycophenolate and cyclophosphamide. And the symptoms range from abdominal pain to vomiting, diarrhea, and dysuria, especially because the enteritis coexist with this lupus cystitis most of the time. And if not treated properly, then patient can get intestinal pseudoobstruction, hydronephrosis, mesenteric vasculitis. So it's very, very important to recognize such cases in the early stage. So this bit of the treatment I've already told you. If in case of refractory cases, we can add belimumab, tacrolimus, and in some cases, intravesical dimethyl sulfoxide has also been used. So now we have already discussed about the lupus cystitis. Because of the lack of time, I'll just quickly go through other rare causes like GPA, sarcoidosis, and Sjogren's syndrome. So as we all know that GPA is a medium to small vessel vasculitis. It will cause the vasculitis in the bladder wall, can cause the stricture, and obviously later cause the obstruction. And if we do the histology, we'll find the granulomatous vasculitis there, and the treatment will be hydrosteroids, rituximab, or cyclophosphamide induction as we treat the GPA in normal cases. Sarcoidosis is a non-causating granuloma causing strictures. So it affects in different ways. It can cause the stricture, it can cause the granuloma formation in the retroperitoneum, and will behave similar to IgG4 related diseases, but how we differentiate it from the IgG4 related diseases, that it will cause a non-causating granuloma, or there will be no storiform fibrosis or IgG4 positive plasma cell. The treatment will be corticosteroid, immune suppressant like methotrexate, and azathioprine. And another way how sarcoidosis can affect is it will cause a hypercalcemia and stone formation. In that way, it will cause the obstruction. Sjogren's syndrome, as we all know that it is a disease of the exocrine gland, but however, it will have the extraglandular presentation. It can cause the renal tubular acidosis and then cause the nephrocalcinosis, and in that way, it can cause the obstruction. And also cause the vasculitis, inflammation in the bladder wall, and like that it can cause obstruction. So in the biopsy, you will find the chronic lymphocytic infiltrates. Again, treatment will be steroids, immunosuppressant, and if some time requires, stuntings. Okay. So the take-home message is that yes, common causes are always common, but there are always uncommon causes of the disease. When we don't find the answer, we need to dig more. And diseases like IgG4 related diseases, previously we was quite afraid of fibrosis. We don't need to be afraid anymore, because we know that there is a treatment. Even in the fibrotic stage, we can treat the patient and make the patient better. Thank you. Any questions? Any questions?
Thank you, Dr. Mason, for your valuable insight. It was indeed a great talk, and we got to learn the differentials of obstructive uropathy in autoimmune diseases and importance of differentiating them with infections. Your contribution is highly valued. Moving on to our next talk, I'd like to introduce Professor Sumaira Raja. She's a renowned expert in the field of rheumatology and holds an impressive array of qualifications, including a graduate certificate in pediatric rheumatology from Australia. She's currently serving as the head of Department of Rheumatology at National Hospital and as a consultant rheumatologist at Arthritis Care Center. Additionally, she also holds a faculty position at Fatma Jinnah Medical University. Professor Sumaira is a highly respected figure in the rheumatology community, and her contributions to the field of rheumatology are truly invaluable. Dr. Sumaira Farman Raja will delve into the transformative world of targeted therapy for juvenile idiopathic arthritis, examining the most recent breakthroughs and their implications for clinical practice. It is a complex and multifaceted condition that affects thousands of children worldwide, affecting their quality of life. Please welcome Dr. Sumaira Farman.
इससे स्लाइड्स चेंज होंगी और उससे वो होगा आपका स्लाइड शो give me 1 second please. Okay. So इससे आप कह रहे हो आगे होगा ठीक है और this is ठीक है thank you so much Bismillahirrahmanirrahim Assalamu alaikum ji I just want to thank the organizers and of course Professor Tafazzul, Professor Flack and all of you, and especially at this point, I'm going to thank Professor Nighat for coming this early for my presentation. I wish he hadn't, because now I'm going to get very nervous. But thank you so much for this invitation. So these are my affiliations, and these are my disclosures. Off-label disclosure is that I had house guests that just left yesterday, and so this presentation has been put together in 24 hours. And I'm a grandmother, so my little babies were continuously coming in and deleting whatever I was doing. So these are my references. And I am going to, this was a very large area to cover, so I have just restricted to the biologics primarily that are available in Pakistan, and their indications in two particular GI subtypes, which are the enthesitis-related arthritis and psoriatic arthritis, with two case narratives on psoriatic arthritis. I will briefly touch upon the other subtypes as well. So we all know what GI is. It is an arthritis of unknown etiology, and it is important to remember that all other known conditions must be excluded, begins before 16 years of age and persists for at least 6 weeks. And the pattern over 6 months determines the subtype. Now, pre-biologic, we know that persistent disease existed in almost 70% of children with polyarticular and also what is juvenile SPA, and long-term disability was seen in 30 to 40%, with severe disability in 10%. As you can see, this is an encouraging graph where it shows that post-biologic, there has been remission of medication for almost 47%. So this is the glass full, but we see that there's still a lot of children that are still on medications and unable to taper their steroids. Therefore, despite these advances, we can see that remission rates are still only approximately 35% or at best 60%. Patients with uncontrolled disease face progressive joint destruction, gait dysfunction, and altered growth. And particularly children with psoriatic arthritis or enthesitis-related arthritis have a relatively poorer prognosis with significant disease-related morbidity. These patients are more likely to experience disease flares and have an overall lower health-related quality of life in comparison to other subtypes. Studies have shown that secukinumab, an IL-17 inhibitor, improves enthesitis, dactylitis, and the swollen and tender joints in adult populations with spondyloarthropathy. And recently this has been approved for children and adolescents with ERA and juvenile psoriatic arthritis. And it seems to have decreased the time to flare and sustained improvement of signs and symptoms in treated patients. And it is a great addition to the juvenile arthritis population. We know that GI is divided into several subtypes. I won't go over these. I just want to say that we are going to talk about ERA and psoriatic in greater detail. I know that many of these are associated with HLA-B27. Some of the psoriatic ANA positives can have uveitis as well, and there is significant disability due to enthesitis and dactylitis that is difficult to treat. So this is a 5-year-old girl who had a symptomatic left cataract, which picked up due to difficulty reading in preschool. You know that these children are usually asymptomatic because they actually adjust to their disability very quickly. There's a 1-year history of a single swollen joint, which was initially attributed to trauma, and the x-rays and blood tests, including rheumatoid factor, was negative, and ANA done at this point when she was sent for the cataract came out positive, and she was referred to us in rheumatology. And a detailed examination revealed another swollen joint and rash on extensor surface legs, and dermatology confirmed skin psoriasis. So this is psoriatic arthritis with dactylitis and chronic anterior uveitis. Just a reminder that uveitis is the most common and potentially the most devastating extra-articular manifestation seen in JIA. And JIA-related uveitis has a worse outcome compared to other etiologies of idiopathic uveitis. And the treatment protocol briefly for JI-related uveitis, in addition to topical corticosteroids and cycloplegics, is to start with methotrexate, and then there is graduated first indication adalimumab, then moving on to infliximab or golimumab, which is not available, sorry. So I'll say adalimumab and infliximab in Pakistan. Tocilizumab, as well as rescue treatment like abatacept, rituximab, which is available, and inhibitors of JAK kinase, which are again now available in Pakistan. The other conventional DMRs like azathioprine, mycophenolate, and cyclosporin have been used. It is important to know that uveitis can continue despite resolution of arthritis, and therefore you must keep a close watch on it. This is a 14-year-old child whose history goes back with reluctance to get out of bed in the morning, and the parents felt the child doesn't want to go to school till he developed a slight limp, and it was shown that he has a swollen left Achilles tendon. His counts were normal, ESR was normal, and he used to play football, so they thought maybe it's just trauma. Later on, the same child developed a swollen toe, and again, because initial attribution to trauma, but then when blood tests, it didn't resolve, and blood tests were done, he came back unfortunately with a raised uric acid. And you know that we see a lot of prescriptions where anyone, whether it's a child or a premenopausal woman or anyone with even a slightly raised uric acid, it is considered gout, and so this child was treated as gout. After 6 months, there was increased swelling of the right knee with a recent limp, and when he was examined, he had a right knee which was swollen with a slightly high ESR, and uric acid was raised, and so he continued to be treated as gout. Later on, the swelling had resolved, but at 23 years, he came back with a low back pain, bilateral gluteal and upper thigh pain, which had been there for 3 years, and this was again initially attributed to trauma. And on examination of his labs, he had a high ESR and a normocytic anemia. So the first question, this was a unilateral sacroiliitis, was that could this be tuberculosis? And a bone scan revealed increased uptake, and so anti-tuberculous therapy was initiated. However, it is important to remember that the other thing that should not be missed is that this could be ERA. And this is a very good article which shows how unilateral sacroiliitis in tuberculous infection can be differentiated from sacroiliitis that is seen in psoriatic arthritis. So more than ERA, in which you can see more bilateral, actually psoriatic arthritis can have just unilateral sacroiliitis. However, he was initially diagnosed as having ERA, and his HLA-B27 came back positive. So he had been admitted for these investigations because his company covered him for inpatient tests. And at that point, a very conscientious house officer on the third day of admission took off his socks during examination. So please remember to expose everything in your patients. And when he did, he saw dry scaly soles, and he also had a long-standing history of scalp, which was, they thought was dandruff. And this actually was juvenile onset psoriatic arthritis. I'm sharing this, and I've shared this a few years ago actually, when there was a launch of secukinumab. This is a patient who came in, started with this story in the center, and then he landed up finally, because he was lost to follow-up, he went on her key medications, all of the things that happen to our patients. And when he came, he actually was locked in. There was absolutely no movement at hip, knee, shoulder, hands. He had florid psoriatic plaque psoriasis, and his brother had been nursing him for the last year plus, literally carrying him to the bathroom and back. And I remember this was the time we were in Fatma Memorial, and secukinumab had just been introduced, and through Arthritis Care Foundation, we actually managed to arrange the injections for him. And I also remember how happy and excited we were. And we had arranged it. It was supposed to be brought in the next morning. When I came to the hospital, unfortunately, we lost him. And it is very important not to lose sight of the fact that it's not the numbers that we treat. These are real living human beings, and particularly with children, I think for all of us we have a soft spot. This child, this man now, was very fond of poetry actually, and his brother told me this, and he allowed me to use this, that he used to say at the end, he was fond of fairs. And as you know, this Aaj Bazaar mein pa bajola chalo, phir hum hi qatl ho, aaye yaro chalo. And the most important message, I think, for all of us is life and death is in Allah's hands, but the quality of life definitely is something that we as physicians have to be very cognizant of. I'm happy to share this child who actually came 2 days ago, who was in a similar state when he came to us. His mamu is a doctor in services, and we tried a lot of things. He was resistant to conventional treatment. He was resistant to anti-TNFs, to tofacitinib. He got some toxicity with that. He had to have a hip replacement on the right side, and he literally was brought in a wheelchair several times. And then we managed to arrange secukinumab for him, and he walked in and he's looking so good. So I'm not saying that the thing is you keep trying and you keep finding ways to resolve situations, and yes, you can prevent disability and save a life. If you persist and stay, how should I put it, stay aware of the fact that if you don't understand what's going on or you're not getting results from the therapy, you have to try other avenues as well. So we know that the prognosis of autoimmune diseases has the best outcome with early treatment, and adverse prognostic factors are delayed diagnosis, delayed referral, which leads to late disease control and continued disease activity. And these two very important trials that were done in the 2010-11, which was the treat GI and the acute GI, showed that how early intervention with addition of a biologic, in this case anti-TNF, etanercept on one side and infliximab on the other, showed that there was earlier resolution of symptoms and earlier clinically inactive disease. And so the concept of treat to target came out in GI as well. This is a very busy slide, but I thought that since the topic was biologics in GI, just to briefly tell you that generally when we treat to target, we say that if the DMRs, and you try switching DMRs, over 3 months, if you do not achieve clinically inactive disease, you need to switch to a biologic, whether it's anti-TNF or in case of polyarticular course, you may try tocilizumab or tofacitinib. And if after 16 weeks of therapy there is still active arthritis, you switch to any one of these agents, you just switch it. While for polyarticular seropositive, rituximab is a choice and it is available in Pakistan. And however, for juvenile psoriatic arthritis and ERA, a very great addition has been secukinumab and tofacitinib. So these are the GRAPPA psoriatic treatment recommendations, different domains. I just want to concentrate on 2 things, which are basically the enthesitis, of course, the axial disease enthesitis and dactylitis, as well as the skin. And many of you would have noticed how difficult it is to control sometimes skin psoriasis and dactylitis and enthesitis as well. And as you can see that over this course, all these domains are, responsive to other than peripheral arthritis, where you can do conventional DMRs. The rest, you need to add a biologic with it, anti-TNF or PDE. Which is So treatment management in GI, as I said, must have a treat to target strategy, and the targets are to control the signs and symptoms, to prevent, and when we say signs and symptoms, if you do a swollen and tender joint count, in polyarticular GI, you need to have 3 or less joints, 5 or less joints, and if it is psoriatic or ERA, then 3 or less joints. You want to avoid comorbids and drug toxicity and optimize function, growth and development, and the quality of life of these children. So the biological DMRs So there are certain biological DMRs that have been approved in the US and EU. But I must say that many of us have been using them off-label in adult population as well, particularly in children, because you do not have that many trials. So many times the adult data is actually extrapolated onto the pediatric population. But unless they are approved, we generally like to keep it safe for children 6 years and above. However, now the good news is that we have etanercept, we have adalimumab, we have secukinumab, and we have tofacitinib. And tofacitinib and secukinumab both have been approved for younger age group in the EU 2+ and above, and in the US 4+ and 2+ and above. Otherwise, etanercept, adalimumab, when you look at the FDA approval indications, the children have to be slightly older. However, we are using them and it is good safety data. So when you look at registries or you look at case series, these agents have been used for children 2 years and above with good safety results. This is just an update on a 2024 article, and I just wanted to show you that if you have, for all GI types, of course, subcutaneous tocilizumab is preferred, and we have it. But for uveitis, if it is refractory, adalimumab is the first drug of choice anytime after 2 years of age, even when you fail one conventional DMR. For poly-GI or extended oligo, tofacitinib in patients from 2 years of age. And for psoriatic, secukinumab is the preferred choice before anything else from 6 years of age on once it has failed TNF inhibitors, or at least 2 of them. So in summary, we have 3 biologics, which are two TNF inhibitors and JAK inhibitor for the treatment of ERA or juvenile psoriatic arthritis. Etanercept, as I said, in the approved indications has to be aged more than 12 years. Adalimumab for patients aged more than 6 years. And tofacitinib is available for patients aged more than 2 years. And I'll come down to secukinumab. It is the one biologic treatment that it is indicated for both ERA and juvenile psoriatic arthritis in patients which are younger, age 2 years or more in the United States. And we have used these in 1 or 2 patients with very good results. So when we talk of treat-to-target approach, again, the window for chances of inducing remission is greatest within early treatment, within months of disease onset. And it has been shown that delay in seeing a rheumatologist has a hazard ratio of 1.8 for not achieving drug-free remission, plus a 1.3 times higher chance of joint destruction. So the risk factors, as I said, delay diagnosis and delay access to appropriate therapies, inadequate specialist services, and especially children living in countries with worse socioeconomic status like Pakistan. This survey showed that we do not have enough pediatric rheumatologists who are trained, and definitely not globally. And in Pakistan, as you can see, most of us, actually all of us at the moment, are primarily adult rheumatologists who have trained or done some training in pediatric rheumatology. Even in countries like the first world, like Australia and New Zealand, this bar is the blue bar are those that are conventionally trained pediatric rheumatologists, and you see the orange bar is those who are either pediatricians or adult rheumatologists who are doing pediatric rheumatology. So even they have this problem. In India, who has actually very large population of pediatric rheumatologists, have a similar situation. So I think in Pakistan we have a lot more to go, but we are still doing not so badly. And just to show that, because of the CPSP recognition of FCPS rheumatology in Pakistan, and then more and more adult rheumatologists trying to clinically train or get access to training in pediatric rheumatology, we now have pediatric rheumatology experience in adult rheumatologists in faraway places, even as far off as in Peshawar and in Quetta and in southern Sindh and southern Punjab as well. And this is our rheumatology family, and most of these are fellows who have trained with us. I don't know, many of you are sitting here, so it is great to see this family growing every year. I just want to shout out to my pediatric rheumatology special interest group in APLAR, who have really, I think we have tried to expand training facilities which are out of the box for APLAR region. And I am so proud that 2 of my SIG members are here, Dr. Tahira and Dr. Takdees. And there is a remote learning webinar series which is every 4 months, and this last one actually had Tahira presenting, and it's a great resource. So I really would like all of you to, and it's free, would like all of you to try and attend these. Arthritis Care Foundation, I think one thing I am proudest to be a part of with Professor Nighat Mir. We sort of started this initiative, and then Emma, then everyone else has carried it forward, and we try to give subsidized care or free care and treatment to children with rheumatic diseases, regardless of their ability to pay or access treatment. I just want to again acknowledge my mentors in pediatric rheumatology, mostly and primarily Professor Nighat Mir, who is sitting here, who made it possible for me to have the wonderful opportunities that were provided. These are our kids who actually, the one on the left was on, I think, tocilizumab. He had systemic GI, and this was a polyarticular GI girl who later turned out to...
For today, and I'm also grateful for the invitation to speak at the forum. I think there is brief delay as far as my presentation is being uploaded on the system. So bear with me for a minute. तो आपको चेंज करना पड़ेगा।
आपकी फाइल में कोई वीडियो तो नहीं है ना?
नहीं
बस ठीक है, आप फिलहाल करें फिर
ठीक है। I feel sorry about the little delay because of technical problem. Before we start, I would like to mention that I have no conflicts of interest or relevant disclosure to mention over here. I have used certain slides from the original talk of the ACR 2024 guidelines for the systemic lupus erythematosus. And here are my references for today's talk. The outline of my talk includes a brief background followed by an overview of the ACR 2024 guidelines for the lupus nephritis. And at the end, we will review the application of new knowledge in the clinical setting. A little bit about background. Ladies and gentlemen, as you know that the SLE is a heterogeneous autoimmune disease with variable course and clinical prognosis. The signs and symptoms can be subtle or robust that affects a single organ system or several and change over time, making it a difficult disease to diagnose. This clinical heterogeneity likely stems from the complex immune dysregulation that results in the SLE disease pathogenesis. SLE may be more prevalent among most ethnic groups in the low and middle income countries, but these countries are still underrepresented in the epidemiological data on SLE. The prevalence and incidence of SLE varied from 3.2 to 159 per 100,000 and 0.3 to 8.7 per 100,000 persons respectively. A paradigm shift has been observed in the treatment of lupus nephritis. More recently, there are new developments in the field of lupus nephritis, and that has led to an impetus for the development of new guidelines for lupus nephritis. A second biologic agent, anifrolumab, has been approved for the treatment of SLE, while the field of lupus nephritis has witnessed major breakthroughs in the form of belimumab and voclosporin, a novel calcineurin inhibitor. And this has led to an inspiration discussion about the paradigm shift in the treatment of lupus nephritis, moving from traditional induction maintenance regimen to the early use of combination therapies. At the American College of Rheumatology, 2024 Congress, Annual Meeting Congress, the ACR released a new summary for the screening, treatment, and management of lupus nephritis. And this consists of 28 graded recommendations, 7 are strong, 21 are conditional, and 13 are upgraded consensus good practice statements. The guiding principles of these lupus nephritis guidelines are to preserve the kidney function and minimize kidney morbidity and mortality from chronic kidney disease and treatment, and to ensure collaboration care with the nephrologist, and to utilize shared decision-making, including patients' values and preferences. It also aims to reduce healthcare disparities and consider pediatric and geriatric population. I would like to explain a couple of points here, and that is that when you see these recommendations, they will either be strong or conditional, and the strength of the recommendation depends upon the quality of the evidence, uncertainty about the balance of benefits and harms, and the uncertainty and differences in patient values. So for a strong recommendation for population, most patients in this situation would want to pursue a recommended course of action, on only a small proportion will not. For clinicians, most individuals should receive the recommended course of action. For a conditional recommendation, for patients, the majority of the individuals in this situation would want to suggest a course of action, but many of them would not due to a number of different reasons. For clinicians, we need to be prepared to help our people making decisions for their clinical situations that are relevant to their preferences and values. Let's review the ACR guidelines, new guidelines. For patients with SLE who do not have lupus nephritis, screening of proteinuria every 6 to 12 months is recommended at the time of clinical flare. For those suspected with lupus nephritis, the ACR recommends performing a kidney biopsy promptly and treating promptly with glucocorticoids while awaiting for the biopsy results and the histopathological results. Patients with SLE who have proteinuria greater than 0.5 grams, they should have a kidney biopsy or when they have an impaired kidney function. In patients with non-lupus nephritis, a kidney biopsy is recommended when you suspect a flare after initial assessment or lack of response or worsening at 6 months of therapy. All patients should receive hydroxychloroquine and RAS inhibitors, and the ACR also recommends to adjust lupus medicine dosages in patients with decreased GFR. I mentioned the institution of glucocorticoid therapy, and here is the recommendation of the new guidelines: glucocorticoid therapy in patients with lupus nephritis for classes 3, 4, and 5. A pulse IV glucocorticoid followed by oral prednisolone less than 0.5 milligram per kilogram with a max of 40 milligrams per day, with taper to a target dose of less than 5 milligrams per day by 6 months. This is in concordance with the thinking of the rheumatology community at large, because we know the worsening functions, organ functions, and the risk of infection with the usages of high-dose glucocorticoids in our patients. And a recent meta-analysis also supported the use of pulse glucocorticoids followed by oral dose 40 milligrams or less, and that showed maximizing functions and with minimizing toxicities. And importantly, the patient participation strongly emphasizes the preference for minimizing glucocorticoids during the process of developing these guidelines. Of course, the individualized tapering regimen in clinical practice is going to happen based on both renal and extrarenal disease activities. This is an overview for the lupus nephritis treatment for the classes 3, 4, with and without 5, and for pure class 5. And I'm going to focus on first the treatment for classes 3, 4 with or without class 5. The new guidelines recommend the use of triple therapy, and that includes the glucocorticoids with the addition of 2 immunosuppressive therapies, including mycophenolate mofetil and either the belimumab or the calcineurin inhibitors. The ACR recommends mycophenolate over cyclophosphamide due to reasons of safety. The mycophenolate can be combined with belimumab for significant extrarenal manifestations, and the calcineurin inhibitors can be combined with mycophenolate in patients with heavy proteinuria. The preferred cyclophosphamide regimen, when it has to be used, is the Euro-lupus nephritis trial dose, which is the lower dose for greater safety, and it can be combined with belimumab, although there is very little data to support, and this can be used an alternate regimen of the initial triple therapy. However, the ACR does not recommend the use of calcineurin inhibitors with cyclophosphamide because there are no randomized controlled trials in this area. Why do we prefer triple therapy over dual therapy and with escalation for those who do not respond? So here is there are 2 points to answer this question. One is the best randomized controlled trials up to till to date showed that the improved outcome with initial triple versus initial dual therapy, and that strongly guided panel discussion along with patient panel input and clinician experience. And the other reason is shown in this graph where you can see that the nephron loss precedes the patient's lifetime situation, even in those patients who do not have SLE, and every episode of SLE or every period of time with active lupus nephritis can changes this course rapidly and for the worst, and eventually there is loss of nephrons, which we cannot afford to wait for and implement most efficacious disease. Rapid control is recommended to reduce the inflammation using most effective regimens for the treatment of lupus nephritis so that the kidney function can be maintained. You can see that, you can ask that what is the evidence behind this triple therapy. There are 2 landmark trials. One is the Bliss-Allen trial, and that showed the benefit with the use of belimumab. And here you can see the primary endpoint with primary efficacy, renal response at week 104, 43% of patients who received belimumab, they have shown a benefit as compared to the placebo group, where it was only 32% improvement. The other landmark trial was the Aurora 1 for the use of voclosporin. Here the patients have shown improvement or benefit with the addition of voclosporin to the mycophenolate and glucocorticoid therapy. The primary endpoint was complete renal remission at week 52. Patients who received voclosporin showed up to 41% of patients showed benefit in the voclosporin arm as compared to the placebo. Now I would like to move on the treatment for class 5 lupus nephritis. Although the data supporting this recommendation is very limited, but still the ACR recommends the use of triple therapy, and that includes glucocorticoid, mycophenolate, and with CNI. The CNI is used because of its stabilizing effect on the podocyte cytoskeleton. What should be the duration of triple therapy? The ACR recommends that the duration of triple therapy should be at least 3 to 5 years, and this is required because the rapid control of the disease activity, to gain rapid control of the activities and continued therapy until sustained and inactive disease is achieved. Because repeat biopsy studies have shown immunological activity persisting for several years, and withdrawal of immunosuppressive therapy before 3 to 5 years will actually would lead to flare of the disease, and that is required to remain and can predispose the patient to lupus nephritis. For non-response and refractory lupus nephritis, there is very little data that can guide us, but the ACR conditionally recommends either change to triple therapy or escalate to triple therapy in case if we were using double therapy initially. For refractory disease, the new guidelines recommend to consider adherence and other diagnosed dialysis, and conditionally recommend proceed to transplant without requiring complete serological clinical remission, provided no other organ system involvement. In patients with lupus nephritis at risk for end-stage renal disease, the ACR conditionally recommends preemptive transplant, and in patients with lupus nephritis on dialysis and kidney transplant, the ACR strongly recommends the regular follow-up with rheumatologist and nephrologist. Now, let's switch gear and move on applying to the ACR guidelines to class 3, 4, and plus 5 lupus nephritis. We will take a case and then we will move forward. This is a case of 29 years old woman with a 3-year history of SLE who presented with inflammatory arthritis, alopecia, positive anti-double stranded DNA, and he presents to you in clinic with worsening joint pains, stiffness, and fatigue. The medications include hydroxychloroquine 200 milligrams per day and low dose of steroid. On examination, she is hypertensive, normal heart rate and lung, and have inflammatory arthritis of the various joints. Laboratory parameters are notable for various cytopenias, elevated ESR, reduced GFR, anti-double stranded DNA is elevated, C3 is low, and the urine DR showed 3 to 10 RBCs. Spot UPCR is 1 gram. What is the most appropriate next step in the evaluation and management of this patient? Here I presented a case of a patient with SLE who comes to your clinic with signs and symptoms and laboratory parameters that are concerning about the new onset of lupus nephritis. So the first step is to arrange a prompt kidney biopsy for the diagnosis and classification, because we know that lupus nephritis has multiple mimickers. The kidney biopsy is required to ensure a right diagnosis before we commit our patient to years-long immunosuppressive therapy. And at the same time, we will actually treat these patients promptly with glucocorticoids so that the inflammation in the kidneys, which is happening in the kidneys, can be taken care and the kidney function can be preserved. And here you can see the relevant key statements of the ACR recommendations for screening kidney biopsy and good practice statements. And we have already gone through these conditional recommendations and good practice statements. So the kidney biopsy shows a class 5 lupus nephritis, and you can see in the image that there is hypercellularity on light microscopy. A crescent is seen on the second slide. There is an IgG granular deposition in the glomerular capillary wall on immunofluorescence, and there is subendothelial deposition is seen on the electron microscopy. So after discussing with her the diagnosis of new class 4 lupus nephritis, you begin to discuss the various therapeutic options. Your patient tells you that she is worried about her kidney disease and is interested in conceiving in future. She is frustrated with her ongoing inflammatory arthritis, which is impacting her ability to work. She says that the intravenous infusion would be difficult for her due to her work-related schedules. So what do you recommend as a therapeutic management plan for your patient? Here is the summary slide from the new guidelines, and we are on the left side of this. Our patient have a class 4 lupus nephritis. We are going to start her on hydroxychloroquine and RAS inhibitors, and we are going to recommend her glucocorticoids along with mycophenolate and plus belimumab, which is a triple therapy option. And why we are recommending this in this patient? Because our patient have active inflammatory arthritis, which are the extrarenal manifestations of the SLE, and belimumab have demonstrated efficacy in the treatment of extrarenal manifestations as well. And this is how we make a shared decisions, and the shared decision depends not only on the patient preferences, but also on the clinical clues in the real case. So you may ask that what is the evidence behind these recommendations? As I mentioned earlier, this is a pivotal Bliss-Allen trial for lupus nephritis. 448 patients were recruited with active class 3, 4, or 5 lupus nephritis. The UPCR was more than 1 gram, and the eGFR were more than 30 ml per minute at screening. All these patients received a high-dose glucocorticoids with 0.5 to 1 milligram per day, and less than 60 milligrams, and then taper to less than 10 milligrams by week 24. These patients were given either cyclophosphamide or mycophenolate 2 months prior to randomization for belimumab or to the placebo arm, and then the primary efficacy endpoint was evaluated at week 104. Here are the top-line results of the Bliss-Allen belimumab trial, and the light blue is the belimumab, and you can see that the 43% of patients achieved primary efficacy endpoint with proteinuria threshold of less than or equal to 0.7 gram. On the right side of this slide, you can see the complete renal response in 30% of patients as compared to the 20 in the placebo arm, with a proteinuria threshold of less than 0.5 or 0.5 gram. These are the data from the subgroup analysis of the clinical trials, and based on the baseline protein levels greater than 3 and less than 3. And you can see over here the patients who were receiving belimumab, they have shown more benefit. The patients who actually recruited with levels of proteinuria less than 3, they showed the high probability of benefit in the belimumab arm as compared to the placebo. Let's take a second case. This is a case of 31 years old woman with 2-year history of SLE, manifested as inflammatory arthritis, alopecia, positive anti-double-stranded DNA. She presents to the clinic with nocturia and frothy urine. The medicine includes hydroxychloroquine 200 milligrams and low-dose prednisolone. The exam showed that she is hypertensive, normal heart and lungs, and there is +1 bilateral pedal edema. The lab showed 3.7 of WBCs, hemoglobin a bit low, ESR is raised, and anti-double-stranded DNA is positive, C3 is low, and the urine showed 3 to 10 RBCs, and spot urinary creatinine ratio is 4 gram. The kidney biopsy showed class 4 plus 3 lupus nephritis. She tells you that she has very worried about the kidney and interested in future pregnancy. She says that the intravenous infusion would not be an option for her due to his traveling schedule. What would you recommend as a therapeutic management plan for this patient? Now I'm moving on to, I will go back to our recommendation slide, and you can see here that we are going back to our summary slide here, and we are going to recommend immunosuppressive therapy, but in this case we are going to recommend triple therapy with CNI. And why is that? One of the deriving feature in this case is the UPCR of 4 gram, and this is crucial. We know that from multiple lines of data, earlier we can reduce proteinuria, better would be the long-term kidney outcome, and all these features are thinking about the CNI. What is the evidence behind this recommendation? The Aurora 1 trial with voclosporin for lupus nephritis. This trial recommended 357 participants with active class 3, 4, and R5 lupus nephritis. UPCR was 1.5 gram, or more than 2 gram, and the eGFR was more than 45 ml per minute. These patients received lower dosages of glucocorticoids like 500 milligrams of prednisolone times 2, followed by prednisolone dose of 20 to 25 milligrams with a taper to 2.5 milligrams by a week. Here you can see the study design. The participants were randomized to voclosporin or placebo on the background of mycophenolate mofetil. The mycophenolate mofetil dose was 2 gram and is different from the Bliss-Allen trial, and the complete renal the primary endpoint was week 54. Here are the top-line results of Aurora 1 voclosporin lupus nephritis trial. The primary endpoint at week 55, you can see the superiority of the voclosporin over controls. I would like to show you the time to UPCR with voclosporin in blue and the controls in red. There is a rapid differentiation early on where you can see the reduction in the proteinuria in the voclosporin arm. And this is because of the non-immunological effects of the CNI on the cytoskeleton of the podocyte, and also because of decreased apoptosis. Now we'll move on to applying the ACR guidelines to the treatment of class 5 lupus nephritis. Let's take another case. This is a case of 40-year-old woman who is diagnosed to have SLE 7 years ago, manifested as arthritis, leukopenia, rash, and positive ANA. No medical history of hypertension or coronary artery disease, no evidence of kidney involvement to date. She presents to you for biannual appointment of and complaining of periorbital puffiness and swollen ankles. The medication include hydroxychloroquine and the low-dose prednisolone. The exam showed normal blood pressure, normal heart rate, plus 2 pedal edema. There is mild leukopenia, but the ESR is 56, and double standard DNA is negative. C3 and C4 are normal. The bland active sediment in urine plus 3 proteinuria, and the UPCR is 3.5 gram. Here I would like to submit the ACR new guidelines for lupus nephritis, and that recommends performing a kidney biopsy in patients who have proteinuria less than 0.5 gram and are impaired kidney function. In addition, I would like to remind you about the good practice statement that says the prompt use of glucocorticoids at the time of diagnosis so that we can suppress the inflammation and can preserve kidney function. Here is the kidney biopsy results, and you can see the thickening of the glomerular membrane on light microscopy. On silver stain, there are holes and spikes of the glomerular capillary wall and that are consistent with membranous lupus nephritis. There are deposits of immune complex on immunofluorescence, and there is subepithelial deposits on electron microscopy. After discussing with her the diagnosis of class 5 lupus nephritis, you describe the first-line therapeutic option. What do you recommend as a therapeutic management plan for this patient? Let's again focus on the guidelines recommendations. For class 5 lupus nephritis, we have looked at two cutoffs of proteinuria. One of them is greater than 3 gram and the other is less or equal to 3 gram. So in patients with active, newly diagnosed pure class 5 lupus nephritis, the ACR recommends patients with low levels of proteinuria, a triple therapy of glucocorticoids, mycophenolate mofetil, and CNI. The ACR also recommends treatment of patients with low levels of proteinuria with glucocorticoids and immunosuppressant because these patients may progress to high grade of proteinuria over time. Here you can see the goal of treatment for all classes of lupus nephritis is to achieve a complete renal response. And complete renal response within 6 to 12 months and reduction in proteinuria less than 0.5 gram is another goal with the stabilization or improvement in the kidney function. As the guideline said, the duration of therapy would remain 3 to 5 years after achievement of complete renal response. What is the evidence behind these guidelines? Let's walk through this decision tree. The diagnosis of pure class 5 lupus nephritis is made on kidney biopsy, and the decision tree splits whether the proteinuria is a gram or less than a gram. For our patient, proteinuria was 3.5 gram. Therefore, we go to the right side of the decision tree where the ACR guidelines recommends the use of hydroxychloroquine, RAS inhibitors, and the triple glucocorticoid therapy with mycophenolate mofetil and CNI. And these results are based on the post-hoc analysis from the clinical trials that supports the use of voclosporin with mycophenolate mofetil and low-dose corticosteroids. They can reduce the proteinuria early on in class 5 lupus nephritis. A formal evaluation should be done at 6 to 12 months. And if the patient achieves partial or complete renal response, we will go to the left side of this decision tree. We will taper off and stop glucocorticoids if we do not achieve complete remission. We need to assess adherence therapy if the complete renal response is not achieved, and we can possibly switch to an alternate therapy or can use a non-conventional therapy like anti-CD20. The next follow-up should be planned at the 6 to 12 months. And at the next follow-up, in case of partial renal response, we will continue with treatment until we achieve complete renal response. After complete renal response is achieved, we will reduce the glucocorticoids to 5 milligrams by 6 months and continue maintenance therapy for 3 to 5 years. On the other hand, if we are not able to achieve a complete response, we need to assess adherence, consider repeat biopsy to rule out other diagnoses and advanced chronicity. We may consider anti-CD20 therapy or combination with mycophenolate, belimumab, and CNI, or this patient can be referred to an investigational treatment. Let's review the evidence behind these recommendations. I will walk you now through some of the evidence that support these guidelines. There are data from the integrated analysis of phase 2 trials of Aurora LV and Aurora for voclosporin. The area that is squared in shows that the patients with pure class 5 lupus nephritis, the odd ratio for achieving a complete renal response is 1.5. Of course, you note that the confidence interval crosses the white line and this is because of the fact that the number of patients in this integrated analysis were low. Belimumab efficacy evidence. These are the data from BLISS lupus trial looking at patients with pure class 5. These patients have odd ratio of less than 1 for complete renal response when treated with belimumab. Therefore, this is not a good option for our patient with class 5 lupus nephritis. These are the data from pooled analysis of the voclosporin trials that show in patients with class 5 lupus nephritis, patient treated with voclosporin had a high probability of achieving 50% reduction in the UPCR at 1 year compared to the control arm, and at the time of the UPCR to less than 0.5 gram was 176 days in the treatment arm compared to the 295 days in the placebo arm. These are the eGFR data that shows while there was a slight decline in the mean corrected eGFR for patients treated with voclosporin, the mean eGFR remained in the normal range with a slight change from the baseline of -1 at 1 year mark. Back to the case. This patient was started on a regimen of pulse glucocorticoids followed by prednisolone 20 milligrams per day, mycophenolate, voclosporin, and losartan. She continued with hydroxychloroquine. After 6 months, she achieved a partial renal response with UPCR of 1.5, eGFR of 80, and double stranded DNA negative. Normal complement, prednisolone is down to 5 milligrams, losartan is continued, and the mycophenolate level is 4. While the level is therapeutic, you ask about medication adherence. And she admits that she has difficulty with the number of pills and asks about alternate options. She has not experienced any toxicity from the mycophenolate. What do you recommend as a therapeutic management plan for at this stage? Patients with membranous lupus nephritis takes longer to achieve a complete renal response, and we would not expect complete renal response at 6 months into this treatment. So please do not switch to an alternate regimen. Consider tapering glucocorticoid to 0, continue with mycophenolate mofetil with CNI and losartan, and consider adding SGLT2 inhibitors. These agents have not been evaluated in the ACR guidelines, but recent observational studies supports their use in patients with persistent proteinuria. With that, I would like to end and thank you very much for your attention and time. I will be happy to take questions at the end.
Thank you so much, sir, for your thought-provoking presentation on this challenging topic. Now let us proceed toward the end of session panel discussion. We have 5 minutes for this session. If there are any questions from the audience for our distinguished panelists, then we will be taking the questions now.
First of all, I would like to thank Dr. Maisam Afzal, Professor Sumaira Farman Ali Raja, and Dr. Muhammad Mahmood Riaz for their so informative talks and for updating us with the new knowledge that is now disseminating across the globe. My first question is from Dr. Maisam Afzal, who presented a case of SLE it was a case of complicated SLE, if I remember correctly on the slide. And I was wondering that instead of all the other drugs which are probably not available in Pakistan or are not cost-bearing for the patient, maybe we will be considering cyclophosphamide for that patient. And as we all know, cyclophosphamide itself causes cystitis and hemorrhagic cystitis. So I was wondering how would we clinically differentiate between a cystitis due to lupus or cystitis due to cyclophosphamide?
Okay.
Dr. Mason.
Okay.
So what was the question, sir? Obviously, it depends upon that if we have already used the cyclophosphamide in the past and the cystitis secondary to that, we, I mean, if there will be the exposure of the cyclophosphamide before, then we can say it's because of that. However, the lupus cystitis will happen if in case of very severe disease. And as I said, that the lupus cystitis presents in a severe disease with other like a lupus enteritis and coexist with the lupus enteritis. So a patient with a severe disease will present like that. I mean, with a dysuria, abdominal pain, and nausea, vomiting, and really, there should be an exposure ahead of cyclophosphamide, and with a very high dose of cyclophosphamide, you will expect the hemorrhagic cystitis. So it's, I mean, what I can say is that the cystitis, because of the cyclophosphamide, there should be, the patient should be on the treatment on that. Biopsy, obviously biopsy will, when we'll do the biopsy, biopsy will prove there will be the infiltrates, chronic inflammatory infiltrates will differentiate it from the acute hemorrhagic cystitis.
Thank you so much, sir. Moving towards the next question.
Thank you very much. I'm Dr. Ali Rukh. I have two questions with the Dr. Sumaira Farman Raja, madam. One question is that we are given the patient very late, polyarticular JIA or JI, and they have been on steroids for a very prolonged period of time, and they usually develop osteoporosis, and they present to us with multiple fractures. Kindly guide us for the treatment of osteoporosis in juvenile age. And second question, should I ask later on?
So, if a child has been on corticosteroids and there have been no fractures and only you have a low Z-score on DEXA, then generally it is not recommended to start bisphosphonate. You will just give calcium, vitamin D and optimize. But if there has been fracture and low impact fracture especially, in that case, then various bisphosphonates have been used. You need to make sure, one, calcium is adequate, vitamin D particularly is in the adequate stage and it's very adequate range, which is difficult because we don't know the normal ranges for our population, but probably something about around 60 or 70 would be a good range to have the vitamin D. And then you have bisphosphonates. Alendronate has been used. Pamidronate used to be very good. We have a lot of experience of pamidronate with osteogenesis imperfecta and fractures, but now it's not available in Pakistan. But if you get that, because you have a lot of experience, but alendronate has been used in children with osteoporosis.
And what about zoledronic acid?
You can use zoledronic acid. The only thing is that because it is limited usually for osteoporosis, you know that we generally, zoledronate used to be given annually, but experts feel that the effect lasts for 18 months. So since the total zoledronate at one time should not be more than 3 injections, you can probably give 3 every 18 months. But then what will you do next? So it's probably, unless the child is intolerant to oral, I would prefer to go with alendronate and pamidronate rather than zoledronate, just because we have more experience and data with it in children with, like osteogenesis imperfecta. Of course, zoledronate has a safety profile with malignancy, and it has been used in children with, oncology issues, so it can be used.
Thank you very much, madam. Second question is with Dr. Arshad. Sir. Mehmood, sir. Sir, Mehmood, sorry. Sir, we treat the patient of lupus nephritis, as you have guided us that we should start the treatment with triple therapy. Here in Pakistan, we don't have belimumab. Can we replace it with rituximab? One question. Second one is patient, in spite of having remission in lupus nephritis, patient do have complaints of arthritis again and again. When we taper down the steroids and NSAIDs, patient again develop arthritis. It does not respond even to tacrolimus, which is available in Pakistan. Again, voclosporin is also not available. Give us the tailor-made or how we can alter the treatment here in Pakistan.
So I would like to respond to this question by saying that there are no clear-cut scientific evidence to support these, to take such decisions, but the ACR also acknowledged the fact that the treatment decisions will vary from region to region, and depending upon the availability of a set of drugs, the access to the clinical specialist care, and the expertise of which are available in the region. So we don't have this disease, as you said, that can we use rituximab instead of belimumab. As you know that there are no data to support that, randomized controlled trials, but just an anecdotal evidence, we use rituximab in inflammatory arthritis like rheumatoid arthritis, and if you see your patient SLE who is presenting with inflammatory arthritis and it's difficult to control that disease with the help of other immunosuppressants like mycophenolate or tacrolimus, personally I feel that that patient would get benefit by the use of rituximab as far as the extrarenal manifestations are concerned. But on the other hand, if the patient has a lupus nephritis, there are no clinical trials that support the use of rituximab as an upfront therapy because we have other options available. And even if we are not able to use triple therapy, we should use dual therapy, which we have been using for quite a long period of time. And I think it's not, we are not far away for having new drugs soon because, you know, although we don't have voclosporin, but we have tacrolimus.
Sorry,
okay, sir. The continuation of the same question. Can we combine mycophenolate mofetil with methotrexate or sulfasalazine?
Again, I would say that there is no data to support that. But you know, as we are moving forward, we have seen that couple of years, if you look back and see that we were not really supporting heavy immunosuppression in a combination form about 10 years before, if we look back to our clinical practice. But you know, with the advancing treatments, now we are actually recommending more and more combination therapies. So this is, but you know, you keep in mind that when you increase the amount of immunosuppression, that would lead to adverse effects as well. So when you treat your patient, you need to keep a balance of the treatment benefits as well as the potential adverse effects that are attached to that treatment. So you have to individualize, but you know, as such, there is no recommendation or the scientific evidence behind this recommendation to combine these two drugs, particularly the mycophenolate with the methotrexate.
Okay, thank you so much for this enlightening discussion. Now I would like to
Can I just add?
sorry. One more question.
नहीं क्वेश्चन quickly मैं सिर्फ ये बता रही हूँ कि in real life हम लोग बहुत कुछ करते हैं और हमें पता है कि हम we have to work out of the box. So many of us, I think, have used rituximab, and particularly there are reports where they have used rituximab with the first and fourth dose of cyclophosphamide in patients with lupus nephritis who are resistant to therapy, who cannot afford mycophenolate, who are not adherent to or intolerant to mycophenolate. So there are situations where in Pakistan, at least in our clinical practice, I know that we have tried to combine the two. And same goes for combination of methotrexate and mycophenolate. As Dr. Mahmood Riaz is absolutely correct, these are not approved indications and there is no data and certainly not randomized control. But in real life and real world clinical practice, if you cannot control it, as long as you monitor closely and watch out for toxicities, if whatever tolerated mycophenolate everything is good, but arthritis is not settling, it can sometimes respond to a low dose of methotrexate. But you have to be very careful to educate the patient, and of course the onus is on you, because you have to explain to them that, look, we are doing it because we are sitting in Pakistan, or we can't do this, and you have to be careful to monitor your counts and all the other risks of infection and all. Yeah.
Bismillah ar-Rahman ar-Rahim. I am Dr. Fayyaz Ahmad Ranja, having retired as Director General Health, everybody knows. Excellent presentations of this morning, but I am very glad that Professor Raja and Hafiz Saab have mentioned one thing, which was prevention. This musculoskeletal disorders and this problem of rheumatology is likely to become #1 incidence of disease in next decade. The total number of rheumatologists now for whole of this country is not more than 200. And in next few years, this problem is going to become the biggest problem of the nation. So I think while focusing on this research and the academics, the most important thing for this nation, for the poor nation, will be to focus on community rheumatology, just like other organizations like cardiology. Now they are focusing on preventive cardiology. It will not be possible for any government to tackle the problems, this musculoskeletal disorder, after a few years. Therefore, I request the top notches in rheumatology, the Professor Tafazal Haq and Madam Mir and Madam Raja, that we should work on an institute of rheumatology where preventive rheumatology is also given due importance to save this nation from the future problems. Thank you.
Thank you so much.
Thank you, Dr. Ranja, for your comments. It is well taken. But I would like to say here that most of the drugs that we use in rheumatology in serious cases and complicated cases, they cannot be given in the hands of primary care physician or the community physicians. So for that, the patient has to be referred to a center where these specialized care are available and people are apt to the knowledge that how to use those modalities of treatment. So yes, your idea is very good, but yes, to a certain extent we can extend this possibility of community rheumatology to go ahead, but not to all the extent. Thank you.
Thank you, everyone. This concludes our first scientific session, and now we'll be heading towards the inaugural session. I would like to invite esteemed Dr. Tafazal Haq, a visionary leader and pioneer rheumatologist, to join us on stage as a chief organizer and patron-in-chief. As a founder and former head of Department of Rheumatology and Immunology at Shaikh Zayed, Professor Dr. Tafazal Haq has been instrumental in shaping the field of rheumatology in Pakistan. His dedication and commitment towards learning and training has a profound impact on the next generation of rheumatologists, enabling them to provide high-quality care to patients across the country. Next, I would like to request our guests of honors to please take their seats on the stage. I'd like to request Professor Dr. Mahmood Ayaz, the Vice Chancellor at King Edward Medical University, Lahore, to please take his seat on the stage. So he's the Vice Chancellor at King Edward Medical College, Lahore. Next, I would like to invite Professor Dr. Sardar Fakhr Imam, the Head of Department of Medicine and Allied at Rahbar Medical and Dental College, to please take his seat on the stage. I'd like to request Dr. Abdul Majid Chaudhary, who is a renowned surgeon, educationist, and administrator, to please join us on stage. Professor Dr. Nigat Mir, consultant rheumatologist and one of the most renowned names. Professor Dr. Aisha Hamayon. Professor Dr. Mona Aziz, the Head of Department, Hematology Department of Shaikh Zayed. And Dean of Shaikh Zayed Medical College. I'll also like to invite Dr. Tariq Mahmood Mia on stage. Dr. Neelam Akram, can you please join us on stage? Dr. Sumaira Farman Raja, can you please join us on stage? I'd like to call on stage Dr. Aftab for the recitation of the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم آمن الرسول بما أنزل إليه من ربه والمؤمنون كل آمن بالله وملائكته وكتبه ورسله لا نفرق بين أحد من رسله وقالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين रसूल ईमान लाए उस चीज़ पर जो उसकी तरफ अल्लाह की जानिब से उतरे और मोमिन भी ईमान लाए। ये सब अल्लाह और उसके फ़रिश्तों और उसकी किताबों और उसके रसूलों पर ईमान लाए। उसके रसूलों में से किसी में भी हम तफरीक नहीं करते। उन्होंने कह दिया कि हमने सुना और इताअत की, हम तेरी बख्शिश तलब करते हैं ए हमारे रब। और हमें तेरी ही तरफ लौटना है। अल्लाह ताला किसी जान को उसकी ताकत से ज़्यादा तकलीफ़ नहीं देता। जो नेकी वो करे वो उसके लिए, और जो बुराई वो करे वो उस पर है। ए हमारे रब, अगर हम भूल गए हों या ख़ता की हो तो हमें ना पकड़ना। ए हमारे रब, हम पर वो बोझ ना डाल जो हमसे पहले लोगों पर डाला था। ए हमारे रब, हम पर वो बोझ ना डाल जिसकी हमें ताकत ना हो, और हमसे दरगुज़र फरमा और हमें बख्श दे और हम पर रहम कर। तू ही हमारा मालिक है, हमें काफिरों की कौम पर गलबा अता फरमा। जज़ाकुमुल्लाह।
Jazakallah, Dr. Aftab. I'd like to call on stage Dr. Fayaz Ahmed Ranja, consultant physician and community rheumatologist on stage. Please join us on stage. Now, I would like to request all our distinguished guests to rise and join us in honoring our national anthem. Dr. Fazlul Haq on the dais to share his thoughts about this conference. Please, sir.
Assalamu alaikum, ladies and gentlemen. Thank you so much, first of all, for coming so early in the morning on a weekend to attend this conference. The idea behind starting this Rheumacon was not just to hold a conference in Lahore, but to refresh ourselves of the updates that this field is evolving so rapidly all over the world, and research is going on so rapidly all over the world that we need to be abreast with the latest of the knowledge. So the idea is to update a person like me who is old in his learning and get new knowledge from people who are the younger lots. So it is also a good opportunity for those as inspiring rheumatologists who are taking their postgraduate examinations as a refresher course. So I'm sure that it also helps there. Professor Mahmood Riaz is sitting here. He has been a backbone in supporting rheumatology at College of Physician and Surgeon of Pakistan, and it would not be an exaggeration if I say that he has always done a great deal in making new centers, recognizing them, making new supervisor, making new teaching opportunities available to those people who want to become rheumatologists. Here I want to just make a little correction that there are probably not 200, it is about 100 trained rheumatologists across the country. It's a huge numbers as far as the time given to us is concerned. But of course, the need for more rheumatologists is always there, and I'm sure more and more new residents will come over. One more thing I would like to request to College of Physician Surgeon through Professor Mahmood Riaz is that the rheumatology may kindly be made a minor rotation in non-compulsory or compulsory, as you may like, in the FCPS medicine training program, so that more residents are exposed to this specialty and they can take on, if they want to, it as a future. Thank you so much, everyone.
Next, I would like to invite Professor Dr. Mahmood Ayaz to come on stage and say a few words.
Bismillah ar-Rahman ar-Rahim. Am I audible? Thank you very much. Assalamu alaikum. मेरी ज़रा पुरानी आदत है कि जब मैं सलाम करता हूँ तो जवाब मैं ज़रा ज़ोरदार तलब करता हूँ हमेशा, क्योंकि सलाम का जवाब तो सलामती ही हो सकता है, तो मैं फिर आपको सलाम करूँ. अस्सलाम वालेकुम. No, that's better. It's a great occasion being here this morning. बहुत खुशी होती है ये इस तरह की कॉन्फ्रेंस को मुनक्कद होते हुए देखते हुए. लेकिन इसमें जो सबसे खूबसूरत बात है, अभी मैं सोच रहा था जब मैं सारी बातें आपकी सुन रहा था, तो हम हमेशा एक लफ्ज़ इडियम उर्दू में यूज़ करते हैं कि गोश्त पोश्त का बना हुआ इंसान. फ़ारसी में गोश्त तो गोश्त ही आपको पता ही है, मीट, ठीक है. तो व्हाट इज़ पोश्त? नो, वो पुश्त है, दैट्स बैक. सो गोश्त पोश्त का बना हुआ इंसान का मतलब है कि अ पर्सन मेड ऑफ मीट, स्किन एंड बोन्स. सो दैट इज़ व्हाट इज़ इंसान. तो अगर आप कैलकुलेट करें एनाटॉमिकली तो 55 to 60% ऑफ योर बॉडी वेट इज़ बिकॉज ऑफ योर मसल्स, एंड 10 to 15% ऑफ योर बॉडी वेट इज़ बिकॉज ऑफ बोन्स, and 2% is about skin. So putting collectively together all these three components, this makes roughly 65 to 70% of your body is made up of bone, skins and muscles. So am I talking about rheumatology? ऐसा ही है ना. तो जब इंसान की जो बुनियादी साख्त है वो गोश्त और पोश्त पे बनी हुई है, और अगर ये गोश्त या पोश्त अच्छे तरीके से काम न करे, तो यू कैन अंडरस्टैंड द अमाउंट ऑफ chronic pain which you have, the disability which you have in your body, and the lack of the ability to work appropriately as a good member of the society. A severe physical disability exists. तो किसी ने ऐसे नहीं कहा कि मुझे भी तो आराम की ज़रूरत है, मैं भी तो गोश्त पोश्त का बना हुआ इंसान हूँ. इसका मतलब है कि हमारी बोन्स, हमारी हड्डियाँ, हमारा गोश्त, हमारी स्किन हमारे लिए मैटर करती है, एंड दैट इज़ व्हाट रूमेटोलॉजी डील्स विद. आर वी क्लियर? मेरे ख्याल में मैं बात अपनी क्लियर कर नहीं सका. दी ग्रेट रूमेटोलॉजिस्ट सिटिंग हियर. तो मैडम क्या हम इसी स्पेशलिटी की बात कर रहे हैं? जी, तो हम इसी स्पेशलिटी की बात कर रहे हैं. सो दैट इज़ द अमाउंट ऑफ इम्पॉर्टेंस दिस कैरीज for the whole society. I'm not going to talk about the doctors as specialists, as surgeons and rheumatologists and physicians. मैं उसके बारे में बात नहीं कर रहा. अब मैं बात कर रहा हूँ कि about the amount of this section of medicine has an impact on the society. Look at the society where the muscles and the bones and the skin is not working properly. Look at the amount of loss of the physical hours in terms of the man working hours or woman working hours in the society. So I think that this is going to become one of the biggest specialty. It was an ignored specialty. And मैं समझता हूँ कि College of Physician Surgeons ने बहुत अच्छा स्टेप उठाया कि अब हमारे पास starting from a very meager number of the supervisors and the trainees, it has grown into a large specialty with training centers all over Pakistan. और वन ऑफ द मोस्ट फियर्सली कंटेस्टेड स्पेशलिटी, जब मैं रेजिडेंट्स के हम ट्रेनिंग प्रोग्राम्स की बात करते हैं, जो लोग अप्लाई कर रहे होते हैं जिनको हमें रिफ्यूज़ करना पड़ता है, तो आई मस्ट टेल यू दैट अपार्ट फ्रॉम गायनिकोलॉजी एंड डर्मेटोलॉजी, दिस इज़ वन ऑफ द मोस्ट फियर्सेस्ट कंटेस्टेड स्पेशलिटी. अब सर्जरी और मेडिसिन इतने इंपॉर्टेंट शायद नहीं रहे, इतने ज़्यादा वहाँ पे कंपटीशन नहीं है. यहाँ पे बहुत सवियर कंपटीशन है. फॉर वन एग्जिस्टिंग ट्रेनिंग पोस्ट देयर आर 27 अवेलेबल कैंडिडेट्स. सो दैट इज़ द मैग्नीट्यूड जो हमारे पास एप्लीकेशंस आती हैं. सो वंस अगेन आई थैंक तफजुल एंड हिज टीम फॉर एक्चुअली होल्डिंग दिस वेरी वेरी इंपॉर्टेंट मीटिंग, और इसकी तरफ तवज्जो दिलाना, इस तरफ हुकूमत के लिए इसके बारे में रहनुमाई देना, और इसका माशरे में इसका इम्पैक्ट इस सेक्शन ऑफ मेडिसिन का वो बताना बहुत ज़रूरी है. और मैं आपको फिर एक दफ़ा बहुत मुबारकबाद देता हूँ इस कॉन्फ्रेंस को इनाग्रेट करने का. और लाहौर में जितने भी बड़े बड़े रूमेटोलॉजिस्ट हैं, सबको मैं यहाँ पे बैठा हुआ देख रहा हूँ, और आप सबकी आमद का यहाँ पे बहुत शुक्रिया, और बहुत मेहरबानी मुझे बुलाने की. बहुत शुक्रिया.
I'd like to invite Dr. Ahmed Saeed on stage. I should have done that earlier. Accept my apologies. He is the president of Pakistan Society of Rheumatology, and it's a great honor for us to have him here. So I'd like to call on stage Dr. Sardar Fakhr Imam to share a few words of wisdom.
In the name of Allah, the Beneficent, the Merciful. And I'll stick to a few words as desired by you. It's a pleasure and an honor for me to be here with you. I've been coming and attending almost every conference that has been held here, and I've seen the level, the matter which is being talked about, the material which is being listened by people, and that's very interesting, because otherwise rheumatology or the medical practice related to this field was limited primarily to paracetamol, brufen, dicloran, and that was just about all. There were people who could not move, and now they are up and about, not just up and about, running around and playing maybe not too aggressive games, but they are living a full life. That's exactly what I'm trying to say. But I think once the subject of prevention has been raised by Ranja Saab, I don't think anyone can really underscore that importance of prevention, because it's difficult. We can't really have a healthy nation if we don't start working on our younger lot during their childhood, teenage, adolescence. Because if you realize, we are not living a healthy lifestyle by any way. And that's going to impact overall on the health status of our people, and including the field of rheumatology. But I think it is great, and we must pay compliments to the department, we must pay compliments to Professor Tafazul, Professor Aflaq, and the team. And I think President of Rheumatology Society, they're all doing great job, and I'm sure they'll continue doing it because they've come up with great dedication. This is the group which has really started to move and has started to pick the specialty up. We now expect that the snowball effect will come soon, and sooner the better. Thank you very much.
Thank you, Dr. Sardar Fakhr. Next, I'd like to call Dr. Abdul Majid Chaudhry on stage.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. Professor Ahmed Saeed and the distinguished guests sitting on the dais, ladies and gentlemen. Thank you very much for inviting me here. Know nothing about rheumatology, but everybody at my age needs a rheumatologist. And I'm so happy that some of my students sitting here, they are rheumatologists, so, including Professor Mir. Because I think as we are gaining on the age in this country, we need more radiologists. I was just told that there are only 120 rheumatologists in this country. And the requirement, I think it's around 2,000 at this stage. And anyway, thank you very much. I think it's a great academic activity which must be continued. And you are doing a wonderful job as a society. Continue with it. And I think we are going to require more and more as the time passes. Thank you very much. God bless you.
Thank you, Dr. Abdul Majid. It's an honor for us to have Professor Dr. Nigat Mir with us. We'll request her to say a few words about the conference.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. First of all, I'm extremely grateful to Professor Tafazul and Professor Iflaq and Rheumatology Unit at Shaikh Zayed Hospital for doing a marvelous job, and you've been doing it for such a long time. So this is a great service to rheumatology, and congratulations, and thank you for having us here. बिल्कुल डॉक्टर अयाज आपने सही कहा है, गोश्त पोस्ट का बिल्कुल सही आपने एक कूजे में दरिया बंद कर दिया. Because now musculoskeletal disability is the leading cause of disability in the world, is one of the leading cause, and another one is depression. And आपको पता है कि जब depression होती है तो MSK disability भी होती है और MSK disability हो तो depression. So दोनों combine करके are the leading cause of a big, huge issue which is the world going to face in the coming years. तो हम लोग उसके लिए बिल्कुल तैयार नहीं हैं, हम बहुत कोशिश कर रहे हैं. तो थैंक यू कॉलेज ऑफ फिजिशियन एंड सर्जन्स पाकिस्तान के आपने में रिकग्नाइज़ किया, और हम कहीं 8 रोमोटोलॉजिस्ट से अब कोई 150 रोमोटोलॉजिस्ट है हमारे पास. वी नीड 2000 मोर, बट वी वोंट गिव अप. इंशाल्लाह विल कंटिन्यू. ये सारी एफर्ट्स इसी तरफ चल रही हैं, एंड दिस इज़ वन ऑफ द एफर्ट्स, एंड इंशाल्लाह ताला विल कंटिन्यू टू वर्क टुगेदर फॉर वन कॉज, एंड दैट इज़ for the betterment of patients with rheumatic diseases. And remember, rheumatology is like 2/3 of your medicine now. It's multisystemic disorder. So this specialty actually should be present in every teaching hospital in Pakistan. And sir, it's my request to you and my humble, I don't know, I think I'm talking to the wrong person, क्योंकि आपके हाथ में होता तो फ़ौरन कर देते कि हमारे जो graduates निकल रहे हैं इस वक्त, जो उनको कोई सीट किसी टीचिंग हॉस्पिटल में नहीं मिल रही एज अ रूमेटोलॉजिस्ट, 2 FCPS करके वो मेडिकल ऑफिसर लगे हैं. सो इस पे ज़रा प्लीज़, आई एम श्योर आप कुछ ना कुछ तो कर सकते होंगे. थैंक यू सो मच.
Thank you, Dr. Nigat. Now, we are honored to have Dr. Mona Aziz, the head of Department of Rheumatology Department, Shaikh Zayed, and Dean of Shaikh Zayed Postgraduate Medical Institute.
Assalamu alaikum. Bismillahirrahmanirrahim. I would like to thank Dr. Professor Tafazal, Professor Iflaq, and all the participants of this esteemed gathering. Rheumatology is an important subject, branch of medicine, but now a definitive separate speciality. No longer a subspecialty, but it is a subspecialty now. I would like to emphasize 2 points. As we know that the disorders are affecting the individuals, causing individual suffering, but also it's the disorders are becoming public health problem. So this increases the importance of this specialty. The preventive aspect, as someone mentioned, is very important. And the preventive departments or sections like physiotherapy, like gyms, like walking or jogging tracks, these are very important. And why prevention is important? Because it will reduce the burden on the specialty, on the therapeutic aspect, on the people who are treating the disorders. Secondly, I want to raise the awareness about the digital gadgets which are increasing the skeletal, joint and bone disorders at an earlier age. In this era of digitalization, the laptops, the mobile phones, increased use of mobile phones, online working, long hours of sitting without going to office and having an activity, these are shifting the burden of rheumatological diseases to a younger age group. And obviously the rheumatologist has to take care of it. In near future, there will be an increasing tendency of cervical spondylosis, backache and muscular and joint problems at a younger age group because of this digitalization. Thank you.
Thank you, Dr. Mona. We have with us Professor Dr. Tariq Mahmood Mia. Please come on stage.
Bismillahirrahmanirrahim. Sir, thank you very much for inviting family physicians. अभी रांझा साहब से बात हो रही थी. Basically, inviting family physician in such conferences is of utmost importance. Reason being that most of the people, they first go to the family physician and then they are referred to if they need. So I think the training of family physician in every specialty is must, not being they will treat the whole patient, but I think the proper and timely referral, this is the important duty of a family physician. And we have started, sir, a course at our FamilyCon, pain management course and different diseases, and we are trying to prevent and reverse the metabolic diseases and got excellent results. हकीम लोग कहते थे कि जिसका पेट ठीक है उसका सारी चीज़ें ठीक हैं, तो हम मजाक उड़ाते थे. इसी तरह कुछ क्वैक्स ने कहा जी कि डायबिटीज़ में पैंक्रियास जो है वो ज़िंदा हो सकता है, तो हम उनका भी मजाक उड़ाते थे. लेकिन आज हमने देखा कि हमने डायबिटीज़, ओबेसिटी और तमाम मेटाबॉलिक डिजीज़ में, इवन ऑटो इम्यून डिजीज़ में रोल ऑफ डाइट इज़ वेरी वेरी इम्पॉर्टेंट. हमने लोगों को लो कार्ब डाइट और इंटरमिटेंट फास्टिंग पे डाला. आप अंदाज़ा करें कि उनकी पेन वो काफ़ी हद तक ख़त्म होगी. और जो बहुत इम्पॉर्टेंट चीज़ है कि जब हम रिफाइंड फूड लेते हैं तो हमारे जो गट माइक्रोबायोटा हैं, जिनकी डाइट जो है वो फाइबर है, तो वो हमारी म्यूसिनस लेयर को खाना शुरू कर देते हैं एंड देयर इज़ लीकी गट सिंड्रोम. और यही भी बेशुमार ऑटोइम्यून डिजीज़ की भी शुरुआत यहाँ पे होती है. तो मेरा ख्याल है कि अगर हमें डिफरेंट स्पेशलिटीज़ को मिल के अगर काम करेंगे, अगर मैं एक पेशेंट को मैं जानता ही नहीं हूँ कि इसे रेफरल की ज़रूरत है और उसको मैं डिले करता हूँ, तो आई थिंक दैट इज़ मतलब है कि वो आपके पास भी जब जाएगा तो वो प्रॉपरली ठीक नहीं कर सकेंगे. तो लिहाजा ये कोलैबोरेशन है, ये बहुत ज़रूरी है बिटवीन डिफरेंट स्पेशलिटीज़. And I am really very thankful that you invited and involved family physician in such conference. Thank you so much.
Thank you, Dr. Tariq Mahmood. I'd like to call Dr. Fayaz Ahmed Ranja to join us on stage to share his experience and insights.
Bismillahirrahmanirrahim. नहमदहू व नुसल्ली व नुसल्लिमु अला रसूलिहिल करीम व नऊज़ु बिल्लाहि मिनश्शैतानिर रजीम बिस्मिल्लाहिर रहमानिर रहीम। प्रोफेसर डॉक्टर तफज़्ज़ल हक साहब और उनकी टीम ने उस तारीकी में शम्मा जलाई हुई है कि जिसमें लोगों को, बहुत कम लोगों को पता है कि र्यूमाटोलॉजी एक अलग स्पेशलाइजेशन है। पलवानों से शुरू करके जोड़ों के, पट्ठों के दर्दों के लोग अरसा दराज से इलाज करते आ रहे थे, तो अब र्यूमाटोलॉजी एक इमर्जिंग फील्ड बन गई है, इमर्जिंग फील्ड। और WHO के आदाद शुमार के मुताबिक इस वक्त में कार्डियोवैस्कुलर डिजीज़ नंबर 1 पे हैं, जबकि अगले प्रोजेक्टेड फिगर्स के मुताबिक मस्कुलोस्केलेटल डिसऑर्डर जो आज 4थे नंबर पे हैं, अगले चंद सालों में 10 साल में ये नंबर 1 पे आ जाएंगे। और आप अंदाज़ा कर सकते हैं कि जो गरीब लोग हैं, अभी ये जो दवाइयाँ निकल रही हैं नई नई, टोफा जक है, ये रिनवोक है और पता नहीं आगे क्या क्या आएंगी, ये गरीब आदमी के रोज़ाना के ख़र्च में जब बजट में शामिल होगी तो उस वक्त पता लगेगा कि कितना बड़ा प्रॉब्लम था। तो मैं सल्यूट पेश करता हूँ प्रोफेसर तफज़्ज़ल हक साहब को और मैडम मीर साहब को, सईद साहब को, मैडम राजा को, प्रोफेसर हारून को, कि इन लोगों ने एक अलग स्पेशलाइजेशन को बाकायदा तरीके से ऐसे मुतारफ़ कराया कि अब ये वर्ल्ड फेम के ख़ुद तो बन गए। मैं आज की इस महफ़िल के हवाले से दरख्वास्त करूँगा इन बड़ों से कि अगले मुस्तकबिल इस कौम के लिए ज़रूरी है कि इस स्पेशलाइजेशन को, जैसे मेयो में अपना फ़ख्र इमाम साहब, मजीद साहब मेरी बात से इत्तफ़ाक़ करेंगे कि जब हम केई में आए थे मेयो में, तो वहाँ पे न्यूरोलॉजी का और यूरोलॉजी का अलग वार्ड नहीं होता था, इसी मेडिकल के वार्ड के अंदर ही 2-3 बेड उनके होते थे। इसी तरह से ये जो हड्डियों जोड़ों के जो महमूद याद साहब कह गए, इनके लिए एक ही होता था कि मैक्सिमम लोग पहले हकीम और पलवानों के पास जाते थे, फिर आर्थोपीडिक वाले आ गए। अब आहिस्ता आहिस्ता ये एक अलग स्पेशलाइजेशन बन गई है। इसके तमाम कवायद ज़वाबित पूरे करते हुए मुस्तकबिल की आने वाली नस्ल के लिए आप कुछ कर जाएं, अल्लाह ताला आपको इसका अजर भी देगा और कौम आपको हमेशा याद रखेगी। और अल्लाह का फजल है कि मुझे जब अल्लाह ने DG हेल्थ पाकिस्तान लगाया, तो मुझे उस वक्त में इस्लामाबाद में हमारे सिर्फ फारूकी साहब थे, जो बहुत बड़ी शख्सियत भी बाद में बन गए, PMDC में भी बन गए। मैंने उनसे कहा कि आप र्यूमाटोलॉजी के बहुत बड़े अफसर हैं, लेकिन आप ही हैं ना, अब आगे क्या होगा? इसको बतौर सब्जेक्ट, बतौर एक प्रोफेशन और बतौर स्पेशलाइजेशन आगे लेके जाए। तो अल्लाह का करम है कि हमने उस दौर में जो कंसीव किया था आइडिया, उसको हम आगे लेकर चल सकते हैं। और इंशाअल्लाह ताला इसमें मुल्क का, कौम का और सबसे बड़ी बात गरीब आवाम का फ़ायदा है कि जो अर्ली डायग्नोसिस, प्रॉम्प्ट ट्रीटमेंट, मियाँ तारक साहब ने भी कहा कि जो लोगों को थोड़ी थोड़ी ट्रेनिंग करनी पड़ेगी, हमें थोड़ी सी कम्युनिटी र्यूमाटोलॉजी में थोड़ी सी उनको डायग्नोज करना और अर्ली डायग्नोसिस में प्रॉपर बंदे की तरफ रेफ़र कर देना। जिस वक्त में डिफॉर्मिटी हो जाए, जिस वक्त में गुर्दा और जिगर कंप्रोमाइज़ हो जाए, उसके बाद वर्ल्ड फेम के ये जो बैठे हुए हैं र्यूमाटोलॉजिस्ट शायद ये भी उतनी मदद ना कर सके, अगर वो पहले वक्त आता तो उसकी कर सकते। लिहाजा आज की इस र्यूमाकॉन के हवाले से मैं दरख्वास्त करूँगा प्रोफेसर तफज़्ज़ल हक साहब से कि ये आज ही इसको प्रायोरिटी नंबर 1 पे ले जाएं कि मुस्तकबिल में क्या होगा और मुस्तकबिल में आने वाली बीमार इमर्जिंग डिजीज़ को रोकने के लिए कुछ ना कुछ स्टेप लेने ज़रूरी हैं। साथ ही इस मौके पर मैंने प्रोफेसर साहब से पूछ लिया, हमारी जो द मोस्ट फेमस, जब से प्रोफेशन में आए हैं तो र्यूमाटोलॉजी में 2 ही नाम सुनते आए हैं, मर्दों में प्रोफेसर तफज़्ज़ल हक साहब का और औरतों में प्रोफेसर मीर साहबा का, निगहत मीर साहबा का। तो अब अल्लाह करे कि और ज़्यादा लोग बढ़ जाएं। अभी तक तो पाकिस्तान में बहुत थोड़े हैं, 125 रजिस्टर्ड हैं, 10-15 और डाल लें जो अभी नए नए FCPS हुए हैं।
150 के करीब रूमेटोलॉजिस्ट हैं, 25 करोड़ की आबादी है। अब इनको बढ़ाना भी है और इनको ट्रेन भी करना है। ये एक प्रोफेसर है पूरा और इसको आप करेंगे इंशाल्लाह, मेरी तवक्को है। अब मैं चूँकि हमारी जो मैडम साहबा हैं उनके वालिद साहब का चंद दिन पहले इंतकाल हुआ है, तो मेरी दरख्वास्त है कि सारे का सारा हाउस एक दफ़ा आओ हम सब मिल के उनके लिए फातिहा खानी भी कर लें और दुआ कर लें। और यही वो चीज़ है जो मरने वालों को बाद में पहुँचती रहती है। अल्लाहुम्मा सल्ली अला सय्यिदिना मौलाना मुहम्मदन नबील उम्मी व आलिहि व बारिक व सल्लिम व सल्ली अलैहि। अल्लाहुम्मा अग़फ़िर लिजमीइल मोमिनीन वल मोमिनात वल मुस्लिमीन वल मुस्लिमात अल-अहयाइ मिनहुम वल अमवात इन्न रब्बना इन्नका रऊफ़ुर रहीम। अल्लाहुम्मा अग़फ़िर लिहय्यिना व मय्यितिना व शाहिदिना व गायबिना व सगीरिना व कबीरिना व ज़करिना व उन्साना। अल्लाहुम्मा मन अहयैतहु मिन्ना फ़अहयिही अलल इस्लाम व मन तवफ़्फ़ैतहु मिन्ना फ़तवफ़्फ़ाहु अलल ईमान। या अल्लाह, हम इस वक्त में सारे तेरे सामने सवाली हैं कि हमारी मैडम साहबा प्रोफेसर निगत मीर के वालिद साहब को जन्नत में आला मकाम अता फरमा। या अल्लाह, कब्र की सारी मंजिलें आसान फरमा, बरज़ख की घाटियाँ आसान फरमा। या अल्लाह, जहाँ कोई कुछ नहीं कर सकता तू वहाँ सब कुछ कर सकता है। ये अल्लाह, मरहूम के हक़ में हमारी ये गवाही कबूल फरमा। या अल्लाह, जितने यहाँ बैठे हैं, किसी की माँ, किसी का बाप, किसी के दोनों, या अल्लाह किसी की बहन, किसी का भाई, या अल्लाह तेरे पास पहुँचे हुए हैं। या अल्लाह, हम उन सब के लिए भी दुआ गो हैं। या अल्लाह, उन सब की भी कब्रों को जन्नत के बागों में से बाग बना। और या अल्लाह, जो हम पीछे रह गए हैं, हमें अपनी अपनी कब्र की तैयारी की तौफीक अता फरमा। सल्लल्लाहु तआला अला हबीबिही मुहम्मदिन व अला आलिही अहले बैतिही व ज़ुर्रियातिही व अस्हाबिही अजमाइन।
Ameen. Thank you, Dr. Fayaz. It was very kind of you to remember the father of respected Dr. Negat Mir. May Allah bless his soul. So next, I'd like to invite Professor Dr. Ahmed Zayed, the head of Department of Central Park Medical College and the president of Pakistan Society of Rheumatology, to take the stage and say a few words. Thank you.
Assalamu alaikum everyone. चमन के माली बना लें मवाफ़िक अपना शार अब भी, चमन में आ सकती है पलट कर चमन से रूठी बहार अब भी। मैं ये देखता हूँ कि जी फ्यूचर लीडरशिप भी मौजूद है, विगर भी है, मोटिवेशन भी है, सब कुछ है। अल्हम्दुलिल्लाह, ये स्पेशलिटी हैज़ कम अ लॉन्ग वे एंड देयर इज़ स्टिल अ लॉन्ग वे टू गो. 1 in every 4 person in the community is suffering from musculoskeletal disorders. This is what the data we generated with the help of a WHO ILR grant just a couple of years back. So there is an unmet need to train more people. Yes, empowering family physicians. This is one passion. Professor Neghat, Professor Sumaira, myself, our colleague, very dear colleague, Dr. Saira, who is not here right now. So we were able to run a course which was a 9-month online mixed course, face-to-face as well, couple of years back. That needs to be replicated. We need to empower our family physicians. This is what our vision is. We need to come up with our referral guidelines for rheumatic diseases. Last year, so we were able to publish the first ever multidisciplinary back pain guidelines. They have already been published. So now the goal is to have a referral guideline for rheumatoid arthritis for this year, and the local treatment guidelines, inshallah. So this year we would be hosting PSR 2025 as well in this city, and from that forum as well, inshallah, we'll be coming up with newer insights, and I hope to see all of you there as well. Thank you, Professor Tafazzul. Thank you, Dr. Aflaq, and the team for giving us an opportunity to be part of this wonderful gathering. Thank you, everyone.
Thank you, Dr. Ahmed Zayed. Now, please say
अस्सलाम वालेकुम। मैं कहने लगी थी कि बस करें, सब थक गए हैं और चाय भी वेट कर रही है। इसके बाद क्या कोई मैं कुछ कह सकती हूँ except thank you very much for inviting and for this all of you being here. I just want to tell you कि उम्र के साथ and ये जो मैं कहने लगी हूँ ये probably above अपने आप को कहाँ रखूँ 40 को अप्लाई करेगी, बाकियों को शायद नहीं करेगी, कि नमाज़ पढ़ते हुए अब मुझे पहले एक ज़माने में नहीं समझ आता था। इकबाल का एक शेर था ना, तेरा दिल तो है सनम आशना, तुझे क्या मिलेगा नमाज में। अब समझ आती है बिकॉज आप नमाज पढ़े होते हो, कभी दिमाग इधर जा रहा होता है, कभी उधर जा रहा होता है, एंड यू डेस्परेट कि आप कनेक्ट करें अल्लाह ताला के साथ। आई थिंक माई फादर वंस लिख के गए थे, इनफैक्ट ही वॉज इन वेल एट दैट टाइम, एक दुआ है अल्लाह बिज़िक्र लाई तत्मइनुल क़ुलूब, अल्लाह के ज़िक्र में इत्मीनान क़ल्ब है। And I was sharing with my trainees also, and something that has worked, I think, for all of us, कि जब आप काम करते हैं, आप पेशेंट्स देखते हैं और दिल से देखते हैं और ये सोच के देखते हैं कि ये भी अल्लाह की रज़ा के लिए कर रहे हैं, तो आपकी ज़िंदगी में देयर इज़ मीनिंग एंड पर्पस। बिकॉज आजकल ज़िंदगी यंगस्टर्स के लिए हमारे से भी ज़्यादा शायद मुश्किल हो गई है, मेडिकल प्रोफेशन में और ज़्यादा मुश्किल हो गई है। कंटिन्यूसली आप ये सुन रहे होते हैं कि क्या गलत हो रहा है, ये नहीं सुन रहे होते क्या सही हो रहा है अपने मुल्क में या अपने प्रोफेशन में। तो यू नो इफ़ यू थिंक लाइक दैट कि आप जब करो और अपनी पूरी नीयत से करो और ये सोच के करो कि ये अल्लाह के लिए कर रहे हैं, तो आपकी ज़िंदगी में भी बरकत आएगी, दिल में भी चैन रहेगा। एंड सो दैट्स ऑल आई वांट टू से, एंड थैंक यू सो मच।
Now I'd like to invite Professor Dr. Tafazle Haq Mahmood to, for the souvenir presentation ceremony. Dr. Flaq will be joining him, and Dr. Mona Aziz as well.
So Tafazul and Madam Mona, please come to the stage to give the guest of honor shields to the guest of honors. Sanai.
So I'd like to call on stage Dr. Sardar Fakhar Imam to receive his souvenir from the respected. To receive the guest of honor shield from Dr. Mona and Dr. Tafazul. Dr. Abdul Majid Chaudhary to receive the guest of honor shield. Respected Dr. Nighat Mir, please join us. Respected Dr. Tariq Mahmood Mia. Respected Dr. Fayaz Ahmed Ranjha. Dr. Sumaira Farman Raja as a guest of honor and guest speaker. We'd like to request Dr. Mahmood Riaz to come on stage to receive his shield. Dr. Maisam Afzal as a guest speaker. Professor Dr. Mona Aziz. Now we'll take a group photo of our guest of honors. Please stand up. Sitting or standing? अब पिक्चर हो जाए उसके बाद स्टेज के लिए नहीं बुलाया मैंने इनको बुलाया था शी वाज़न्ट इवन हियर We'd like to call on stage Professor Mrs. Neelam Akram to receive her shield of guest of honor. ये तो बता Thank you, everyone. Now there will be a tea break of 15 minutes. Speakers, guests of honors, and dignitaries will stay here for the tea. Kindly, everyone move towards the Crystal Hall. We'll be resuming the conference after 15 minutes.
Let us proceed towards the second scientific session of today. Our next speaker will delve into the latest insights on polymyalgia rheumatica, focusing on the 2025 updates and essential practices in diagnosis, treatment, and management. We are privileged to welcome Dr. Muhammad Haroon, who is a preeminent rheumatologist. He holds a PhD in rheumatology, fellowship from prestigious institutions, and has published over 50 peer-reviewed articles. His expertise in clinical and genetic research has established him as a leading authority in this field. Please welcome Dr. Muhammad Haroon as he shares his insights on polymyalgia rheumatica.
Assalamu alaikum, everyone. Shall we wait or shall we start? खाली कुर्सियों से खिताब करना है मैंने. Right. So let's do my duty to talk, whoever is there to listen. So thank you very much, as I said, for having me. So it's a little different today. I'll be talking about is the polymyalgia rheumatica. Right. So let's dwell into a little bit about the basics in terms of the definition, in terms of the little bit about the etiologies and so on before talking details about the management. So we know the polymyalgia rheumatica is an inflammatory rheumatic condition. Generally, of course, the neck, shoulders, and the upper pelvic girdle are usually affected in these. Of course, it's an inflammatory condition. So generally, you tend to see raised inflammatory markers. So talking about the epidemiology, for example, if you look at, of course, it's more than 50 years of age, around the age of 70 to 80. Of course, the incidence is quite a bit. But looking at the figures from the internationally, and I agree with those figures, is that definitely around 100 per 100,000 patients would have one of those features. And naturally, it increases with age. And we know that it's the second most common inflammatory or autoimmune rheumatic condition, second to rheumatoid arthritis. Of course, it goes with GCA a lot of times. For example, in GCA, 50% of the patient would have polymyalgia rheumatica, and other way around 30% of the patient with GCA, with polymyalgia rheumatica, could have concomitant GCA as well. So talking about the etiology, just like any other autoimmune condition, of course, it's very easy to say, it's not well understood. But looking at the familial aggregations, for example, studies, so it's usually is a HLA class 2 driven disease, not HLA class 1. HLA class 1 we tend to see in psoriatic arthritis, for example. HLA class 2 we tend to see more the typical of rheumatoid arthritis, and the same is HLA DR1, B041. That's also very much mimic of what we see, the genetic, for example, the etiopathogenesis in rheumatoid arthritis as well. Naturally, infection and the vaccination have also been attributed towards etiopathogenesis of this condition. For example, in different outbreaks, there was much higher incidence of polymyalgia rheumatica has been reported in a lot of European countries. So talking about, of course, the name, the polymyalgia rheumatica, we know it's not myositis, we know it's not arthritis, then what it is. Of course, it implies that might be some form of myopathy or neuropathy or something. But if you look at the imaging studies or even the histological studies, there's no, the muscles are very much preserved. There is no inflammation as such in the muscle as such, but rather we know there is a periarticular structures which are usually affected in this particular condition. And that has been proven with all the imaging studies that you can talk about, for example, ultrasound, CT, MRI, and very, very commonly we see in the PET scan as well. So let's look into a little bit what happens in this particular condition. For example, again, we learn from the imaging studies, naturally, because there isn't much to find on examination apart from the patient complaining about the symptoms. So the subacromial bursitis has been considered as one of the hallmark, one of the most common, rather, finding in the imaging studies in the patients with the polymyalgia rheumatica, and the same goes with the biceps tendonitis. Talking about the neck and the spinal, for example, the symptoms, where do they originate from? Usually it is the interspinous bursitis in this particular condition, which tends to cause these symptoms of this profound stiffness. Talking about, for example, what happens at the hips, it's the same as the greater trochanter areas, the bursitis around those areas, the ischial processes, for example. There is also inflammation happening. For example, the hamstring tendonitis, for example. So these are the usual imaging studies tell us that what happens as regards the pathology and the reason behind these symptoms. Again, talking about the back pain, for example, the usual what we see in the neck as well is the interspinous bursitis is the cause for these symptoms. So in summary, if we want to know where the symptoms are originating from, it's the biceps tendonitis or subdeltoid bursitis, the biceps tendonitis and cervical interspinous process, and the same as I just mentioned, what happens in the lower pelvic girdle in these patients. But of course, we need to be mindful. Of course, these are elderly patients. The rheumatoid factors, of course, we tend to request. So the rheumatoid factors in the general population and up to 10% of the older population that can also be positive. So rather than we label blindly to as seropositive rheumatoid arthritis, so we need to be a little mindful. Of course, it would be in the lower titers. And one thing that really helps in this scenario is the anti-CCP antibodies, which is very much specific. In PMR, we do not tend to see anti-CCP antibodies. Of course, rheumatoid factors can be positive, but not anti-CCP antibodies. Distal symptoms can be common up to almost 1/2 of the patients, usually as the rest synovitis, low-grade synovitis, and the MCP synovitis can also be there, and that's concomitant to the usual, the proximal symptom that we tend to see. Of course, it's an inflammatory condition, so we tend to see the ESRs and CRPs raised. For example, if you look at the studies for the ESR, so 94% of the patients would have elevated ESRs, and up to 99% of the patients would have high CRP levels. Rather, it's mentioned that in one study, only 1.5% of the patient would have normal inflammatory markers with the polymyalgia rheumatica. And usually, if you look at the guidelines, for example, if you look at the usual recommendation, people do talk about that the normal inflammatory markers, especially CRP, would practically exclude the diagnosis of polymyalgia rheumatica. I think it's a little bit too much to say. I personally think there's a good bit, at least 20% plus minus, would have normal inflammatory markers or just a borderline. For example, you tend to say 6 or 7, for example, of the CRP. With the right symptom, that can be enough to diagnose a patient with the polymyalgia rheumatica. We tend to see subclinical vasculitis in the patient with the polymyalgia rheumatica. For example, if you look at the PET scan, the studies have consistently shown that up to 1/3 of the patient with the polymyalgia rheumatica would have subclinical synovitis, and usually these are the subclavian arteries which tend to let up in the PET scanning. If we look at the ultrasound studies, they talk about around 1/4 of the patient would have subclinical synovitis, but that can be involvement of lot of different areas, just like we tend to see in arthritis, the usual like the carotid, subclavian, and the axillary artery, subclinical inflammation on the ultrasound studies. So talking about how do we diagnose? So it's of course, is the age more than 50, early morning stiffness, profound early morning stiffness. There has to be 2 out of those 3 areas, the neck, shoulder, and the pelvic girdle. So if 2 of those areas are affected, age is there, and of course, there is a profound early morning stiffness is there, and naturally the inflammatory markers are raised, and the prompt response to steroids is a very classic that we tend to see. So let's dwell into how to manage these patients. The goals of treatment is very simple. One is to control symptoms, not the inflammatory markers, not the imagings. The most important thing in polymyalgia rheumatica is how to control the symptoms, and of course to be vigilant about the concomitant vasculitis, and especially worrying is the giant cell arteritis. And naturally, this is an older age group we are talking about, so we need to minimize the risk of the complications of the medication. The steroids has been the cornerstone, even to date now as well, is the gold standard how we treat these patients. And unfortunately, we don't have any class 1 evidence when we talk of how much to use and so on. So it's all, of course, anecdotal evidence of the years and years of experience. That's how we learn that how much steroids we should be using and what the duration would be. Right? So, as I said, the most important thing is how to relieve the symptoms. And to use the minimum amount of steroids for these patients. That has to be the most important understanding in dealing with the patient with the polymyalgia rheumatica. And another thing is do not always chase the inflammatory markers. Make sure that, of course, there are activity scores for polymyalgia rheumatica. We should be focusing those one. We should be focusing on their symptoms. And of course, nationally, we should be following their CRP and ESR, but just the borderline in case if the CRP and ESR are still there, but the patient is asymptomatic, you should not be escalating the treatment based on still raised inflammatory markers, especially if they are just a borderline. Initial dose, the mostly is around 15 milligram. That's how we go by. Right, but again, there is no like sort of the blanket statement, if you like. That all depends on the patient sitting in front of you, looking at their, naturally the age group. If somebody is like 80 or 90 years old, already having diabetes, for example, loads of other complications, but the symptoms are not that severe. Of course, the low dose can be enough. Low dose can be absolutely sufficient. For example, even 10 milligrams can be enough. So again, as I said, it depends on the patient sitting in front of you, looking at the comorbidities, looking at the overall risk and all this, then you can decide 10, 15, or in some patients, of course, with the very high symptomatology, for example, we can easily go up to 20 milligrams. 25 milligrams, of course, we can still use, but if somebody needing more than 25 milligrams of steroids, we should be thinking about some other diagnosis, especially concomitant giant cell arteritis or some other systemic vasculitis in these patients. Looking at this recent systematic review, for example, looking at what should be the initial dose of steroids in treating patients with the polymyalgia rheumatica, there is, as we know, there is so much heterogeneous population used in these observation studies. One was the randomized trial, but there was no conclusion. It was all depends on the patient, as I said, and of course the concomitant other risk factors associated with this, that we should be aiming for what should be the initial dose. Of course, as I mentioned, the response is very, very quick. We tend to see the response. If we are not getting a response within 1 week of starting steroids, doubt the diagnosis, or making sure that if the diagnosis is right, then definitely we need to escalate the dose if the response is not coming within 1 week. Blood test monitoring, of course, the CRP and ESR, of course, is very, very important. Baseline CRP and ESRs are very important, not only for the diagnosis, but also in the follow-up as well, that when the symptoms are improving, of course, the CRP and ESRs are settling or not, and that very, very reassurance when, of course, the patient is sitting in front of you. So steroid tapering, again, there's no consensus. As I keep on repeating myself, is the symptomatology is the most important, the response is important, not this inflammatory markers in these patients. Of course, how to aim for the overall, the aim for the treatment duration is around 1 to 2 years. So thinking about that, we don't have, unfortunately, only 5 milligram tablet available. In Europe, we used to have 1 milligram tablet available. So we used to start was 15 milligram and reduced on 1 milligram a month. So that was like a sort of a standard approach, depending on then afterwards. But again, we don't have any such facility. So what we tend to do generally is that we reduce down 2.5 milligram every month until it goes down to 10. And below 10, again, is around 1 milligram a month that you should be aiming for. But as I said, more than 99% of the patients or thereabouts do not go with the same regime because every patient behaves different depending on, of course, the other comorbids. And well, as I mentioned, usually you aim for 1 to 2 years of treatment plan, but most of the patients would need much longer duration of treatment. And for example, if the 2 studies that I've quoted there, so the one was that the duration of the treatment was up to 37 months, and the other study mentioned that the patient would need 6 years of treatment, especially in the much lower doses. So how to minimize the risk? First of all, we know that this is the aging population. In 2 of the studies that I mentioned here, the 65% of the patient with the polymyalgia rheumatica would have some steroid-related adverse event, and the other study showed there was 43% of the patient had some form of steroid-induced sort of complication. However, in an inception cohort, I have mentioned another one as well, the second one, they're talking about the polymyalgia rheumatica with the steroids, that there was just, the cataract was the only one complication which was different compared to the placebo group. But that's, if you look at this one, for example, that was the conclusion of that particular study. But if you look at the details of that particular study, of course, they were looking at diabetes, hypertension, hyperlipidemia, and the osteoporosis-related fracture. But what you and me really see in these patients are what? Weight gain, right? The weight gain. People talk about all the time, that the face is all like puffy. and of course the other complications related to that. So that's why they did not include in this particular study those complications. And of course, we need to be much more mindful about steroid-induced osteoporosis and all this. So the relapse happens around 50% of the patients with polymyalgia rheumatica. Rather, it's considered that it's more the rule that the relapse would happen than the exception. And usually it happens within the first within a year of the treatment, because of course you're trying to reduce down the steroid dose, so that happens earlier on in the disease rather than the later on. So we tend to see asymptomatic patients with the abnormal testing, as I just earlier on mentioned, that the CRP and ESRs can be borderline raised, but the patient is still asymptomatic. Of course, what I tend to do is I do not follow much the CRP and ESR unless they are broadly, of course, markedly raised and they're not settling. If the CRP and ESR have settled more than 50% and the patient is asymptomatic, I would sit tight and just observe, but of course be mindful of other mimics as well. That can be a problem in some of the patients. So let's talk about the steroid-sparing therapies. So usually it's mentioned that most of the patients, rather you should not be thinking about steroid-sparing therapies in the patient with the polymyalgia rheumatica unless the comorbidities are there, for example, the diabetes, the cardiac risk factors are there, and so on. On those patients, you should be thinking, otherwise you should not. Personally, I do a little different. I tend to, of course, once you have diagnosed a patient with a polymyalgia rheumatica, your thinking really is that this particular patient will be on steroid, on whatever doses of steroids is, and we know the relapses are going to happen, and we know this is an aging patient. So I try, not at the first visit. Of course, there's a first visit, you make a diagnosis, you challenge them with the steroids, you want to see the response of all this, you want to see the settling of the ESR and CRP. Once you have made that sort of observation, and then I try to expose all these patients to some form of steroid-sparing agent so that at least some of the steroids can be reduced to at least a decent level earlier on rather than waiting for 2 years and then thinking about introducing these steroid therapies. And we'll talk about what are those therapies. Of course, NSAID, you know, this is aging, of course, again, the population, they're already on antihypertensive, they're already on ACE inhibitors. You don't want to expose them to a lot of NSAIDs in the longer run. The methotrexate, of course, is one of the best friends. We always try methotrexate for any form of joint pains we talk about, so inflammatory joint pains, of course. So looking at the evidence, for example, in polymyalgia rheumatica with methotrexate has been very mixed. We don't have a good evidence as God does it works. And if you look at the old evidence, so there has been a lot of things, one even randomized controlled trial as well, looking at the methotrexate versus placebo. And there always was the issue was the dose of methotrexate used in these patients, because we know these are aging patients. You are worried about the GFR. You don't want to give them a higher dose of methotrexate because, of course, we are aware of the renal clearance. So in all the studies, the low dose of methotrexate was used and it was not effective. However, we have now very recently this double-blind placebo-controlled trial which has been recently published. What they looked at was very, very brave sort of, this study was conducted 52-week placebo-controlled trial, randomized, recently diagnosed polymyalgia rheumatica. Very early on, we are not talking about a refractory disease. We are talking about a very earlier on, right, the patients, and they were blinded and all this, and the primary outcome was by the age of 52 weeks, so let's see, does it help in terms of having a steroid-free remission or not? So 52 weeks, and the very important thing was they went up to 25 milligram of methotrexate. So all the patients, they went up to 25 milligram of methotrexate and 52 weeks randomized double-blind controlled trial. But unfortunately, if you look at compared to the placebo, 68% versus 67%, they did not achieve steroid-free remission. So methotrexate was an absolute failure, not only from the observation studies, but this randomized double-blind placebo-controlled trial, this was an absolute failure, unfortunately. In infliximab, there's only one randomized controlled trial. Again, it wasn't effective. Leflunomide is a very interesting one. I remember talking to Professor Das from UK a number of years ago. I think it must be 7, 8 years ago. And he was talking about that time about the leflunomide use in polymyalgia rheumatica. And since then, there have been very good evidence talking about the leflunomide in polymyalgia rheumatica. For example, if you look at this particular observational study, retrospective, and also some prospective as well. What they looked at was compared to methotrexate and leflunomide, for example, if you look at the time until steroid discontinuation, so they started both the steroids plus, of course, the leflunomide. The other group was the methotrexate plus the steroid. In the leflunomide group, they were able to stop steroids in 4 to 4.7 months or thereabouts. Compared to methotrexate, for example, if you look at the steroid was stopped after 31 months. Right? So compared to methotrexate, leflunomide really did great in this particular study. Right? Let's talk about now IL-6 inhibition. Of course, we know we have the evidence in last number of years. For example, this prospective open-label phase 2 trial, they looked at 52 weeks, again talking about the same, up to 4 months they kept on using, and the same was in the early PMR, the bottom one, if you look at, that's a very interesting one. What they did was, so the bottom one, efficacy of the first line tocilizumab used in polymyalgia rheumatica in these patients without steroids. So they started on with the tocilizumab without steroids, and up to 3 months, 12 weeks, and there was also another 4 weeks observational of the same patient. What they found out was with the tocilizumab, they were able to achieve remission without steroids in polymyalgia rheumatica. There has been few randomized recent controlled trials. For example, the SPARE trial, if you look at these are the new onset of the polymyalgia rheumatica, not exposed to steroids before. So they randomized into 1:1, 16-week study. And again, in this study also, if you look at the graphs, for example, the steroid-free remission was achieved significantly in the patient with the tocilizumab compared to placebo. And the same was that the primary outcome, the probability of the relapse was much, much less in the patients with the tocilizumab compared to the placebo. If you look at another randomized controlled trial, here they were talking about the more refractory cases, the patients who were still having active polymyalgia rheumatica and they needed more than 10 milligrams of steroids and the polymyalgia rheumatica was still active. In these patients, when IL-6, the tocilizumab was used, there was a significant improvement of the up to 24 weeks. The primary endpoints and all those were achieved in these patients. So randomized controlled trial, these two were significant in favor of tocilizumab. And this is a SAPPHIRE trial where, again, the IL-6 inhibitor was used weekly and there was a 14-week steroid drop compared to the placebo where 52 weeks of steroids were given. Right? On one arm, 14 weeks of steroid taper was given plus IL-6 inhibition, and the second one, the placebo, there was a 52 weeks of the steroid taper. And if we look at the results, for example, there was a significant remission achieved in the patient with the tocilizumab, with the sarilumab, plus, of course, the overall cumulative. If you look at the steroid use, was significantly less in the patient who used IL-6 inhibitor. Based on this particular randomized controlled phase 3 trial, FDA did approve. FDA approved this sarilumab IL-6 inhibition for the patient with, let's move on quicker. So looking at the rituximab, for example, we have only one evidence. If you look at the rituximab in the patient with the polymyalgia rheumatica, in this particular study, 49 patients were given at the start of the polymyalgia rheumatica diagnosis. They were given one treatment dose, 1,000 milligram, and then again 1,000 milligram, and then they were followed, and significantly higher patients achieved remission with the rituximab, but there's only one report, but there was a significant number, 49 patients, this particular study was used. Baricitinib, which is a JAK inhibitor, very recently published data in the polymyalgia rheumatica. Again, the use was in their group was baricitinib was used, JAK inhibition without steroids, compared to the other group where the both were used, and significantly the higher number of patients achieved remission with the JAK inhibitor. And talking about the tofacitinib, of course, because which is easily available, this is the Chinese data. And they very nicely did was, they looked at, first of all, looking at the evidence that what is the gene expression analysis in these patients. So in their patients from the peripheral blood mononuclear cells, so this is the principal component analysis. I won't bore you with all this. So PMRA is active PMR, and then this is the PMR in remission, and this is the healthy control. what they looked at was there was a significant difference in the gene expression analysis when they did on these patients. So the inflammatory genes were much more expressed in the patient with the polymyalgia rheumatica compared to the healthy controls. And the genes were all inflammatory genes, and what they saw was that most of those genes, they were blocked, or most of those cytokines were actually blocked by the JAK inhibition. So this is after tofacitinib. So the red ones are the active ones, and the blue ones which have been suppressed after tofacitinib therapy. So those inflammatory genes which were overexpressed after tofacitinib, of course, they all were reduced down after tofacitinib therapy. This is a very recent one published in the Annals of Rheumatic Diseases. They also looked at the 14 patients about the whole different cytokine analysis. Not only they achieved a good response, but looking at the cytokine analysis as well, they were significantly reduced after tofacitinib therapy. So in the interest of time, let's talk about the conclusion. So people, of course, we all talk about that it's a mild enough disease. It's just an inflammatory arthralgia rather than an arthritis. But if you look at the overall significant disease burden it carries, that's a lot. Because again, as I keep on repeating this, we are talking about an aging population which have already got a lot of comorbidities. So it's very important to come up with a plan, not just a steroid, but also looking at some steroid sparing therapies from the start, from the day one. And we need to be mindful about the mimics of the PMR and the vasculitis, which is a very close friend of it. We should not sort of ignore that, especially in the patient who have got persistent inflammatory markers. I have recently seen a polymyalgia rheumatica patient. Again, absolutely surprised me, because one day when the nurse was telling me the blood pressure is not recordable, and turned out to be there was a subclavian stenosis in that particular patient. So these patients do surprise us now and then. Thank you.
Thank you, Dr. Haroon, for adding to our knowledge. As we're running short of time, we will humbly request our speakers to keep the presentation short and try to conclude within 20 to 25 minutes. The next presentation in our series will focus on axial SPA, examining the most recent global research and its implication for local treatment strategies and best practices. As a leading cause of chronic back pain and disability, axial SPA presents significant challenges in diagnosis, treatment, and management, necessitating a comprehensive multidisciplinary approach to care. It is our esteemed privilege to introduce our next speaker, Dr. Muhammad Ahmed Zayed, a leading luminary in the field of rheumatology. Please join us in warmly welcoming Professor Muhammad Ahmed Zayed to the stage as he presents Advances in Axial SPA, Bridging Global Evidence with Local Practice.
Thank you for your kind introduction, and thank you again, the organizers of Rheumacon, to give me an opportunity to speak on this occasion. So as far as the conflict of interest are concerned, they are none relevant to this presentation. So this is just an outline of my talk. I would be starting with a case scenario. And this is a 30-year young male who had been having chronic back pain for almost intermittently for 7 to 8 years, which he actually went unnoticed. So it was just a mild pain stiffness, which used to be worse in the morning, and he used to be up and about. And it was just 3 weeks story, which was having a pain in the right buttock and radiation up to the upper thigh. He's a gym enthusiast, referred to me by a colleague, an extended family to him, and seen in a clinic, and with the notion that I have sciatica, because this is what he has been told by his local practitioner, and his pain was worse when he was sitting for long periods of time, because he does an IT job remotely. His review system for spondyloarthritis was totally negative, except a family history of a maternal uncle who has back pain but has never been evaluated for that. And his pain actually gets better with pregabalin. So what are your thoughts at this stage? Any thoughts? Any fellows in training? So any our colleagues sitting here? So it's like a variable character kind of a situation in which he can go both ways. His Schobers comes out to be 4 centimeter, which was equivocal. His Faber on left side was positive with tenderness in the piriformis area. So I'm in the clinic, I generally, once I have CRP, only then we can calculate S-test. But his first visit BASTI was just 1.7, which is like a very mild or inactive disease at this stage, if it is SPA, axial SPA. Rest of the musculoskeletal examination was totally unremarkable. The joints, anthesis, the skin, there was no SPA feature at all. And his neurological exam was also normal, meaning by he had a negative straight leg raise and he had normal power, no issues with the sensation in the lower extremity. This was his X-ray like. So X-ray has changes of grade 2 bilaterally, symmetrical, but they are more in the upper 1/3 or half rather than the lower. So it would be by modified New York criteria. So if observer, there would be a lot of inter-observer variability when you report such X-rays. You can easily say that there are equivocal changes and someone may say that it's like a grade 2. So at this stage, so the first, obviously, differential was axial spondyloarthritis. The second was a mechanical character of the back pain, considering that he has the tenderness in the piriformis area. So this might be a myofascial pain syndrome, a piriformis, prolonged job, IT. So sitting for many, many hours in a whole day. And then relevant investigations, they were ordered. He had MRI sacroiliac joints. So whenever you order an MRI, this is so very important that you do not write MRI pelvis. It has to be MRI sacroiliac joints, and it has to be done with semi-coronal sections. And the right technique, the sequences which you would like to see order would be the stir or short or inversion recovery sequences. His HLA-B27 was also sent at that stage, and his CRP and ESR as inflammatory markers. So this was the mind map going on. So if it's like a non-radiographic axial SPA versus radiographic, so would start him on NSAIDs, would refer to exercise, physical therapy, and if he's not responding, only then we would consider biologic. But what if it is just a mechanical problem going on in this young man, and you just wrongly label? At times you try to over-diagnose and overkill as well in the practice. So what if it's like just a mechanical strain? He just needs physical therapy, reassurance, postural correction, and then short-term use of NSAIDs and muscle relaxants and nothing else. So this was his MRI like. So MRI, when done properly, so can actually shows areas of osteitis and bone marrow edema. So this is periarticular subchondral bone in one quadrant, and then you can see that in some other quadrants there is also some hyperintense lesions, osteitis, and there is some early erosion over here as well, so, and over here. So there is an osteitis. And some streak of fluid can also be seen in the, so over here, so you can see a streak of fluid in the joint as well, which is also significant. And ASAS actually doesn't keep these capsulitis, synovitis, or enthesitis as a definition and the criteria, but it is basically the ASAS recommends having osteitis. Even in 2009, it used to be quantitative, at least have to be present in more than two consecutive sections or in more than 2 quadrants. But they have now revised their definitions for active sacroiliitis. Structural changes are still not part of it. So this is what exactly happened in these patients over a course of disease. A patient from here which is a non-radiographic axial SPA, can evolve into radiographic, can develop syndesmophytes, and this can happen in every 1 out of 4 patients over a period of next 2 to 5 years. So which is actually a huge number, especially when patients are HLA-B27 positive and when they have a high CRP, because these are the predictors of radiographic damage. So considering the EULAR ACES recommendations, you would start them on non-steroidal anti-inflammatory for at least 2 to 4 weeks before you escalate the treatment, and you would refer them to physical therapy. You would educate them about their disease, active lifestyle. This is not the kind of back pain in which you would really tell them not to do anything, not to bend forward. Rather, this patient has to be doing all kind of exercises, but obviously high intense exercises which can mechanical stress can also lead to inflammation. So he's a gym enthusiast. His gym training, the weight training needs to be modified as well. And then he has to have that measures of disease activity done periodically in the clinic, and then we decide whether to escalate the treatment or not. And the treatments which we can offer them are the TNF, IL-17, and even the JAK inhibitors. It seems that there is no one best fit for your patient. So you have to tailor treatment according to your patient. So this is the era where we are entering into precision medicine. And we know that there are pathogenesis, there are genes other than HLA-B27 as well, ERAP1, ERAP2, so there are IL-23 receptor genes, there are gut microbiome on which the studies have been done. And we need to really see which patients are the ones who actually require this kind of treatment, which we know that has its own implications, like giving TNF, like giving IL-17 inhibition, and even JAK inhibitors. So this is the era in which we are now entering. Maybe down few years we would be having artificial intelligence taking over, and then that machine learning telling us which patient is the best patient. But I think that we are going to stay there, so human mind, so that is going to be the one, and we have to individualize treatments despite the fact that there are factors which are more objective, which can tell us about the disease progression. And if you look at the patient characteristics, someone, yes, a male gender, I would really worry. So they are the ones who are, it's considered to be male gender, a predictor of radiographic progression. Smoking. So by the way, this gentleman also smokes, accompanied by wife, and उसने कहा कि vape करता है. Vaping it still, I believe, is smoking, and this gentleman needs to stop smoking. Obesity, because of the mechanical stress, obesity itself has been considered to be one of the comorbidities which leads to difficult to manage disease. The biomarkers, the CRP and high ESR, even calprotectin, which can be done, but still not like validated to be used in clinical practice, and high disease activity scores, STAS and the BESTI, and the presence of baseline syndesmophytes. So all these patients in which you are actually doing a baseline visit, they should have lumbosacral spine x-rays, lateral view, and the cervical spine x-rays as well, in order to look for the presence of any syndesmophytes. And obviously, I have already talked about the MRI, and in a few seconds, I would be actually going over with these fatty changes as well. So this is just few insights from the ASAS, which I'm going to share with you. These are the representative images from the ASAS handbook, and this was 2019 when they updated. So if you have never ever seen before capsulitis, that the arrow over here is what exactly you would look for the capsulitis. This is bone marrow edema. Your patient has similar picture. This is more extensive. This is like more representative image. So you can see that there are images now which are other than that, which is a backfill edema happening in patients with where there is an erosion. So this is backfill edema. So this is hyperintense edema where the erosion is actually happening, and sclerosis. So these are the structural changes. Structural changes have not been made the part of active sacroiliitis criteria. But when you are looking at the MRI, remember, radiologists look from a different perspective. Most of the time they have no knowledge about the clinical symptoms. This is what exactly happens most of the time. So you have to read your MRIs yourself and have to develop that expertise. So looking at this is fat metaplasia in a patient which is like becoming now a chronic change. This is backfill happening that in an area which is a vertical erosion. And then this is a bone bud. So this is a bone bud which is ankylosis on the left side, and on the right you can see the bone bud. So these are the structural changes which you can appreciate on MRIs as well. But MRI, the best actually changes which you can see are either on the X-rays or on the CT. So you can see a erosion over here, the same patient, intense lesions seen which are more suggestive of sclerosis on MRI. So do not ignore these changes. And when you look at the latest modalities which are being used, there's a low-dose CT which is being employed for detecting syndesmophytes, and a type of scoring which we used to do on radiographs, which is an MSAS. This is a score which is done, CT syndesmophyte score using a low-dose CT. So this is a paper which was published in Research Musculoskeletal Diseases in 2024 January. And yes, deep learning is there now. These algorithms, they have been developed, they have been proposed, and they have been published this year in January. So there is a rapid, optimized, there are 2 algorithms which are being employed and are being considered as machine learning models for detecting MRI changes active of sacroiliitis in patients with suspected spondyloarthritis. And this is a paper by Nicholas J. What is the evidence for treat to target? So treat to target, we know that patients who have a high STAS, they have a more disease progression in terms of radiographic damage. So this is what a cutoff which we generally aim at, which is considered a low disease activity at 2.1. So this is a composite of measures which are the patient-reported outcomes and obviously the CRP incorporated together, and you can compute it using just an app on your mobile and come up with a score. And I always tell my fellows that your understanding about the disease is really bleak if you cannot give a number to what is the disease activity at this point in time. For family physician practice people who are sitting here, ब्लड प्रेशर कितना है 140/90 से नीचे लाना है, टारगेट क्या है, HbA1c का लेवल क्या है. तो the same actually has happened in the field of rheumatology. So we have come to now the targets that we have to suppress inflammation so that our patients can have better outcomes. This was the TICOSPA trial, which was published in 2021, which actually couldn't meet the primary endpoints. But when you looked at the secondary endpoints, SS40 and the STAS LDA, so there was significant difference. There were more patients in the tight control group in which the disease in their treatment was being escalated using STAS CRP scores as compared to those who were having usual care. So what are the new additions in our therapeutic armamentarium? So this is what exactly we were having for many, many decades, just anti-TNF. So then we had IL-17 inhibition came in. Then we have JAK inhibitors. The first JAK inhibitor which was launched in Pakistan was tofacitinib. Opada was also approved for radiographic as well as for non-radiographic axial SPA. I think now in 24 we have bimekizumab, which is also now not available in Pakistan yet, but it is also approved, which is also IL-17 inhibitor, IL-17A and IL-17F inhibitor. So what are the factors which affect? So this is what I generally feel that these are the factors which we have to keep in mind as clinicians. The first is the disease activity, obviously, because we are treating to target. And then the comorbidities, a patient who is an elderly, patient who is young. So they are generally, expa patients are generally young. They tolerate these medications very well. So these drugs, when we have even concerns with cardiovascular safety, with infections, but these patients are the ones who have disease in their third and fourth decade, second decade of life. So they are the ones who are good candidates for these medications. If a patient has accompanying psoriasis, the guidelines say that moderate to severe psoriasis, your first choice would be secukinumab, which is IL-17 inhibitor, which is available in Pakistan. If you have a patient with recurrent uveitis, so then it would be a monoclonal antibody, adalimumab, infliximab, not Enbrel, not secukinumab. If you have IBD, so there is a caution, there is a warning with secukinumab using in patients because it can lead to worsening of inflammatory bowel disease. Then the choice would be monoclonal antibodies, anti-TNF as compared to other. And then the issues of access, what to do? You know what the medications are there, but people can't afford it. How are they going to afford? So the issues of access needs to be addressed, and this is one thing which we all have to really take care in our practices. This is the data which was the landmark trial which led to FDA approval by upadacitinib with ASAS-40 response rate of around 66%, low disease activity attained in 65, and ASAS inactive disease in 57. So this is very promising data. So I'm really intrigued why upadacitinib has been performing well as compared to our other chicks on the block. So this is what exactly the data says, and you can see over here, so the upadacitinib is being represented in green, and this is the percentage of patients who have ASAS-40 response, and this is the STAS-LDA, and you can see over here, so this is up to like 67, 68%, up to 70% of the patients, they did so well that they were able to have their STAS less than or equal to 2.1. which is great happening in the field of XBA in recent years. When you compare it with tofacitinib, so you can see tofacitinib hasn't performed that well in that regard because the ASAS-40 response rates are still hovering around, so this is 40%. 20% can happen even with an NSAID. So, and if now you compare them, so this is what exactly the comparison would look like when this comes to 40% improvement in the ASAS criteria. So upadacitinib is really performing well as compared to tofacitinib. This is the data, which is the bimekizumab, which is IL-17A and F inhibitor. So this is still not available, and you can see over here that the ASAS response rate in patients still is now in these patients after 52 weeks is around 40%. And this is the comparison between the three groups which we have now available in our armamentarium. So the JAK inhibitors, IL-17, and TNF in terms of ASAS-20 response, ASAS-40, and ASAS-60 response based on their landmark trials. And you can see over here the JAK are really performing well. Now coming to radiographic progression. So are we there now? So can we say that these medications, they can suppress inflammation and prevent radiographic progression as well? There had been some reports with anti-TNF. This is the images which are from a trial which was actually done by Alberta, the group prospective cohort on tumor necrosis factor inhibitors. They reduce spinal inflammation. Remember that 5% of the patients in XPA might not have inflammation in the SI joints. They might have only in the spine. And do not forget that these are also the side, the posterior elements, the anterior corners, which can show hyperintense signals if you do a whole MRI spine. This is still not advocated to be a routine practice because a lot of money then would start going into it. So, but the thing is, yes, if you suppress the inflammation earlier, there would be no fat metaplasia, there would be no bone formation. So that window of opportunity persists for AS patients as well. This is the Meyer 1 study, which was actually looking at secukinumab showing sustained efficacy and low structural progression in radiographic axial SPA over a period of 2 years as compared this was one comparison of secukinumab with adalimumab. It is a SURPASS trial. This is the cumulative probability plot of patients of having MSAS score at week 104. You can see that there is as such no difference. These are individual patients over here all over the period of time, and this is how we score actually on MSAS scoring: normal, erosion, squaring, early syndesmophytes, and then syndesmophytes giving a 3 score of 3 on these sites which are in the lumbar spine and the cervical spine, the anterior corners. And this showed that spinal radiographic progression over 2 years was low, with no significant difference between secukinumab and adalimumab. Now the regional data which we have been able to contribute, and the local data. So our center and the center which Dr. Haroon works has been contributing to APLAR SPA registry. So the highest enrollment actually is from Pakistan. So I'm really proud of that around 20% of the data from all Asia Pacific is generated by Pakistan. So so far up to like 349 expa patients they have been registered. This is the data as of this year, August. This was presented in APLAR. And if you look at the use of biological DMARDs and the TS DMARDs in this registry, this is around 67%, and this is what the pattern of these biologics is. Predominantly, it's anti-tumor necrosis factor, then is IL-17 inhibitors, and then would be the JAK inhibitors. And these are the outcomes. If you look at the outcome, I'm just restricting myself because this is for the psoriatic arthritis, and this is what STAS LDA. So patients are doing well when actually you are treating them to the target. This is a treat to target cohort. This is generating evidence in support of that. As of today, the ASAS and JULA do not recommend as such treat to target approach. They do recommend to measure disease activity score and to look for improvement of more than 1.1 in subsequent visits, but as such predefined, they say the predefined target, but the predefined target is now 2.1 or less. This is our cohort, which we have been able to establish with the support of Arthritis Care Foundation, looking at frequency of patients in whom this T2T, this treat to target approach has been employed, and the proportion of patients achieving the target of low disease activity at 6 months, 1 year, and 2 years using the STAS-TIA CRP cutoffs. So far, 309 patients have been enrolled. This is the data as of March 2024. The compliance to T2T was observed in 86.1% of the patients. These were the baseline characteristics. So still we have majority of our patients have radiographic expa. Male gender is predominant. Diagnostic delay is around 6 years mean. And this is the use of biologics, around 46.3% in our cohort. This is the pattern of the biologic being used. Etanercept in 18.4, 33.8% IL-17 inhibition, secukinumab, and tofacitinib has really picked up. This data as is of 24 March, so upadacitinib has not been included in it. The outcome measures, if we look at the data, so it is really promising that STAS CRP cutoff was achievable in around 60% of the patients. Like 60% were doing great in our cohort on whether they were on biologics or not. When we looked at comparative efficacy of achievement of proportion of patients as CRP, it was highest with etanercept, and then it was comparable in secukinumab and tofacitinib. This is another study which we published in 2023 in Armed Forces Journal, which was secukinumab use. And again, around 50% of the patients were achieving the target. And when we compared it with PSA we know that secukinumab IL-17 inhibition leads to more promising results with psoriatic arthritis and psoriasis, and it is up to like 57%. So this is the data which we presented last year in APLAR, which is about, again, comparison of tofacitinib versus secukinumab, and it is a retrospective study design, and we were able to come up that efficacy. If you look at the efficacy between tofacitinib and secukinumab, it was comparable. There was no statistically significant differences. This was the an abstract which I presented at EPLAR or gender differences in disease parameters, adherence to treat to target from the same data from the same cohort. HLA-B27 positivity is less as compared to men and females in our cohort, and the best eye baseline was higher, which was statistically significant as compared to their counterpart men. The CRP was also high at the baseline as well as at the last follow-up visits throughout. So they have disease which is more active. When you looked at the disease parameters, so 25% of the females achieved the target, and it was 38.9 in men as compared to 25% in females. And the use of biologic DMARD was also higher in men as compared to women. So the burden of the disease in women is higher than in men in terms of best eye, but comparable as far as CRP is concerned in our cohort. There is disparity in use in terms of biologics and TSD-MARDs. There is need to identify factors affecting biologic TSD-MARD use. The key message is treat to target strategy in cohorts is feasible strategy for generating local data. Despite the availability of newer biologics and TSD-MARDs, still 40 to 50% of the patients in clinical trials as well as in international and our national cohort, they will not be achieving the target. So we are still not there. And there is an unmet need for the nationwide registries and local guidelines considering patient preferences and cost issues. This is my mentor, Professor Nigar, Professor Sumaira, so at ACR, after presenting and this is my acknowledgements to institutions with whom I work. And thank you for your patience listening, and I hope to see all of you in PSR 2025 in Lahore in October as well. Thank you for your patience.
Thank you so much, sir. You are a true inspiration, and we are honored to have you with us. Now let's move towards the next speaker of today's session. I'm honored to welcome esteemed Professor Nigat Me to have on stage.
Bismillahirrahmanirrahim. Professor Tafazul, Professor Aflaq, Shaikh Zayed Hospital, what a great event. Congratulations. बात सारी ये है कि अब सिचुएशन बहुत टाइट है, और आप पूछेंगे कि क्यों टाइट है। टाइट इसलिए है कि सारों को भूख लगी है, बाहर मौसम बहुत अच्छा है, मैच की तैयारियां हो रही हैं, लिटरेरी फेस्टिवल चल रहा है, और हम सुबह से लेक्चर सुन रहे हैं। सो बहुत अच्छे सेशन जा रहे हैं, बट मेरा ख्याल है कि ज़रा अब पेशेंस कम हो रहा है। सो 3 cheers फॉर दिस क्राउड हु इज़ हेयर एंड अभी बड़े सब्र से बैठा हुआ। 3 cheers फॉर समवन एल्स ऑल्सो। मेरी अम्मा घर में बैठी हैं, मेरे हस्बैंड घर पे बैठे हैं, मेरे बच्चे फ़ोन कर रहे हैं, और मेरी टीचर्स इंतज़ार कर रही हैं क्योंकि बहबूद में एग्जिबिशन हो रही है। तो प्लीज़ मेरे लिए भी 3 cheers। अच्छा जी, यहाँ पे जो आपको इतनी प्यारी एक तस्वीर नज़र आ रही है, इसके बारे में ये कहूँगी कि हम बहुत थोड़ों से शुरू हुए थे और ये काफ़िला बहुत बढ़ गया है। और इसमें वजह क्या है कि मंजिलों की राह में जो हायल अंधेरे हो गए, मंजिलों की राह में जो हायल अंधेरे हो गए, हमने जलते हौसलों से रास्ते रोशन कर लिए। तो ये हमारी कहानी है, ये रूमेटोलॉजी की कहानी है। सो कैन यू टेल मी हाउ टू गो अलोंग विद द स्लाइड एंड द पॉइंटर्स प्लीज़। अच्छा जी, अब आपको मेरी स्टोरी इसलिए सुननी पड़ेगी, और ज़रूर सुननी पड़ेगी, क्योंकि जब आपका कोई प्यारा जिसके मोढ़े में दर्द ही नहीं जा रहा, जिसके सर का दर्द शुरू हो गया है, जिसको खाना चबाने में डिफ़िकल्टी हो रही है, और जिसको नज़र आना बंद हो गया, तो अगर आपको नहीं पता होगा, चाहे आप फिजिशियन हैं, चाहे आप रूमेटोलॉजिस्ट हैं, आप किसी भी ऑर्थोपेडिक सर्जन, जिससे अगर आप यहाँ से ये लेसन नहीं सीख के जाएंगे कि इसके क्या कॉन्सिक्वेंसेस हो सकते हैं, एंड व्हाट इफ़ इट इज़ नॉट डायग्नोज, तो क्या होगा। तो आज फिर ये हो जाए कि ये मैंने तो सोचा था कि हम सारा कुछ ये करेंगे, बट होपफुली, क्योंकि यू नो दिस डिजीज़ विच वी आर टॉकिंग अबाउट it's so heterogeneous that if you don't know this, there's a vasculitis fellowship for 1 year in USA because 2 साल की ट्रेनिंग में vasculitis नहीं आता. So इस वजह से vasculitis को सीखना बहुत ज़रूरी है if you want to be a good physician, a good rheumatologist. हमको सबको पता है कि जो classification vasculitis की है वो it can depend upon the vessel size. So हम लोग इस वक्त बात कर रहे हैं सिर्फ large vessel and medium vessel vasculitis. And large vessel vasculitis or medium vessel vasculitis में we're just going to talk about giant cell arteritis. So होता क्या है जी कि basically it's an inflammation of the vessel wall. और इसमें GCA में क्या होता है? GCA is actually basically a generalized inflammation. It involves all the layers of the vessel wall, and it is a granulomatous inflammation, and the hallmark is the presence of giant cells. लेकिन we have to remember कि giant cells जो हैं वो 50% of the biopsies में होते हैं, they are not present. And we also have to remember that the inflammation starts in the adventitia. Vasa vasorum में शुरू होके it goes towards inside and destroys the entire vessel wall with the rupture of the internal elastic lamina, जिसकी वजह से obviously the lumen narrows and there is ischemia. अच्छा, अब you know, for us to understand the therapies, we need to know the basic mechanism. और बहुत आसान सा ये वैसे तो आपको बहुत एक busy slide लग रही है, but ये move क्यों नहीं हो रहा भाई? Yeah. So basically, there are 3 factors, and the 3 factors are IL-6, IL-17, and Th17 cells in GCA. We don't know, भाई क्यों इसको हो गया GCA? So there are genetic factors, there are environmental factors, and there are certain drugs, we don't know, certain regions where this is more common. So what do? What they do is that IL-17 cells are present in the wall of the blood vessel, in all the layers of the blood vessel. Well, all these environmental factors or whatever the reason, whether it's your genes, the cells which get activated are T cells and macrophages. And the T cells and the macrophages secrete IL-6. So IL-6 and Th17 are interrelated because Th17 cells will be activated, more kinins will be released, and this will cause an inflammatory cycle which will destroy the vessel wall. So that is why the treatment right now aims at blocking IL-6, blocking IL-17, and obviously the T cells. So hopefully, अच्छा जी, I didn't know, sorry, मुझे खुद नहीं पता चला कि how was this disease discovered and who discovered it. तो अब आप history पे जाएं, तो it was discovered by an ophthalmologist, and this ophthalmologist was from our Baghdad, Iraq, और उन्होंने ये notice किया कि there was a potential relationship with visual symptoms and inflamed arteries. And then Hutchinson ने बड़ी अच्छी तरह से describe किया an 80-year-old with inflamed arteries who had headache, and his scalp was so tender that he could not even put on his hat. So this is history, but obviously as the time went along, in 1938, polymyalgia rheumatica and the relationship with temporal arteritis was established. अच्छा जी, ये केस है और मेरा ख्याल है कि ये केस रूमेटोलॉजिस्ट के लिए है, पीजी ट्रेनीज़ के लिए है, इसको देख लें. और यहाँ पे मैं देख रही हूँ वहाज को. वहाज इसका आंसर जो एंड में देगा, you will give them a gift. So a 70-year-old woman with the history of PMR, remember polymyalgia rheumatica, और अभी डॉक्टर साहब ने बड़ी अच्छी टॉक दी है polymyalgia rheumatica पे, I'm not going to go over it. So it was diagnosed 2 years ago. बहुत दफ़ा रिलैप्स हुआ, और ये हम सब के साथ होता है कि आप पेशेंट को टेपर करते हैं स्टीरॉइड्स एंड द पेशेंट रिलैप्सेस अगेन. सो वो थर्ड रिलैप्स पे 15 मिलीग्राम ऑफ प्रेडनिसोन पे उसको कंट्रोल किया, बट इट वाज रिड्यूस टू 5 मिलीग्राम. and he comes back, or she comes back, ESR has been 70, CRP has been elevated, but now she comes in with severe abdominal and back pain. Correct answer बताएंगे बाद में. What would you do? Increase prednisone to 15 milligram per day and reattempt tapering later? Will you add Actimra or continue low-dose prednisone? Will you shift her to the emergency room? Would you start her on methotrexate without changing the dose? And what is the test which you will do? So let's see, आपको इस talk के बाद इसका जवाब आएगा या नहीं. When we were doing our fellowship, we only knew two things: polymyalgia rheumatica, giant cell arthritis. We never knew that there was something in between also. So now the emerging concept is that it is a spectrum. It's a disease spectrum. And this Venn diagram over here clearly explains it. So अगर आप देखें तो जो blue circle है वो PMR है, जिसके बारे में मैं discuss नहीं करूँगी. We just listen to Haroon's talk. But it overlaps with GCA. So GCA में अब very interestingly you have a cranial GCA and you have an extracranial GCA. What does cranial GCA do? So आपके घर में अगर किसी 70-year-old को सख्त दर्द हो रही है सर में और उसको अगर GCA है तो उसको एक और चीज़ का बहुत खतरा है और उसको कहते हैं ischemic GCA. Cranial GCA involves the branches of the external carotid artery, so you will have temporal headache, scalp tenderness, and jaw claudication and chewing में difficulty. So this is all a cranial GCA, but branches of external carotid artery. But the ischemic GCA, जो circle छोटा वाला है, उसके अंदर people who have this, they can develop loss of vision because of the involvement of the ciliary artery which is supplying the optic disc. So optic disc अगर आपका चला गया है तो you can lose vision, and if you do not recognize it in 48 or 72 hours, then you can lose your eyesight forever. And 20% of these people are at risk for losing their eyesight. Extracranial GCA is आप pulses examine करना कितना ज़रूरी है patient का. आप PMR का patient है, आप उसकी pulses नहीं examine कर रहे. That would be wrong because extracranial GCA involves the subclavian and its branches and axillary artery. So patients will have difficulty in combing their hair, they will have handi nahi pak rahi ji, dard ho jata hai. All these things because of axillary involvement and subclavian and vertebral artery involvement. So this is extracranial GCA. और इसके अंदर अगर आप yellow circle देखेंगे तो वो एक isolated aortitis है जिसमें aorta involve हो जाती है और aorta की involvement से आपको पता है कि क्या कुछ हो सकता है. So let's now, so we have gone through this, these are the arteries, these are the sites, but I would literally, all my emphasis on recognizing the anterior ischemic optic neuritis because it can lead to loss of vision, remember that. So rest of the stuff we've just talked about, आपको सब लोग कहते हैं भाई classification criteria नहीं use करने diagnosis के लिए सही कहते हैं, they are meant for research, but they do help us a little bit. And जो helping इसमें इस चीज़ से हो रही है कि सिर्फ you have to remember one thing, the age limit is 50 years. So 50 years से less में ये चीज़ें नहीं होती हैं. So 50 years and more, mostly females. So अगर आप इसको देखें तो आपको ये लगेगा कि wow, the positive temporal artery biopsy, which is now also equivalent to doing ultrasound where you see a halo sign, gets how many score? 5. अगर आपको इसमें 5 मिल जाते हैं, आपको कहीं और से भी एक लेना है, and you can make a diagnosis of GCA because see the importance they have given to the positive biopsy and to the halo sign, and rest of them are all 2. If you score, so you don't have to do it in your clinic because we all know that this has to be basically all clinical. This is very interesting. Fast Track Clinic in Berlin, which was established, did a study and they found that GCA itself has subsets. So there is a cranial subset with people have only cranial symptoms, जो मैंने अभी आपको समझाए हैं. Extracranial only 21%, लेकिन दोनों को जो cranial भी होगा और extracranial भी, which is axillary arteries, subclavians, so they can be like around 32%. So इस वजह से you must make sure that you know that patients who have PMR, 50% of the patients with GCA will have those symptoms, but they can have these mixed pictures. So this is a study which was done in different countries, which showed that there is a subclinical GCA in patients with PMR. आपको आपके patients याद होंगे कि आप बार-बार उनकी steroids taper करते हैं और बार-बार वो relapse कर जाते हैं, बार-बार वो relapse कर, उनको high doses steroids की चाहिए, हैं तो वो PMR, but then you should start suspecting subclinical GCA. And इन studies में अगर आप देखें तो स्पेन, इटली वगैरह में 23% of the patient who had PMR had occult, temporal, axillary, subclavian and carotid involvement. And the range goes out to 16% from different countries. ये बात याद रखें कि this is the same spectrum. So we know that ये blue में सारा आपको नज़र आ रहा है, ये GCA और PMR में एक ही जैसा है. So commonest vasculitis है GCA, don't ignore it because we are missing it out too much. वो हमेशा shoulder pain के साथ कहीं orthopedic के end up हो जाते हैं, आपके पास भी आते रहते हैं, बाजू में दर्द हो रही है, so don't ignore them. And we know that पता नहीं क्यों भाई ये कैसे है कि हर बीमारी जो है वो औरतों में ही ज़्यादा है, so ये भी औरतों में ज़्यादा है, but इसमें age जो है वो plus 50 years as I already said. So common features तो blue में हैं, जिसमें fever, which are systemic features, which due to release of kinins, polymyalgic symptoms, hurting shoulders, neck वगैरह, and acute phase reactants. But जो differentiating points हैं, clearly वो headache है, जो कि PMR में नहीं होनी चाहिए. Temporal artery abnormality है, जो PMR में नहीं होनी चाहिए. Jaw claudication and visual symptoms. मुझे ये पर्ची टाइम की नहीं दिखाना क्योंकि discrimination हो जाएगी. अच्छा, suspect. So अब आपने क्लिनिकल हिस्ट्री से सस्पेक्ट कर लिया है कि आपको जॉइंट सेल, इसको मुझे लग रहा है कि इसको जॉइंट सेल आर्थराइटिस है, तो पहले तो सब बायोप्सी की तरफ जाते हैं. आप में से कितने लोगों ने कभी पेशेंट को बायोप्सी सजेस्ट की और उसने मान ली है? मेरे तो पेशेंट बहुत कम मानते हैं कि हम जी इधर से बायोप्सी कराएंगे. उफ तौबा, बायोप्सी क्यों कराएं जी, हम टेम्परल आर्टरी की मरीज आंखें ख़राब हो जाएंगी. सो टेम्परल आर्टरी बायोप्सी was the gold standard, and but the good thing about this is कि इसमें जो जॉइंट सेल्स जो प्रेजेंट हैं, जो ऑब्वियसली एक हॉलमार्क हैं, वो सिर्फ 50% में है. और अगर आपके सर्जन ने आपकी बायोप्सी सही नहीं ली और उसने 2 सेंटीमीटर्स का एक पीस नहीं लेके भेजा, तो यू विल मिस योर डायग्नोसिस बिकॉज दे हैव स्किप लीजन्स. सो हमारे यहाँ एक तो कोई कराएगा नहीं, सर्जन को कहाँ से ढूंढेंगे, वो 2 सेंटीमीटर का टिश्यू देगा, फिर हिस्टोपैथोलॉजिस्ट के पास जाएगा. तो हमारे लिए तो एक गॉड सेंड गिफ्ट आ गया है, बिकॉज नाउ द गाइडलाइन सेज दैट वी कैन डू अ अल्ट्रासाउंड विद समबडी हु टेम्परल आर्टरी अल्ट्रासाउंड और एक्सिलरी आर्टरी अल्ट्रासाउंड इज़ द गोल्ड स्टैंडर्ड. हाँ, अगर हम बड़ी आसानी से कह देते हैं कि जी पेट सीटी कर लें, MR एंजियोग्राम कर लें. Yes, if you can do it, there's nothing like it because you will see wall edema as you see in the MRIs, MR angiograms which are shown over here. And PET scan में सारा aorta जो है वो lit up है और halo sign जो है वो आपको नज़र आ रहा है in the ultrasound. So there is an update and ये सारा कुछ अब किताबों में लिखा है, AI में लिखा है, आप खोल के देख सकते हैं. So I don't think I need to go into the details of all this. I want to ask, let me skip this. अच्छा जी, अब हमारे पास जो पेशेंट्स कहाँ जाते हैं सबसे ज़्यादा? जब उनके बाजुओं में दर्द होती है, सर में दर्द होती है, किधर जाएंगे? फिजिशियन के पास जाएंगे, राइट? सो फिजिशियंस के पास जब जाते हैं एंड इफ दे आर नॉट अवेयर ऑफ दिस, तो ऑब्वियसली दे विल मिस द डायग्नोसिस एंड देयर इज गोइंग टू बी अ डिले इन द रेफरल. सो इसके लिए बहुत अच्छा एक फास्ट ट्रैक क्लिनिक शुरू हुआ बर्लिन में ही अगेन, वेयर इज एजुकेटेड देयर डॉक्टर्स that किसी भी पेशेंट को जिसको इस तरह के सिम्टम्स हैं, if they develop jaw claudication, double vision or amaurosis, loss of vision, then they have to immediately fast track clinic to a rheumatologist. तो आपने देखा कि वो रिजल्ट कितना अच्छा है. Reduction in the irreversible visual loss was very significant, 37% compared to 9%. and 19% compared to 2%. You can see the differences, marked reduction in the visual loss. So we should be thinking about such things. एक बहुत अच्छा score है. I am not practicing this, but this is an excellent score which helps the family physicians and doctors and rheumatologists to make sure that GCA is not missed, it's diagnosed early and it is referred early. So हर चीज़ को एक point दिया हुआ है. And if you look at that score, let's not look at the details, but you can see that जब age 60 से ज़्यादा हो रही है तो score जो है वो over 65 is 3. और अगर आपकी टेम्पररी एब्नॉर्मैलिटी है तो 2 है. सो इस तरह डिफरेंट स्कोर्स लेके आप उनको पॉइंट्स देते हैं. सो आप देख लें कि ESR CRP को इतना पॉइंट नहीं मिले. सो ये स्कोर अगर आप कैलकुलेट करते हैं और स्कोर में अगर वो लेस देन 9 है तो ऑब्वियसली पेशेंट इज़ वेरी लो रिस्क. अगर वो 10 to 12 है तो इंटरमीडिएट रिस्क है, और अगर वो ग्रेटर देन 12 है तो ही इज़ एट वेरी हाई रिस्क. और ये सब कुछ जो है इज़ वेरी इम्पॉर्टेंट बिकॉज आपको पता है कि 50% जो पेशेंट्स हैं वो आपके पास पहुंचते ही नहीं टाइम से. सो अगर आपके पास ये सब कुछ है तो आप उनको जल्दी रेफ़र कर दे फिजिशियन, तो हॉस्पिटलाइजेशन रेट्स में डिक्रीज़ है, स्टार्टिंग GC डोजेज़ जल्दी शुरू हो जाती हैं एंड ज़ाहिर है कि डायग्नोसिस जल्दी हो जाता है. सो दिस इज़ व्हाट द फास्ट ट्रैक क्लिनिक्स आर डूइंग. सो मैं काफ़ी फास्ट फॉरवर्ड ट्रेन चला रही हूँ, but hopefully you are getting all the information. So अब आप करें क्या? अब ये भी सब कुछ दिया हुआ है कि अगर आपका पेशेंट आपके पास आ जाता है और वो पहले वो GCA है, बट द GCA की भी तो कैटेगरीज हैं. एक कैटेगरी है विच इज़ हाई रिस्क फॉर विजुअल लॉस और एक जो है वो नहीं है. सो अगर वो हाई रिस्क नहीं है फॉर एनी विजुअल लॉस तो आप उनको ओरल स्टीरॉइड्स पे शुरू करेंगे. बट अब जो रिकमेंडेशन है कि ओरल स्टीरॉइड्स के साथ ही आपने उनको डिजीज़ मॉडिफाइंग बायोलॉजिक शुरू करना है विच ऑब्वियसली टोसिलिजुमैब. तो अब ये नहीं है कि आपने वेट करना है. सो इट इज़ प्रिफर्ड फॉर rather than giving them glucocorticoids alone. और इसी तरह जो लेकिन इफ़ यू हैव रेफर्ड, कोई ऑप्थेल्मोलॉजिस्ट आपको एक पेशेंट भेजता है, ESR ज़्यादा है, CRP ज़्यादा है, इसकी विजन ख़राब हो रही है, इसको ऑप्टिक न्यूराइटिस हो रहा है, तो what will you do? You will pulse them for 3 days. And then obviously you will start them on oral steroids, but at the same time you will start them on अभी जो approved है which is trastuzumab. अगर वो नहीं है तो जो बाकी चीज़ें हैं वो तो हमारे मुल्क में अवेलेबल ही नहीं है, उनकी बातें करना फजूल है. बेटासेप्ट, मेथोट्रेक्सेट, यस नो. सो अब आपका पेशेंट तो PMR का है, लेकिन आपको पता चल गया कि उसको जाइंट सेल आप सस्पेक्ट कर रहे हैं कि उसको अकल्ट GCA है, अकल्ट GCA, और हमने बता दिया कि उसको डायग्नोज आपने कैसे करना है. सो शुड यू ट्रीट दैट बिकॉज उसको तो कोई सिम्टम्स नहीं हो रहे हैं बट वो रिलैप्स कर रहा है बार बार, और वो बार बार उसकी डोज आपको ज़्यादा करनी पड़ रही है स्टीरॉइड्स की, तो आप बहुत ज़्यादा सस्पेक्ट कर रहे हैं कि उसको है. और सो यू सी दैट the difference between the two graphs, which is clearly explained that you will treat them as silent GCA unless you can obviously, if you do your hello sign or you can get all that. अगर वो नहीं भी करते तो आप देखेंगे कि जो पेशेंट्स को साइलेंट GCA होता है वो साइलेंट GCA को आपने ट्रीट करना है, एंड ट्रीट करने से उनकी स्टीरॉइड की डोज बहुत कम हो जाती है. एंड इफ यू लुक एट द ब्लू लाइन एंड द रेड लाइन यू कैन सी हाउ मच डिफरेंस इट इज़ बिटवीन द रिलैप्स रेट. अच्छा जी, ग्लूकोकॉर्टिकॉइड हर एक बंदा पूछ रहा है, अभी दे तो दिया, अब इनके से करना क्या है? भाई जो दिल कर रहा है करो तो बिकॉज ये तो देना ही है. सो आपको पता है कि देर आर यूलार की डिफरेंट क्राइटेरिया है, ACR के लोग डिफरेंट कर रहे हैं, जर्मनी के लोग डिफरेंट कर रहे हैं. आपने शुरू कर लिया, आपको पता है कि पेशेंट को क्लिनिकली भी फॉलो करना है, ESR CRP भी देखते रहना है, और फिर फाइनली व्हेन पेशेंट इज गेटिंग बेटर देन यू टेपर द स्टीरॉइड्स रैपिडली बाय 10 milligram every week, and then once you reach 15 or 20 then आपने slow होके taper करने हैं, so that when they reach 10 milligrams then very slow like 1 milligram, because they have to be continued on it for almost a year, maybe some people require more. आपको पता होना चाहिए कि what are the side effects. You all know this, osteoporosis है, hypertriglyceridemia है, और infections है, और ये सब कुछ है. we have to watch that. हाई रिलैप्स रेट्स बहुत ज़्यादा है दोनों डिजीज़ में, 43, 50. सो वी हैव टू वॉच फॉर हाई रिलैप्स. अच्छा जी, बड़ी ट्रीटमेंट आ गई हैं, हमारे पास नहीं आती हैं लेकिन कुछ ना कुछ तो हमारे पास भी है. So tocilizumab to hai, so it's already approved for treatment for GCA alone. Right now, few studies saying maybe PMR. Serilimumab की बात नहीं हो रही, वो PMR के लिए approved है. But we have on the horizon upadacitinib, which almost trials are completed, and we have secukinumab. We saw that IL-17 inhibitors and जो हैं वो कितने ज़्यादा टेम्परल आर्टरी की वॉल में प्रेजेंट हैं और टी सेल्स और मैक्रोफेज एक्टिवेशन कितनी ज़्यादा हो रही है. तो इसके फेज 2 ट्रायल्स हो चुके हैं and you can see the difference, the blue line and the yellow bar, which determines the safety and efficacy of secukinumab in patients with giant cell arthritis. So अब केस पे आ जाएं प्लीज़. क्या करना है? अच्छा पहले प्लीज़ पहले पीजीज एंड हमारी यंग फैकल्टी क्या करेंगे पेशेंट के लिए? ABCD जल्दी से बताओ, क्योंकि आज ने कोई आप लोगों को गुड और कोई? अब मैंने तो जवाब बता ही दिया. What is the test which has to be ordered? Which is the test to be ordered? What are you thinking about? Quick, हमारे पास टाइम नहीं है, पर्चियाँ आनी शुरू हो गई. 5 मिनट है. थैंक यू जी. बैक पेन हो रही है उसको. अच्छा, so basically you will order what? Because you are suspecting aortitis. So this patient can have isolated aortitis also, but we saw that Venn diagram, they all overlap. So you देखें कितना आपको vigilant रहना है इस patient के साथ. It's amazing. It amazes me कि rheumatology कितनी exciting है. So summary कुछ करने की ज़रूरत है. So हमें पता होना चाहिए कि it's a spectrum, it overlaps. Rapid initiation will save the vision. Rapid diagnosis, so very important, and we should think about fast tracks. And there are, I think Upeda is an oral drug and people would love it. And similarly, we have secukinumab. So, भाई, eyes cannot see what the mind doesn't know. ये बात तो अगर पहले 100% थी, अब 500% है. तो and success comes with passion, जो कि आपके teachers और mentors में था, and hopefully it has transferred into you as well. Great sacrifice सबने दी है, great team work, मेरी टीम ने बहुत दी है. सुमायरा बैठी हैं, अहमद बैठे हैं, then Saira, Rafaqat, and mashallah so many of them, and obviously all the hospitals, Shaikh Zayed. So we have now different teaching hospitals having rheumatologists, और सबने sacrifice दी है. Hello, women ने ज़्यादा दी है, और मेरी फैमिली ने भी काफ़ी sacrifice दी है. मेरे काफ़ी grandchildren हैं, और वो कह रहे हैं कि आप हमें भी थोड़ा सा टाइम दें. So give time to your family, and thank you, and see you at PSR. Thank you so much.
Thank you so much, ma'am, for sharing your expertise with us today. The last speaker of this second scientific session is Dr. Tahira Parveen, who is a renowned consultant rheumatologist and the head of Department of Rheumatology Department at Liaquat National Hospital, Karachi. Today, Dr. Tahira will share her valuable insights on biological therapy in pregnancy in rheumatology. Please welcome Dr. Tahira Parveen on stage.
Assalamu alaikum. Again, it happened with me before. I was between the audience and the lunch. So it is happening again. Bear with me. I'll try to, move faster. My talk is not that comprehensive. I tried to be focused to the biologics only during pregnancy. And it is the talk of the day, topic of the day, because we know, so when I start, there is no disclosure, and I will talk a little about physiology of placental transfer of biologics. Beta thoda side pe ho jana, I forgot to bring my glasses up. And biologic drug-induced maternal and infant immunological changes and evidences and recommendation. So when we talk about systemic autoimmune rheumatic diseases, thank you so much. We know that it's the disease of women, especially the women of childbearing age. So it's normal and it's our daily routine that we see the patients who are pregnant or planning pregnancy and they've got diseases that are uncontrolled or not completely controlled. So we know that systemic autoimmune diseases, they can flare the pregnancy and they can negatively have an impact on the disease activity of the pregnancy and can alter the outcome of pregnancy at the same time. Therefore, it is crucial to have the disease controlled throughout pregnancy and even before the conception as well. At the same time, we face problem with the conventional DMARDs. Many a times, we are unable to control the disease activity with just conventional DMARDs, so biologics are imperative. So most of the biologics which we are using currently in the autoimmune conditions are immunoglobulins. They are either fully monoclonal antibodies or antibody fragments. IgG1 is the most experimented and clinically used IgG subclass in biologic development, and the switch from chimeric to fully human antibody has improved the safety and tolerability of the mAbs. When we talk about the transport of immunoglobulins across maternal barrier to fetus, IgG and low levels of IgA are the only antibodies that get transferred from mother to the fetus. In early pregnancy, there is insignificant transfer through passive transfusion, passive diffusion, but later on there is a process through which they get transferred and the level of immunoglobulin increase steadily in the blood of the fetus. It is supported by different type of receptors called FC receptors and FC placental receptor, which is gamma. It promotes, I will tell you on the So these are the mAbs or immunoglobulins. They get attached to the FC receptors in the endocytes of the placental syncytiotrophoblastic layers, and these endosomes, they then transfer this complex across the layer and then into the fetal circulation. So here we can see that even if the biologic levels stay stagnant or normal in the maternal blood, they continue to rise by the end of second trimester, and then they reach to their peak at the time of the birth. So we know that the antibody formulations, by this cartoon, we could see that for, the antibody formulation lacking FC portion, like certolizumab, are less readily transferable IgG classes. Therefore, they are considered relatively safer during the pregnancy. Now we know at the same time that pregnancy itself is a complex immunological condition. There are changes in the human body. At the same time, these systemic autoimmune rheumatic diseases, and if the patient is using biologic therapy, the changes are further complex, and it is considered as an immunocompromised state leading to the susceptibility of various infection. So administration of biologic drugs causes an increased burden on the body and the immune system. But at the same time, there is insufficient data which covers this level in the women, but there is sufficient data in infants, especially about infliximab and adalimumab. They have checked the cord blood level of these drugs, and they found that infliximab was higher in the cord as compared to adalimumab. The reason we have already learned, while the level of the certolizumab, etanercept, and eculizumab were negligible. Most drugs with high levels at birth persisted for a couple of months, but then they subsided or vanished from the fetal or neonatal blood by themselves. There was also harmless, reversible, low infant total and B-cell lymphocyte count was identified, which was considered to have a negative impact on the vaccination course after rituximab and belimumab. This was a very good paper which was published in 2017. It showed the effects of pregnancy on pharmacokinetics, kinetics. Now, Interestingly, when I looked into the papers which were published about the biologic safety and efficacy during pregnancy, most of the papers were published by gastroenterologists related to inflammatory bowel disease, because we know that TNF inhibitors are very much in their use as well. So when they measured infliximab and adalimumab blood levels in 25 patients of IBD, they found that there was increased level of infliximab in the blood during pregnancy, and it was an unexpected finding. They had to stop infliximab due to increased risk of infections. Another paper Assalamu alaikum, Pakistan. I'm sorry, but I expect, and the people who have traveled from other part of the Pakistan, at least they expect that you respect their presence and their efforts. Thank you so much. So this is the paper which was published in 2014. It was again anti-TNF impact if administered in pregnant women with IBD. 25 children were exposed and 80% were also breastfed. 7 children only had mild decrease in immunoglobulin level, IgA and IgG, without any clinical signs. There was a relatively higher risk of upper respiratory tract infection, but it happened long after the clearance of those antibodies of the drug. Another paper, it was a good large paper from a French cohort, Evasion, which considered 1,500 anti-TNF exposed pregnancies as compared to 10,000 non-exposed patients. Maternal infection rate was much higher in the exposed patient as compared to non-exposed people. When we talk about tocilizumab, this analysis, it was published by Roche, post-marketing analysis. They divided the group into 2, retrospective and prospective pregnancies. 180 prospective pregnancies, they resulted in about 60% live births, 21% spontaneous abortions, and there were malformation as well, 4.5%. So it was pretty dangerous data actually. And the retrospective data was much worse than that. 50% had live birth, which is much lower, and 28% had spontaneous abortion, and fetal malformation was in 3 infants. While the fathers who were exposed to tocilizumab before pregnancy, the fetal outcome was normal. Again, rituximab, they showed a systematic review and case series in which 78 resulted in live birth and 12 spontaneous abortions if the pregnancy was exposed within 6 months of conception. B-cell count was lower in 39% of the newborn and normalized within 6 months. Case series of 11 patients showed uneventful pregnancies. So this was the hard part actually to listen to. When we come to evidence and recommendation, a very encouraging data in which about 5,000 women with childbearing age of rheumatic diseases and IBD who were exposed, out of which 1,000 patients who were exposed to biologic at some stage of their pregnancy, they had comparable live birth in both the groups, but the patients who were exposed to biologics, they had higher rates of IUGR, preterm delivery, preeclampsia, and C-sections. Another data which showed that comparable pregnancy outcomes in patients who had disease matched control and chronic inflammatory disease-free pregnancy through GRADE approach. So these 2 studies were a little encouraging as compared to before. We know that we have to talk to our patient about preconception counseling every time they visit us, even if they tell us they are not planning pregnancy, but every time many a times. At least it happened to me. Today I counseled them, started with a teratogenic therapy, and in the very next visit, they gave me the khushkhabri of pregnancy. So, I mean, I don't know who's to blame here, but we have to, keep telling them that it's not going to happen. You should be avoiding this, but yes. So we know that if the disease is under control at the time of conception, the outcome of pregnancy and the patient's disease and patient life would be favorable. I'm just going to briefly talk about the British Society of Rheumatology guideline, because they are the latest one, published in 2023. They said almost the same thing for most of the drugs. TNF inhibitors can be continued throughout pregnancy, especially if the disease is not under control. But if it is in remission, you can consider stopping infliximab at 20 weeks, because we learned that the blood level in the cord was higher as compared to other TNF inhibitors. Adalimumab and golimumab should be stopped at 28 weeks. Etanercept can be continued till 32 weeks. Neonatal vaccination, if the patient is exposed throughout the pregnancy, then avoid live vaccine till 6 months of the age after delivery, and vaccinate on schedule with non-live vaccine or rotavirus. They are compatible with breast milk exposure. For rituximab, there is limited data available which showed that they are teratogenic, but again, there is insufficient data that can make us confident that it is compatible with the pregnancy. It should be stopped before pregnancy, before conception, but in case you do not have any other option available to control the disease, yes, the patient's life is more important than the pregnancy. If the patient is, if the fetus was exposed to rituximab in 3rd trimester, then no live vaccine till the 6th month of age, and she can breastfeed the child. For tocilizumab, there is limited data which shows that it is teratogenic. At the same time, insufficient data to make us confident. And again, it can be considered if there is no other safer option available during pregnancy. However, we know that during pregnancy, its exposure will be harmful to the fetus. When to stop? Consider stopping before conception. Again, if used throughout the pregnancy, you have to delay the vaccination till the age of 6 months. This goes with all the coming drugs now for IL inhibitors, anakinra, canakinumab, belimumab, secukinumab, ixekizumab. All of these, they do not have sufficient evidence that they are teratogenic, but at the same time, they do not have sufficient data that they are safe during pregnancy. So in special circumstances, we can use them to save the patient's life. For tofacitinib, because it's a newly launched drug, again, we have insufficient data to make any recommendation during pregnancy. They should be stopped at least 2 weeks before planned conception, and there is insufficient data to JAK inhibitor in breastfeeding, and given that they are likely to be transferred in breast milk, so they should be avoided during breastfeeding. Now the key points are the same. With regard to biologic therapy used during pregnancy, individual drug effectiveness and transplacental transfer should be taken in consideration. All anti-TNF inhibitors are safe during pregnancy. Other drugs, they might be effective for treatment, but they should be avoided. Very limited data is available for tocilizumab and other MABs, and non-live vaccine should be avoided in patients 6 months after the birth if the pregnancy was exposed to these biologic during pregnancy. Minimal transfer in breast milk is found for various drugs, but again, TNF inhibitor biologic DMARDs are safer than non-TNF inhibitor biologic DMARDs. Treatment with the following drugs is considered, has not demonstrated any clinical relevant impact on fertility or pregnancy outcome, and can be continued in male patient trying to conceive. This applies to all the drugs you have, these are listed here from methotrexate till mycophenolate, but you have to consider the pros and cons. Thank you.
Thank you so much, ma'am, for this enlightening talk. Now let us proceed towards the end of session panel discussion. If there are any questions from the audience, you can ask them now. Any questions, please? Please. Okay. Please give the mic to the sir. What did we hear?
I'll take question. Sir, thanks for a very, very explanatory and very beautiful presentation by you, sir. Sir, my question is on biologics. Hello. Biological drugs comparison with the tofacitinib and upadacitinib. Are there any head-to-head trials which are going on? Because as such, there is no published data yet. Second question is radiological progression. Is there JAK inhibitors, do they stop or halt the radiographic progression or not? One thing I want to share, I have seen that when we prescribe these drugs to SPA patient, when we stop the drugs, when patient misses some dosages of the drugs, patient restart having the same symptoms of pain and etc., etc. And what is your experience in this regard? Kindly, three parts of my questions are radiological progression, or do tofacitinib and JAK inhibitors halt or not? And one is head-to-head trials.
Okay, so first, like coming to head-to-head comparison between different class of drugs. This is one area in which most of the pharmaceuticals, they do not actually enter into, and that's why we have to have registry data. So registry is a real-world experience, and then there is always a way of comparing it through comparing their results of their randomized clinical trials, which is what exactly people do most of the time. So, and as such, I'm not aware of any head-to-head comparison between tofacitinib and any one of the biological agents in terms of expa. But I did share a SURPASS study, which was IL-17 inhibition with adalimumab, which was looking at radiographic progression, which actually shows promising results, which meaning by that the MSAS score over 2 years was less than 2 in both groups. Meaning by if you would suppress inflammation, no matter whether it's IL-17 inhibition or anti-TNF, both would work. Same was with infliximab alone. We don't have, as of today, data with any of the JAK inhibitors long-term on radiographic progression, because you know that radiographic progression studies require at least 2 to 5 years data. And most of these drugs, they got just FDA registration for upadacitinib came 2023 and 2021 for tofacitinib, so too early to now comment on the radiographic progression part. And the third question, which I have forgot, so was about how to taper. JAK inhibition, there is some analgesic effect as well. Honestly speaking, just missing a couple of days to a week leads to flare in rheumatoid arthritis. And same applies in my clinical practice with expa patients. Because half-life of generally a biologic, which we use like etanercept, is like 1 week. So patient may be having a flare if skipping 1 or 2 dosages. But something which they have to take twice a day means that the half-life is like 12 to 24 hours. So this is very likely that disease is going to flare within a week or so. They have to be on regular treatment. When you are evaluating for measuring their disease activity. They shouldn't be skipping their dosages in the last preceding days. This is my message, because I'm telling you that their flare can happen as early as 3 to 4 days if they have skipped their dose. Because today I just shared the data on EXPA with you people. So inactive disease was seen in around 20% of the patients. 60% of the patients had met the target of low disease activity as per the SDAS-CRP criteria, 60%. And I am again saying that 40 to 50% of the patients are patients in clinical practice. They are not going to respond to any one of these. That's why there is still room for more and more molecules and research in these areas.
Assalamu alaikum. My name is Dr. Khalil. I am a family physician.
Dr. Khalil, I want to add something to Dr. Ahmed, if you allow me,
yes,
please.
Please.
So I agree with Dr. Ahmed that it seems that we are unable to taper our patient off JAK inhibitors. But having said that, if your patient has been taking regular treatment for a couple of months and is in remission, then you can halve the dose. Like you're giving tofastinib twice a day, you can make it once a day. But for some reason, many of my patients have been on JAK inhibitors since the day that it was launched, like 3 years now, more than 3 years now. I haven't been able to take them off JAK inhibitors, but yes, I was able to reduce the dose.
We have another question for Sir Ahmed. Yes, sir, please.
My name is Dr. Khalil. I am a family physician. I don't have any question. I just have 2 points to make, just 2 suggestions, please. Number 1, you have mentioned the arthritis care clinic. We don't know where it is. It should be made to the public. Number 2, we have sent so many patients to the Behbood Idara or arthritis clinic also. But we find that the procedure is very cumbersome and they are watching the patient very few in numbers. Please make it easier and try to see more patients over there. This is number 1. Number 2 suggestion. It was mentioned that arthritis and arthritis-related diseases would be number 1 in the next 10 years. So we have to reduce it. We cannot produce more FCPS and more professional expert doctors, but we can train our family physicians by giving some workshops, arranging some workshops and certificate courses. And I don't feel ashamed in mentioning that we as family physicians, we are unaware of the basic guidelines, even the basic guidelines, how to diagnose all these diseases which were mentioned here since this morning. So kindly train us as well. Thank you very much.
We have another question, please. Yes, Dr. Mahin.
Thank you, Dr. Khalil, for pointing out this thing that our services across Pakistan, so we need to have a centralized place from where you can have an idea. So one forum is Pakistan Society for Rheumatology website. So you can go and find a rheumatologist in nearby city so that patients can access, healthcare professionals they can access. And we are now around 150 rheumatologists across Pakistan working in academic rheumatology units, which are providing subsidized and free care in government, tertiary hospital, public and the trust sector hospitals as well. The point which you have raised is that foundation, the clinics are at 12B Muslim town, which is close to Shaikh Zayed. And then in this town, at least there are 6-7 academic rheumatology units. So उन सब का बिल्कुल पता होना चाहिए सब फैमिली फिजिशियंस को और रेफरल गाइडलाइंस का भी पता होना चाहिए so that पेशेंट्स का ये जो टाइम लैग है उसको हम कम से कम कर सकें. थैंक यू फॉर पॉइंटिंग आउट दैट.
डॉक्टर खलील, एक चीज़ आपने ज़हन में रखनी है कि फातिमा जिना यूनिवर्सिटी वहाँ पे भी रूमेटोलॉजी क्लिनिक है, डिपार्टमेंट है, किंग एडवर्ड में भी है, शेख ज़ैद में भी है, सेंट्रल पार्क में भी है, फातिमा मेमोरियल में भी क्या कहते हैं, सारे क्लिनिक्स फ्री हैं. ज़ाहिर है वो उनकी जो इनिशियल कोई 50-100 रुपीज़ कॉस्ट होती है फ़ाइल की, बस वो है. अदरवाइज़ इट इज़ अल्हम्दुलिल्लाह वाइड स्प्रेड नाउ डेज़. ओके, सो ये चीज़ है. बाकी जो आपने रिव्यू कोर्स का कहा है वो डॉक्टर अहमद बता रहे हैं कि वो करवाते रहे हैं और हम उनसे कहते हैं कि हम सारे लाइजॉन करके वो दोबारा शुरू कराएं ताकि आप लोगों के लिए एक किस्म की अवेयरनेस और गाइडेंस हो फ्यूचर के लिए. वेल, वेरी एक्सलेंट टॉक्स बाय डॉक्टर हारून, डॉक्टर Dr. Nighat, Dr. Sumaira, and Dr. Ahmed, and finally Dr. Tahira. I have a question from Dr. Tahira that we have been seeing very good data for biologicals. Interestingly, tofacitinib was launched worldwide in 2012, and in Pakistan it was, I think so, 2021. But that nearly 13 years of data we haven't yet, I think so, finalized globally that whether it is compatible with pregnancy, preconception, or in breastfeeding. Why was it so?
I don't think it's justified to ask this question from me, but it might be an industrial gimmick maybe. But as far as I know, that many of my young patients, they conceived on JAK inhibitor. And when they found out, they stopped it, and some of them, I mean, not some of them, all of them had a normal birth of the normal child, but we cannot make it a landmark. It's just an anecdotal experience. But you know how FDA and all these things work, so we better ask them and put an application there.
Thank you so much. So I think so we have been quite late, and it's now time for lunch. We are a bit squeezed for a time. We will give 30 minutes. The lunch is across the exhibition area, and I will request that after around 3:15 we must come back. We have 3 more very interesting lectures, and we are going to go about it. Please, Professor Tafazul, please come to the stage to give shields to the present presentators. Sir, please.
Dr. Ahmed Zayed, kindly come on stage, please. Dr. Tahira Parveen, please come on stage. Thank you so much. Please move towards the dining hall for the lunch break.
interstitial lung disease and connective tissue diseases. ILD is a critical and often life-threatening complication of connective tissue diseases such as rheumatoid arthritis, lupus, scleroderma, and myositis, with a very high morbidity and mortality with a complex diagnosis and management, and it has a huge impact on the quality of life of our patients. Ladies and gentlemen, it is our pleasure to invite Dr. Muhammad Saqib, Associate Professor of Pulmonology at Shaikh Zayed, Lahore, to take the stage at Rheumacon for a keynote lecture on interstitial lung disease and connective tissue disorders, Management Pearls. Please join me in welcoming respected Dr. Saqib to the stage.
Bismillahirrahmanirrahim. Thank you very much. First of all, I would like to thank the organizers for giving me this opportunity to deliver this talk. Today, I'm going to talk on a very important and very needy topic, that is CTD-associated interstitial lung disease. Interstitial lung disease is a common manifestation of connective tissue diseases, and it can, in fact, it can involve many CTDs, but most commonly it includes rheumatoid arthritis, systemic sclerosis, and inflammatory myopathies. CTD-ILD is defined as evidence of interstitial lung disease, which is demonstrated by CT scan when HRCT shows a combination of reticulation, ground glass opacification, traction bronchiectasis, honeycombing, or cyst in the setting of an established connective tissue disease. So before diagnosing a patient with connective tissue associated ILD, other causes of parenchymal lung diseases in CTD needs to be ruled out. And these conditions include infection, drug-induced lung disease, malignancy, idiopathic interstitial lung diseases. So now I am going to discuss these entities one by one. First of all, rheumatoid arthritis associated interstitial lung disease. As you all know better that rheumatoid arthritis can involve lung in many different ways. It can cause pleural effusion, it can cause pulmonary nodules, pulmonary hypertension, but interstitial lung disease is most common manifestation of rheumatoid lung disease. Rheumatoid arthritis is one of the most common CTDs in Western world, especially in the United States. It is seen in 0.5 to 1% of population. If we talk about prevalence of interstitial lung disease in rheumatoid arthritis, it is seen in, according to different studies, from 10 to 50% of the patients with rheumatoid arthritis may develop rheumatoid-associated interstitial lung disease. So, risk factors. The risk factors to develop rheumatoid-associated interstitial lung disease include more severe rheumatoid arthritis, high C-reactive protein, male gender, elderly patients, patients with obesity, history of cigarette smoking, those patients who have severe extra-articular disease, and exposure to fine particulate matter. The most common histopathological pattern among the patient with rheumatoid-associated arthritis, ILD, is usual interstitial pneumonia, and other common histopathological pattern is non-specific interstitial pneumonia, while other pathological patterns like organizing pneumonia, lymphoid interstitial pneumonia, or diffuse alveolar damage, these can also occur, but these are rarely seen in patients with RA-associated ILD. Most common pattern is UIP or NSIP pattern. Now, talking about the clinical presentation. Symptoms of rheumatoid arthritis-associated ILD typically include insidious onsets of dyspnea and non-productive cough, while fever, chest pain, and acute symptoms are usually less common. They may occur when patient is having an exacerbation, but usually these symptoms are less common. Differential diagnosis of RA-associated ILD include ड्रग-इंड्यूस्ड लंग डिजीज. ऐसे कोई पेशेंट ऐसी ड्रग ले रहा है जिसके साथ रूमेटॉइड लंग में इंटरस्टिशियल चेंजेस आ सकते हैं, लाइक मीथोट्रेक्सेट, इन्फेक्शन, हार्ट फेलियर, recurrent gastroesophageal aspirations, malignancy, and idiopathic ILDs. So before labeling a patient with RA-associated ILD, we have to rule out these entities. So how to reach the diagnosis? The diagnosis of RA-associated ILD is generally based on combination of clinical presentation, pulmonary function test, high-resolution CT scan findings. Lung biopsy is rarely needed, and if it is required, it only in selected patients. These lung biopsy usually performed when patient present with a rapid progression, fever, predominance of ground glass opacification, and before going for a lung biopsy, one should perform bronchoscopy and take bronchoalveolar lavage sample to rule out any infection. So this is a chest CT, which is basically showing NSIP pattern, which shows ground glass opacification, reticulation, interseptal thickening. So this is NSIP pattern with predominance of ground glass opacification. इस पैटर्न को देखना ट्रीटमेंट के लिए बहुत इम्पॉर्टेंट है, इसको समझना ज़रूरी है. This is another pattern. This is called UIP pattern. Here you can see patient is having honeycombing stack of cysts, छोटे-छोटे cysts की stack बन जाती है, peripheral, subpleural, basal, और इसमें आप देख रहे हैं कि इसमें ground glass opacification कम है, इसमें cellularity कम है, fibrosis हो चुकी है. तो this is another pattern which is called UIP pattern. So दो pattern HRCT में commonly देखे जा सकते हैं. अब next है how to approach for treatment. Treatment is determined by severity of impairment, rate of progression, and radiographic and or histopathological finding. अगर UIP pattern है या NSIP pattern है. So we can stratify RA-associated ILD. For treatment purpose हम उसको divide कर सकते हैं कि mild interstitial lung disease or stable fibrotic disease, more severe or progressive disease without predominant fibrosis, more severe disease with fibrosis, और दूसरा यह है कि worsening of these non-fibrotic and fibrotic diseases despite the treatment. So a patient who are asymptomatic and those who have mild ILD, it means they have mild dyspnea or cough with vital capacity, lung volumes, and diffusing capacity more than 70% of predicted. So in this scenario, it is recommended just a clinical follow-up and surveillance with PFTs. हम PFTs को देखेंगे, HRCT बार बार इन केसेस में नहीं करेंगे. PFT को देखेंगे, अगर deteriorate हो रहा है तो then we can go for HRCT. Similarly, for patients with UIP pattern and stable disease by symptoms, PFT and HRCT, in this case also it is recommended only monitoring, clinical monitoring along with PFTs. While initial therapy for more severe or progressive disease without predominant fibrosis. In this case, anti-inflammatory therapy with steroid-sparing agents like mycophenolate or rituximab rather than an upfront anti-fibrotic therapy. अब इधर एक बात बड़ी इंपॉर्टेंट है कि जो ट्रीटमेंट है इट शुड बी डिसाइडेड बाय rheumatologist एंड pulmonologist, क्योंकि पेशेंट को एक्स्ट्रा पल्मोनरी डिजीज़ भी है तो जिसको rheumatologist बेहतर जानता है, तो इट शुड बी जॉइंट डिसीजन बाय rheumatologist एंड pulmonologist. और दूसरी एक बहुत इंपॉर्टेंट पॉइंट है कि देयर आर नो गाइडलाइंस नहीं है इनको ट्रीटमेंट की. देयर आर डिफरेंट केस सीरीज़ जिसकी बेस पे ये ट्रीटमेंट वो जो है अवेलेबल है. इनिशियल थेरेपी फॉर मोर सीवियर और प्रोग्रेसिव डिजीज़ विद प्रीडोमिनेंट फाइब्रोसिस, जहाँ पे फाइब्रोसिस नहीं है वहाँ पे आपने एंटी इन्फ्लेमेटरी दे रहे हैं. एंड व्हेन पेशेंट डेवलप्स फाइब्रोसिस, in that case the choice should be guided by total immunosuppressive burden engendered by add-on therapy, the need of additional immunosuppression to treat extrapulmonary disease, and the extent and progression of pulmonary fibrosis. ये वो चीज़ें हैं जिनको हमने देखना है before initiation of any therapy. So in this case, either addition of a steroid-sparing agent or initiation of antifibrotic therapy with nintedanib, rather than an expected management or treatment with glucocorticoids alone. वो patients who are younger and presents with a worsening of symptoms, PFTs or HRCT over preceding 3 to 6 months, they are going to be benefited by anti-inflammatory therapy. जो लोग यंग हैं उनमें अगर आप एंटी इन्फ्लेमेटरी देंगे तो वो बेनिफिट होंगे, अदरवाइज आपको nintedanib का यूज़ करना है. Few words about nintedanib. Nintedanib, it is an tyrokinase inhibitor which shown effective against IPF treatment. It is approved by FDA based on results of in-build trial for all patients with progressive fibrosing interstitial lung disease. But the cost and side effects and other thing is availability may limit the use of nintedanib. पाकिस्तान में उस तरह freely अभी available नहीं है nintedanib, unfortunately. Indication of nintedanib, इसमें मैं थोड़ा बताना चाहूँगा. Fibrosing interstitial lung disease, which include CTD-ILD, with one of the following criteria in prior 24 months. A relative decline in forced vital capacity more than 10% of predicted value, or a relative decline in forced vital capacity of 5 to 10% and either worsening in respiratory symptoms or increase in extent of fibrosis on high resolution CT chest, or worsening in respiratory symptoms and increase in extent of fibrosis on HRCT. तो इनमें से अगर कोई भी एक present हो along with fibrosing ILD, these patients are candidate to receive nintedanib. Initial therapy, next, initial therapy for fulminant disease. For patients who present with fulminant interstitial lung disease after excluding infection and drug-induced lung toxicity, so it is recommended to start the initial high-dose systemic glucocorticoids. Adjunctive therapy includes cyclophosphamide and rituximab, which may be used in addition to glucocorticoids on case-by-case basis. Next group is if patient develop worsening of non-fibrotic ILD despite initial therapy. So in this case, typical approach is add or change the disease-modifying anti-rheumatic therapies. While patient who develop progressive fibrosing interstitial lung disease despite initial therapy, in this case, either we have to add, if patient is not getting nintedanib, we have to add nintedanib along with anti-inflammatory drug. So next step is how to monitor the treatment with these drugs. Monitoring of the disease activity includes clinical assessment of the patient, HRCT chest, pulmonary function test, and surveillance of the adverse effects of immunosuppressant therapies. Now, prognosis of RA-associated ILD. Risk factors of disease progression and mortality include older age, UIP pattern on histopathology or chest imaging, decreased pulmonary function, and acute exacerbation of interstitial lung disease. These are the factors which lead to poor prognosis of RA-associated ILD. So this is all about RA-associated ILD. Next entity is interstitial lung disease, which is associated with systemic sclerosis. Pulmonary involvement occurs in about 80% of patients with systemic sclerosis. Interstitial lung disease and pulmonary arterial hypertension are most frequent and major types of lung involvement. The prevalence of interstitial lung disease approaches 50% of patients with diffuse cutaneous systemic sclerosis. Risk factors to acquire systemic sclerosis associated interstitial lung disease include positive anti-SCL70 antibodies, black race, or higher skin score. Early systemic sclerosis associated ILD may be asymptomatic, but common symptoms of this ILD include fatigue, shortness of breath, and dry cough. Chest pain is usually infrequent and hemoptysis is rare. So diagnosis, as other ILDs, the diagnosis of systemic sclerosis ILD is established on the basis of clinical presentation, HRCT findings, and usually lung biopsy is not required to reach the diagnosis, and we have to exclude the other causes which may cause interstitial lung disease. HRCT findings in systemic sclerosis typically shows NSIP pattern. As I mentioned earlier, NSIP pattern means patient is having ground glass opacification, interseptal thickening, and reticulation. But if patient have more advanced disease, reticular opacities increase, and patient may develop traction bronchiectasis, which result in volume loss. So these are few features which are associated with increased likelihood of disease progression in systemic sclerosis. So it includes the disease duration less than 4 years, diffuse cutaneous systemic sclerosis, pulmonary function test which include forced vital capacity less than 65% are predicted, and DLCO of less than 55% are predicted, while interstitial lung disease affecting more than 20% of the lung, and patient have anti-SCL70 antibodies are positive. So these are features which are associated with disease progression in systemic sclerosis. Now treatment. For the patient with systemic sclerosis associated ILD who have respiratory symptoms, abnormal or declining pulmonary function test, and imaging evidence of ILD with no evidence of acute infection, treatment is recommended with mycophenolate mofetil as an initial therapy. Tocilizumab and cyclophosphamide are reasonable alternative in some selected patients where mycophenolate cannot be given. Mycophenolate is administered orally, gradually in increasing doses to enhance the gastrointestinal tolerance, with a target dose of 1.5 to 3 gram daily in 2 divided doses, while tocilizumab 162 milligram weekly by subcutaneous injection. If we administer cyclophosphamide, it is administered via monthly intravenous injection for 6 months or via daily oral dosing for 12 months. The duration of mycophenolate mofetil is not well established in patients with systemic sclerosis associated ILD. Maintenance treatment is continued usually at least for 24 months and often for several years. For those patients whose disease shows progression despite the above measures, it is suggested to add nintedanib in the treatment or rituximab in ongoing therapy. Next common condition, connective tissue disease, which may cause interstitial lung disease, is dermatomyositis or polymyositis. ILD occur approximately in 60 to 80% of patients with dermatomyositis and polymyositis. Disease may present as chronic and slowly progressive or acute with rapidly progressive disease. Several histological patterns are usually same. इनमें जो RA associated ILD है वहाँ UIP ज़रा common है, बाकी जो types है वहाँ NSIP common है, UIP rarely है in these conditions. So NSIP is most common, followed by organizing pneumonia, then diffuse alveolar damage, and rare one is usual interstitial pneumonia. Clinical presentation is also same like all other interstitial lung disease. It includes shortness of breath, non-productive cough, or some patients may remain asymptomatic in early course of the disease. Diagnosis, as in other CTD-associated ILDs, is based on clinical presentation and on HRCT imaging. Lung biopsy is rarely required. So if patient is having mild disease, in that case only required observation and serial PFTs. But if patient has a progressive disease, in that case we have to start treatment with prednisolone, 1 milligram per kilogram body weight, and maximum daily dose up to 80 milligram. For patients with rapidly progressive disease leading to high oxygen requirement, like patient presents in emergency with an oxygen demand of 10 liters per minute and may need ventilatory support, in this case it is recommended to addition of intravenous immunoglobulin to high dose intravenous glucocorticoids due to rapid onset of action. और इसमें फिर ऐड ऑन बाद में रोटिक्सिमैब एंड साइक्लोफॉस्फामाइड और टोसिलिज़ुमैब आप कर सकते हैं एज ए स्टीरॉयड स्पेयरिंग एजेंट्स. अब मुझे ये एक मिल गया कि 5 मिनट्स रह गए, मैं जल्दी कुछ आपको ये बता दूं कि SLE में भी पेशेंट मे प्रेजेंट विद इंटरस्टिशियल लंग डिजीज़. इसमें भी कॉमन पैटर्न NSIP है, UIP इसमें भी रेयर है, और ट्रीटमेंट ऑफ चॉइस स्टार्टिंग विद प्रेडिसोलोन, और अगर उससे रिस्पॉन्स नहीं कर रहा तो देन वी हैव एन ऑप्शन टू ऐड एजोथाइप्रीन, माइक्रोफिनोलेट एंड रिटुक्सिमैब. इफ ILD इसमें रेयरली UIP पैटर्न में जाता है SLE एसोसिएटेड ILD में, बट इफ पेशेंट वेल UIP पैटर्न और फाइब्रोटिक NSIP, इन दैट केस वी कैन ऐड निंटेडिनेब इन दोज पेशेंट्स. ये मैं 2 स्लाइड ज़रूर शेयर करना चाहूँगा. एक टर्म है इंटरस्टिशियल नमूनिया विद ऑटो इम्यून फीचर्स. कई मरतबा हमारे पास पेशेंट आते हैं और हम कह रहे होते हैं कि जी ये पेशेंट जो है ना, ये तो र्यूमाटोलॉजी वाले देखें, ये तो इसमें है र्यूमाटोलॉजी, लेकिन वो उसके ना डायग्नोसिस से इसके क्राइटेरिया पे फिट ऑन नहीं होता. तो अमेरिकन कॉलेज ऑफ थोरेसिक, अमेरिकन थोरेसिक सोसाइटी और यूरोपियन रेस्पिरेटरी सोसाइटी ने दे हैव launched another term, that is interstitial pneumonia with it autoimmune features. So this is a different entity which is not fit in rheumatoid associated or CTD associated ILDs. So the term allows to standardization of diagnosis so that these patients can be further studied. NSIP and UIP are the most common radiographic patterns in these patients, and treatment decision are based on clinical evaluation, as there is no randomized clinical trials of treatment of this population. ये एक टेबल है जिसमें वो कॉमन मेडिसिन है, स्टीरॉइड्स, माइक्रोफिनोलेट, एजोथाइप्रीन और टोसिलिज़ुमैब, जो हम कॉमनली यूज़ करते हैं टू ट्रीट द पेशेंट विद CTD एसोसिएटेड ILDs. So few adjunctive therapies ये सब ILDs में कॉमन है, लाइक ऑक्सीजन थेरेपी. जो पेशेंट ILDs के साथ होते हैं, एट सम टाइम दे मे रिक्वायर ऑक्सीजन थेरेपी. एनी पेशेंट हु इज़ नॉट मेंटेनिंग सैचुरेशन at room air or after exercise or during sleep, so we should prescribe oxygen therapy to maintain his saturation around about 88%. Pulmonary rehabilitation is very important. इससे exercise tolerance बेहतर होती है. और last one is vaccination. Vaccination, all the patients with interstitial lung disease should receive annual influenza vaccination along with pneumococcal vaccination, ताकि उनको इस तरह की disease इन्फेक्शन से बच सकें वो, और इनकी एक्सरबेशन ना हो ILDs की. बस लास्ट स्लाइड है. लंग ट्रांसप्लांटेशन. Lung transplant should be considered in all patients with disease that progress despite the therapy. In general, outcomes with transplant in CTD-ILD are similar to outcomes with other interstitial lung diseases. Thank you very much for patient listeners.
Thank you, Dr. Saqib, for sharing your expertise with us. Ladies and gentlemen, it is our pleasure to invite Dr. Taqdees Khalik, a distinguished rheumatologist, to take the stage and share her expertise on auto-inflammatory disorders, a mixed perspective. She is an associate physician at the Federal Government Polyclinic Hospital, Islamabad, and an assistant professor at the NAST School of Health Sciences. Please join me in welcoming Dr. Taqdees Khalik to the stage as she shares her valuable perspectives on this critical topic.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you very much, organizers, for having me here today. It is indeed an honor for me to be present here among the luminaries of rheumatology. So I've been given the daunting task of delivering a talk on autoinflammatory disorders. It is a very extensive topic, as we all know, and I'm sure I wouldn't be able to finish it in 30 minutes' time. ये बिल्कुल उसी तरह है कि दरिया को कूज़े में बंद करने वाली बात है, but I'll try to do my best here. So first things first, let's start with the definition of systemic autoinflammatory diseases, abbreviated as SIDS. So basically, this is a group of diseases characterized by periodic or chronic inflammation secondary to defects in the innate immune system. So they have got nothing to do with the adaptive immune system. That is why we do not find any antibody formation in these disorders, and nor is there any activation of T cells. So far, mutations in 20 genes leading to more than 60 distinct autoinflammatory syndromes have been described. And since these are genetic disorders, they generally have an early age of onset, ranging from first few hours to the first decade of life. Their onset in adulthood is quite rare. And also, since different kind of proteins are involved, the clinical spectrum of these disorders is also quite variable. Now, before I go into the details of individual clinical syndromes, let us revise our knowledge of innate immunity. Let's revise the different pathways that actually mediate the inflammation caused by the innate immunity. So basically, at the center of this whole process is a multi-protein structure which we refer to as inflammasome. There are different kinds of inflammasome in our body. Two of these are shown in this cartoon. One is this NLRP3 inflammasome and another is pyrin inflammasome. So this NLRP3 inflammasome is quite sensitive to cellular damage secondary to infections, toxins, or metabolic disturbances. So once this gets activated, this in turn activates the caspase-1 enzyme system, which in turn cleaves the inactive forms of interleukin-1 and interleukin-18 into their active forms. And we know that interleukin-1 and interleukin-18 are both very potent mediators of inflammation. Second here is the pyrin inflammasome, and this is very sensitive to cytoskeleton problems. So whenever there is disruption in the cell membrane, this inflammasome gets activated, and in turn, it leads to activation of caspase-1 system, and from there is activation of interleukin-1 and interleukin-18, and hence there is inflammation. Thirdly, we see another, this pointer isn't working very well. So thirdly, we see another pathway, this nuclear factor kappa B pathway shown at the end, this protein over here. This is also a multi-protein structure, and its function is to induce transduction of DNA inside the nucleus and formation of cytokines. So once this pathway is activated, different other cytokines are produced, as well as transcription of DNA takes place, and the end result is inflammation in the body. And then we also have certain other pathways like the TNF pathway that we see over here in the left-hand side, and then there's also interferon gamma pathway. So under the normal circumstances, there are also present inhibitory molecules inside the cell that act as a switch-off mechanism, and they ensure that the inflammation is carried on only till the time that it is needed. However, in autoinflammatory diseases, because of genetic mutations, there is either complete absence of these inhibitory molecules, or if at all they are present, they are mutant. So the result is an unchecked and dysregulated inflammation that can pose serious damage to the tissues. So with this background in our minds, let us now move into different categories of autoinflammatory diseases. Now this is just a breather. After such a busy slide, I thought we all deserved a breather. So all who fever are not infectious, and this is basically the theme of my talk. Everybody who has fever does not necessarily mean that they are infectious. There are many other causes of fever as well. Right, so when should we suspect somebody is having SEDS? So the first and the foremost point is recurrent flares of systemic inflammation in the form of fever, rashes, serositis, articular involvement, lymphadenopathy. And all these features must not be attributable to any infectious cause or any other malignant process going on in the body. There should be no plausible explanation for these features. Second clue is, we get the second clue through persistently elevated CRP and ESR, and if available, systemic amyloid A protein and S100 protein can also help us. And then some patients would become absolutely symptom-free in between the flares without taking any medication or without any other intervention. So this this symptom-free period is another clue towards the diagnosis of SEDS. And then most often, there is also the presence of an identifiable trigger such as stress or sleep deprivation, or the child might have had vaccinations or have had some viral infection that has sort of triggered the inflammation in the body. So once we suspect SEDS in a patient, there are certain clinical characteristics that can guide us towards the diagnosis of a specific SED. So first and the foremost is the ethnicity of the patient. So we all know that familiar Mediterranean fever is most common in patients who have Armenian ancestry or who are Turks or Arabs. Similarly, another periodic fever by the name of TRAPS is more common in Western and Northern European children. If we talk about DADA2, this is more common in patients who are from Middle East or from South Asia. Next, inheritance pattern can also help us. Some of these diseases are inherited in an autosomal recessive fashion and some in autosomal dominant fashion. So if a patient has a positive family history of the symptoms in any of the siblings or in the parents, then we should be thinking about autosomal dominant diseases rather than going for autosomal recessive disorders. Age of onset is also very important. Some of these diseases are manifested during the initial first few weeks of life. The best example is SINCA or NOMID or DIRA. And sometimes the age of onset is after the 5 years of age, but less than 10 years of age. So that can also guide us towards a particular diagnosis. Then pattern and length of episodes is also important, as we shall see subsequently. And lastly, there are certain specific symptoms associated with each of these disorders that can help us in making the right diagnosis. So if an infant presents with strokes, we can think of DADA2. If a patient has fever along with very prominent eye symptoms like periorbital puffiness or conjunctivitis, then we should be thinking about TRAPS. Then there are certain patients who present with sensory neural deafness as well. So in those cases, we can think of SINCA, we can think of Muckle-Wells disease, etc. Lastly, type of rash that they present with is also very important. Some of these diseases have urticarial rashes, as we shall see, and some of them have non-urticarial rashes. There can be erysipelas-like rashes, there can be monocytic fasciitis, and with correct identification of the rash, we can move in the right direction. So like I said, there are many ways of classifying these autoinflammatory syndromes. We can divide them into autosomal dominant and autosomal recessive categories. Then we can also divide them into monogenic and polygenic groups depending on the number of genes that are involved. So if we talk about monogenic disorders, we have a couple of famous diseases here. If we talk about polygenic disorders, then again, there's a huge list. These are only some of the diseases that I've mentioned. Overall, we have more than 60 disorders. Just keep that in mind. And lastly, we can also classify them according to their clinical presentation. And this is what I'll be discussing today in my talk. So broadly speaking, we can divide them into 5 main groups. Number 1 is the periodic fevers. Then we have NLRPs, related diseases. NLRPs, if you remember from the previous cartoon, this is the inflammasome. Granulomatous disorders, pyogenic disorders, and then we have a group of miscellaneous other diseases having diverse kind of pathophysiology. So talking about the periodic recurrent fevers, these are called periodic because the inflammation is cyclical. There is a definitive pattern of manifestation of these symptoms. The symptoms last for a specific period of time, and then in between the attacks, there is a specific duration in which they are totally symptom-free. So in this group, we have familiar Mediterranean fever, we have mevalonate kinase deficiency, and we have TNF receptor-associated periodic syndrome, abbreviated as TRAPS. And recently, another syndrome has been included in the group by the name of Bafapa syndrome. I'll be talking about that later in my talk. Although there is no genetic abnormality that can account for Bafapa syndrome, but still, since it shows a periodicity, it has been included in the periodic fevers group. So there are certain clues that can point towards the presence of a periodic fever. First and the foremost, the periodicity of the symptoms, as I've discussed earlier. Then a positive family history is often present. They usually tend to occur in the initial years of life. And then there are certain characteristic accompanying symptoms like rash, abdominal pain, joint pain, mouth sores, and chest symptoms. And all of them always present with elevated inflammatory markers. So if we talk about familiar Mediterranean fever, usually it occurs before 5 years of age. Duration of symptoms is up to 72 hours only. Usually it's 24 to 48 hours. And after that, even if you don't give any treatment to the patient, the symptoms tend to settle down on their own. Attacks, this disease actually also involves the joints. And usually there is a monoarticular arthritis that we see involving large joints of the body, usually hip, knees, ankles, and wrist joints are involved. And the most dreaded complication of this disease is the development of amyloidosis, which is seen in up to 35% of the patients. And this is the highest incidence in any of the autoinflammatory diseases. So the features which are unique to familiar Mediterranean fever are peritonitis. 95% of the patients would present with peritonitis, and this is a key feature. So if a child comes to you with history of fever, which is recurring in a cyclical manner, and it is associated with severe abdominal pain, then you must think of familiar Mediterranean fever. The pain sometimes is so severe that children have been rushed to the OR for laparotomies. And then there is erysipelas-like rash on the limbs in about 30% of the patients. This is also unique to familiar Mediterranean fever. And then incidence of amyloidosis. So if somebody has proteinuria, concomitant proteinuria, then FMF must be thought about. Next, we move on to mevalonate kinase deficiency. Now, this is unique in the manner that the age of onset for MKD is at less than 12 months of age. And the duration of symptoms is 4 to 5 days. First attack is often triggered by the vaccinations. So this is a diagnostic clue. And abdominal symptoms are also very prominent. However, unlike FMF, this is not a peritonitis kind of a presentation. Patients usually have nausea, vomiting, diarrhea, and abdominal pain kind of a presentation. So the clues to diagnosis include age of onset less than 1 year, prominent abdominal symptoms, painful lymphadenopathy, and aphthous stomatitis. Then moving on, we have TRAPS, tumor necrosis factor receptor associated periodic syndromes. And here the duration of attack is much longer than FMF or MKD. The symptoms can last up to 3 weeks. And the distinguishing feature of this syndrome is periorbital edema. And this is not really seen in other periodic syndromes. Other than this, rash, serositis, and myalgias can be present as they are seen in FMF and MKD. And there's often an erythematous patch overlying an area of monocytic fasciitis. So the clues to diagnosis is a longer duration of symptoms lasting up to 3 weeks, prominent eye involvement, and monocytic fasciitis on limbs. Lastly, there is Pfappa syndrome, which is included in this group of periodic fevers. However, it does not have a definitive genetic basis as yet. The usual age of onset is before 5 years of age. Patients get high spikes of fever, which are abrupt in onset and also settle down abruptly. There's a periodicity in the symptoms. The fever tends to occur every 2 to 6 weeks. Along with the fever, there are prominent aphthous lesions in the gingival tissue. And along with that, patients also have enlarged tonsils, cervical lymphadenopathy. So the clues to diagnosis of Pfappa syndrome include periodic fever, recurrent episodes of pharyngitis and adenitis, and this one feature also makes them prone to wrong diagnosis. You know, a lot of them are misdiagnosed as having tonsillitis. They are being treated with recurrent antibiotic courses, and they show lack of response to antibiotics. However, if we put them on steroids, then their symptoms resolve very quickly, and this is a diagnostic clue. And also in Pfappa syndrome, we do not have any systemic features. There are no abdominal features, there are no chest features. So if they are present, then you must be thinking about other periodic fevers. Next, we move on to the second group, which is NLRPs related diseases, also known as cryopyrin associated periodic syndromes. And in this group, the 3 main diseases are FCAS, Muckles-Wells syndrome, and SINCA. And then we also have a newly diagnosed syndrome termed as NLRP12 associated periodic fever, and then there are 1 or 2 more NLRP associated diseases which are included in this group. So the diagnostic clues here would be an urticarial rash. So I mentioned earlier on that certain periodic autoinflammatory diseases present with urticaria-like symptoms, and this group of diseases is one such example. Cold or stress triggers the episode of inflammation, and patients then present with fever, periodic fever, and also with urticaria-like rashes. Basically, this is a spectrum of clinical features. On one end, we have the mildest form of these diseases in the form of familiar cold autoinflammatory syndrome, in which patients only present with skin symptoms and fever. Somewhere in the middle, we have Muckles-Wells syndrome, in which we also have systemic features. And at the other end of the spectrum, we have SINCA or NOMID, which is basically chronic infantile neonatal cutaneous chronic infantile neurological cutaneous and articular syndrome. This is the most severe form of monogenic autoinflammatory diseases diagnosed so far. It is a triad of rash, arthropathy, and chronic aseptic meningitis. They have specific facies and also show intellectual disability. Sensorineural hearing loss is a prominent feature, so audiograms need to be done. They present with daily fever and other multisystem abnormalities. Lymphadenopathy, hepatosplenomegaly are also a feature. If we talk about arthropathy in SINCA, we see that patients present with persistent joint swelling and pain. There is epiphyseal and metaphyseal overgrowth. We can see here that the patella is showing overgrowth, and contracture formation and limited mobility is also quite common. If we talk about neurological symptoms of SINCA, this MRI brain is from a 12-year-old girl, and you can appreciate that there is very prominent cerebral atrophy, and there is also ventriculomegaly. So these children have chronic aseptic meningitis and present with headaches, vomiting, irritability, seizures, ataxia, poor coordination. Along with that, they also have sensorineural hearing loss. Next, we move on to granulomatous disorders. Here again, we have a couple of diseases, but the most prominent of these is the Bloss syndrome, which is basically a triad of non-caseating granulomatous inflammation that we see in joints, skin, and uveal tract. So these patients present with arthritis, uveitis, and dermatitis. The clues to diagnosis include bilaterally symmetrical polyarthritis with boggy synovitis, but mind you, this can confuse the clinicians and they can make a diagnosis of polyarticular GIA. They also have prominent skin involvement in the form of ichthyosiform rash, which is present in about 90% of the cases. And eye involvement is also quite prominent. They can present with uveitis, cataract, or secondary glaucoma. Next, we have pyogenic disorders in which we have Papa syndrome, we have Majeed syndrome, DIRA, DITRA, and a couple of more. So the hallmark of this group is pyogenic inflammation. Patients present with pus formation, either in the joints or in the bones or in the skin. However, if you culture them, there would be no bacterial organism found. So Papa is basically a syndrome in which we encounter prominent skin lesions. Patients can present with pyogenic gangrenosum. Patients can present with prominent cystic acne, and they can have sterile skin abscesses, especially at injection sites. If we talk about arthritis, arthritis is usually polyarticular. Recurring inflammatory episodes resemble septic arthritis. However, if we send the synovial fluid for cultures, there would be no bacterial growth. Next, there is Majeed syndrome, and this is said to be a genetic form of chronic recurrent multifocal osteomyelitis. There are certain points that can distinguish between CRMO and Majeed syndrome, and these are genetic defects. In case of Majeed syndrome, there is a definitive genetic defect in the LPIN2 gene. It has an earlier age of onset. It is associated with congenital dyserythropoietic anemia, which is not seen in cases of CRMO, and also skin involvement in the form of Sweet syndrome can be seen in patients of Majeed syndrome. Next, we have DIRA, DITRA, and lastly, the miscellaneous group of autoinflammatory diseases in which DADA2 is very important. Here patients can present with lacunar strokes, livedo reticularis, and pan-like systemic vasculitis. We can have Candle syndrome, then we have Sevy syndrome, Hoyle-1 deficiency, related disease, etc., etc. So to conclude my presentation, briefly discussing the treatment of autoinflammatory disorders. First and the foremost thing is to identify them and then to treat, and then to focus our treatment on blocking the primary inflammatory pathway involved in each disease. NSAIDs and glucocorticoids play an important ancillary role. There is a definitive role of colchicine in management of familiar Mediterranean fever. Interleukin-1 blockade is effective in disorders mediated primarily through IL-1 beta, including inflammosomopathies, deficiency of DIRA, and TRAPS. In cases of DADA2, we can use TNF-alpha blockade, and in cases which are mediated through interferon, JAK inhibitors have been found to be very useful. These are the complications that can be encountered in patients of autoinflammatory diseases. This is the last slide perhaps, and this gives a clinical approach to patients with suspected autoinflammation. So first you need to suspect autoinflammation, and we have discussed the clues in detail previously. Then you have to recognize the pattern based on the unique characteristics that these diseases carry. Then you can go for genetic testing where available, and lastly, you have to treat them accordingly. Thank you very much for your patient listening.
Thank you, Dr. Taktis. It was a very comprehensive talk on a very difficult subject. Now it's time for a question and answer session. We have completed the talks by the on-site speakers, so we'll be having 5 to 10 minutes for question and answers.
Well, post-lunch, excellent talks by Dr. Saqib and Dr. Taktis. I have a question from Dr. Saqib regarding connective tissue disorders and interstitial lung disease related. No doubt, I have a comment that, Alhamdulillah, at Shaikh Zayed Hospital, we are in very close liaison with pulmonology department and vice versa while treating these patients. And what I have gathered, I would like to ask your experience as well, that at as earliest we identified a patient with a interstitial lung disease and connective tissue disorder, we start the treatment more aggressively, the better the outcomes come, and they are very much earlier outcomes. So what do you think that actually in rheumatology we usually assess the progression or the response to the treatment with the HRCTs? Unfortunately, that is the only domain, I think so, which is present in our setup, especially at Shaikh Zayed, where we can judge it. Otherwise, DLCOs, as well as, it is not available, I think so, in Pakistan, as well as chest X-ray would also doesn't give us a very categoric clue towards the comparison between the treatments.
Sir, thank you very much for a very nice and comprehensive question. Sir, हम HRCT repeatedly नहीं करवाते. We can assess the progression with simple PFTs. हम forced vital capacity को देखते हैं. अगर वो deteriorate कर रही है, तो इसका मतलब है कि patient की disease progress कर रही है, and we have to increase our disease modifying drugs or whatsoever. So we can perform PFTs. HRCT repeatedly recommended नहीं है और नहीं करना चाहिए repeatedly.
Usually after a year or
after 1 year, yes, but not every 3 months or 6 months is not recommended. Or secondly, DLCO, unfortunately available at our setup, even at Shaikh Zayed, but the gases are very expensive, जिसकी वजह से run नहीं हो पाता. Otherwise, machine is available.
Okay. And secondly, the second talk with Dr. Taktis, I think so, that is the challenging horizon for rheumatologists as well, because 60 or more than that, very precisely having mimics of clinically the arthritic patterns, the skin patterns, as well as rest of the CNS involvements, multi-system involvements. I think so that is really a challenge for us to be knowing those diseases, because I have come across multiple times our young rheumatologists identifying, sir, ye to ye lag raha hai hame. So when we recall that, when we go to the literature, the thing starts to emerge that it is like that. Isn't it like that?
It is, because and every day you learn about a new diagnosis, you know, Vexer syndrome, Schnitzler's, and, you know, many other. I think if you ask about my viewpoint, suspecting them is the most important step. Once you start suspecting, gradually you will, you know, start moving around easily. You will start navigating this territory. But if you don't even suspect, then it will be, you know, it will remain an unknown territory. In our setup, we are also challenged because we do not have the genetic testing available freely. Aga Khan is doing it at the moment, but for that, patient has to go to Aga Khan and then they outsource it, and the cost is quite high. I've learned recently that a center in Islamabad is perhaps also doing it, but I've not, I didn't have the time to go and meet them. So I'm not sure what sort of facilities are available there. But for now, Aga Khan is doing it, and not everyone can go there. Not everyone can afford them. So for us, it's a big challenge. But I think for now, even if we start suspecting them, it is a great step.
Step ahead, as well as we may not be treating them overly. We're not over-treating them.
Because there are also mimics, lots of mimics.
Yes, thank you so much.
Now would like to invite Dr. Tafazul on stage to give the guest speaker shield to our respected speakers. Please, Dr. Tafazul. I'd like to invite Dr. Muhammad Saqib to please come on stage and receive his shield. Dr. Taktees Khalid, please come on stage to receive your shield. Our next topic is focused on myositis and overlap syndromes. Myositis is a group of idiopathic inflammatory myopathies affecting muscle tissues, presenting unique challenges in diagnosis and management. Today, we have the privilege of hosting a distinguished guest speaker who will discuss the cutting-edge advancements, promising treatments, and future directions in combating the complex condition. Let's extend a warm welcome to our speaker, Dr. Julie Jason-Pack, renowned rheumatologist and associate professor of medicine at Johns Hopkins University. Dr. Pack directs clinical trials at the Johns Hopkins Myosciences Center and Please note that this is a recorded lecture. Let's invite Dr. Jason Peck.
Well, thank you so much for having me here today, and I'm very excited to present on overlap myositis. Just as an introduction of myself, I'm an associate professor of medicine at the Johns Hopkins Division of Rheumatology. I am also the co-director of the Johns Hopkins Myositis Center and also the co-director of the Johns Hopkins Autoimmunity Center of Excellence. So I'm very excited to talk about overlap myositis today because I feel like I was reflecting that I've been working on this space for some time now. So I will be giving you a journey into what I think overlap myositis is, and we'll have a little bit of a tour through the different types of overlap myositis. So these are my disclosures. And so the objectives of today's talk is to review the most common types of overlap myositis. And hopefully I can convince you that really overlap myositis does exist. And I think it's garnering a lot more attention now in the myositis community as well. And in fact, I have to say there's recent phase 3 clinical trial, even recruiting patients with overlap myositis. So this is very new for us. And I think we're embarking into understanding all types of myositis and not just dermatomyositis or necrotizing myositis. But you'll hear my talk that, there are shades of gray, certainly, which makes it challenging to treat these patients, but also very rewarding. So
another point that I'll be discussing today are some key clinical features of overlap myositis, and lastly, management of overlap myositis. So what is really overlap myositis? And you have to go back and dig into the literature. And I remember doing this many years ago. And really, it's not very well defined, unfortunately. But overlap myositis is thought to be, okay, for sure you need to have myositis and have evidence of muscle involvement as defined by having proximal weakness and abnormal EMG or abnormal muscle MRI or abnormal muscle biopsy, and have another connective tissue disease. And usually that's kind of the most strict definition. Of course, there are many different types of connective tissue diseases you can have. And when you look at the literature, actually, and I did this actually probably now 10 years ago, I remember embarking into this space of overlap connective tissue diseases, especially with myositis. And you can see with systemic sclerosis is actually the most common type of connective tissue disease that's associated with myositis, up to 48%, which is pretty high. The other connective tissue diseases that are commonly associated are lupus, RA, and of course, don't forget about other neuromuscular diseases. And you're going to be asking, what are you talking about? So I'll talk about that very briefly in the next couple of slides. So here is a nice diagram where there are intersections of the different types of connective tissue diseases. And you can see myositis is in the middle. And then, as I said, scleroderma or systemic sclerosis is the most common. And then here you have RA and lupus. And of course, I'm sure I could add other circles, but it's just poorly defined in those areas. This other neuromuscular disease, please don't forget about this group. Up to 10 to 15% in some literature will say that you can actually have concomitant myositis and myasthenia gravis. So for us in the myositis center where I work, so I actually work at both the myositis center and the scleroderma center, but in the scleroderma center at Hopkins, I truly focus on patients with scleroderma who have muscle disease. Those are kind of my patients that I see in my scleroderma clinic. But don't forget about the neuromuscular diseases, because you can have a very challenging situation where someone may have dermatomyositis and myasthenia gravis, and you can't give them high-dose steroids because then you can actually precipitate a myasthenic crisis. So it is very important that if someone has symptoms, predominantly more bulbar symptoms with dysphagia, dysphonia, or fatigable weakness, double vision, all these symptoms of myasthenia gravis, then, and you can also have dermatomyositis, and we've actually wrote a series of these cases in the past. It's important to think about that in a patient who may have significant more bulbar symptoms, even in patients with myositis. Now, you could be like, okay, well, can you have all of these things? Of course you can. You can have like a mixed connective tissue picture. We can have a little bit of features of all of these, including myasthenia gravis. And I have just this type of patient right now who's been really challenging to treat, but she has the definitive high acetylcholine receptor antibodies for myasthenia gravis and lupus and myositis and scleroderma. So I think these can be very challenging to treat. And this is why I think it's actually fun in terms of understanding the disease and exciting to embark into the research space as well. But anyway, this is basically the landscape here of overlap myositis. So I'm going to first talk about RA and lupus in terms of the overlap myositis, but there's not a lot of data, so I'm going to show you here. So these are a really old case series from Brazil, which I thought was a very well done study. It was 220 patients. And again, 18% of these patients with myositis had overlap. And the most common was RA and lupus in this group. And I think we get a lot of these questions from our patients who have two diseases at the same time, with myositis and RA, or myositis and lupus. And they're always asking, is this going to happen in the future, or is this happening at the same time? Or do I have to worry about this, right? If you have someone who's, for example, RMP positive, maybe. Anyway, so in this group, in this study, they found that most of the patients who developed myositis with RA happened simultaneously. But if you had lupus and myositis together, it tended to happen either before or after, about 44%. In this Brazilian cohort, it seemed like there were no differences in mortality or disease relapse. So that was quite interesting. Now, if we solely put a lens on those patients with myositis and RA, This is actually the oldest and largest series in 1984, which is so old, but I thought it gave a lot of insights into what myositis and RA can look like together. And they even had histopathologic findings, and they described this. So at this point in time, there were 31 patients meeting ACR criteria, and they all had RA. But what was the picture of the RA? So the classic clinical phenotype of the patients who had RA were they had active synovitis, but they had a synovitis ESR dissociation, meaning they had dissociation with a number of joints, but high ESR. And then RA-CPK, meaning if they had high CK, it seemed like they had actually seropositive erosive RA. But I think, as you can see here, this is an old study, but it actually is hinting to some other disease states, which I will go into, that you can probably see with myositis and RA. But I like this study, and I want to highlight is there just a lot of people don't get a lot of muscle biopsies in patients with RA and myositis because they're probably already on methotrexate or rituximab, and you're already treating them anyway. But in this group, they actually had patients who had muscle biopsies, and you can see 40% had muscle necrosis. And this is even before a necrotizing myopathy was described in the myositis literature or myositis space. So you can see that when we think about necrotizing myopathy, yes, it's classically associated with anti-SRP and anti-HMGCR, but these overlap patients can definitively, and for surely, obviously, even in 1984, can have significant necrosis on the muscle biopsy. So in their paper, they describe rheumatoid myositis, quote unquote, as having perivascular inflammation with myofibril necrosis. I mean, would love to go back to this paper and look at these muscle biopsies again, because I really wonder if these patients mostly had a necrotizing myopathy. But now, that is the past in the 80s. What about now? So more recent papers, if I really think about a classic patient where I see a patient with myositis and RA, I think the first differential for me would actually be someone who has anti-synthetase syndrome. Because we know that patients with anti-synthetase can have inflammatory symmetric polyarthritis. And these patients sometimes can even be ACPA positive, CCP positive. And so I routinely, if they have inflammatory arthritis, do check for anti-CCP positivity. And it's pretty well known that if you have, based on this cohort of well-defined anti-synthetase syndrome patients from Lorenzo Cavanaugh in Italy, we know that these patients who are ACPA positive tend to have more radiographic damage and things like this. And so they are patients you want to be more aggressive about treating for joint inflammation. So I think currently in the myositis space, I think our heads, if we're thinking about a differential diagnosis of overlap myositis with RA, we're not classically thinking of, a rheumatoid arthritis patient in the RA classic sense, but I think we're probably seeing it more in this anti-synthetase syndrome. All right, so now I'm going to move on to overlap myositis with lupus. Still not that much, and I think the reason is because patients with lupus tend to have so many other organ manifestations that can be driving their disease with the lupus nephritis or CNS lupus. So, but it is something we should really think about. And these patients, a lot of these patients are already on steroids, which make it sometimes harder to diagnose or do a muscle biopsy. So one of the best studies were done by Dr. Sokos in the NIH, published in JAMA 1981. And these were all sequential patients who were admitted to the NIH for inpatient admission over 6.5 years. And I know it's an old study, but I thought it was a very pure and clean study in that they were really looking at consecutive patients. And you can see that these patients, only 8% had muscle involvement. And similarly to the Brazilian study, most of them, 72%, had simultaneous lupus and muscle involvement at the same time. But this is very interesting. And actually one of the senior colleagues who's our chair of the neuromuscular division here at Johns Hopkins has said this to me a lot. And I was like, I don't know if I really believe you, because in the classic sense, perifascicular atrophy is commonly thought to be seen in dermatomyositis. But as you can see here in lupus patients, he described back in 1981 that patients with muscle involvement lupus commonly had perifascicular atrophy without any necrosis. But again, of course, we would like to go back to these patients and see if they met, ACR-EULAR criteria for dermatomyositis as well. Did they have a, Gaucher's papules or not? They don't really describe them at all. So fast forward to now the present time, And what do we know about lupus now, lupus muscle disease? So in 2022, my colleague, Dr. Eleni Tiniaku, looked at the Hopkins lupus cohort with Dr. Andrew Mammon and also Dr. Michelle Petrie, and they looked at the entire Hopkins lupus cohort, and you can see that 7.9% had a myopathy, and their definition was, they had some proximal weakness and or elevated CK or other findings suggestive of myopathic process. And in those patients that they looked at, only 16 had available biopsies, but an overwhelming amount, 50%, had a necrotizing myopathy, just like a patient with SRP or HMGCR. So I think this is important, highlighting again that when you get a biopsy back that says a necrotizing myopathy and they're not SRP or HMGCR positive, we want to do a thorough assessment of determining if someone has actually other connective tissue diseases like lupus or even a rheumatoid arthritis or other connective or scleroderma. And so in these patients who had myopathy, what was the clinical phenotype of these patients? So in the lupus registry, it's very well defined because Dr. Petrie actually captures all of the SLIC criteria. So they were able to go in and say, in those patients had a SLE myopathy, they were more likely to have a malar rash, an odds ratio of 1.67, photosensitivity, arthritis, pleuritis, and also interestingly, if they were double-stranded DNA positive, they were also more likely to have a lupus myopathy and pleural fibrosis, which I thought was quite interesting. So now that's the most up-to-date data that I have for our Hopkins lupus cohort and what lupus muscle disease can look like. What do we know about overlap myositis or myopathy with systemic sclerosis? And I am going to spend a lot more time in this section because of the fact that not only is one of my research interests, but as I said before, it is the most common overlap connective tissue disease in a patient with myositis. So what do we know about overlap muscle disease or myositis with scleroderma? Not that much if you go back. And I have to say, I started doing this research back in, probably 2011. So it's been quite some time. And I remember looking at back all the data and pulling, back then we were still reading like much more paper articles, right, than all these PDFs we have now. And you can see that the prevalence of muscle weakness, which is a more broader definition, was like 5 to 95%. It's just all over the place. But there was a meta-analysis that came out around 2013 that also suggested that maybe about 25% of patients actually have muscle involvement. And again, just like lupus, scleroderma patients can get lung involvement, renal crisis, all these other problems. But skeletal myopathy can actually cause significant complications as well. And so it's important that we really consider this organ manifestation, just like we think about the lungs or the kidneys in scleroderma patients. And again, in terms of the true prevalence, I will go into some of the detail where we look back at our entire scleroderma registry, but we definitely need to come to some type of agreement and consensus in the scleroderma world or even in the myositis world in these overlap patients, like how are we really going to say that someone has muscle involvement? Is it going to be just muscle enzymes, EMG, muscle MRI, or muscle biopsies? And we can have a discussion on that separately later. But one of the first studies that I did actually was back in 2015, but it was started in, I think, 2013. And we finally got this paper published. We took a look at the entire scleroderma database at that time. And because of Professor Wigley, who opened our scleroderma center in 1990, we have a wealth of data. I would say our scleroderma registry is one of the most robust registries in our Hopkins Division of Rheumatology. And so it was such a blessing to be able to look at all this data that's been, truly like mined and collected over many, many years. So basically the purpose of this study was to determine, well, we know that muscle weakness and myopathy is not good to have, but what are the hard outcomes that we can look at to prove to the medical community and to our patients that if someone has myopathy, then they're going to have more severe disability. And what we did was that from 1990 to 2010, we did a nested case control study and looked at patients who had muscle involvement and who didn't. and then also looked at their outcome measure of HAQ-DI, which is the Health Assessment Questionnaire, or a marker of disability index. Now, there's a patient-recorded questionnaire. And what was interesting to us was that for every 1 point of increase in the muscle severity score that we capture in our database, and basically this means 0 means there's no proximal weakness at all. 1 is mild, 2 is moderate, 3 is moderate, and then 4, I'm sorry, severe, and then 4 is you actually require a cane or a assistive device. And as you can see here, for every point of increase, the disability score markedly increases almost like linearly. And you can see 2 to 3 is a marker of very severe disability. And you might say, oh, this is not surprising. But I think, yes, it's not surprising, but it really cements the fact that these patients with muscle disease can have as much disability as someone with severe skin disease if they're not appropriately treated. And I think this is very important so that we can actually institute treatment if we can. So these patients tended to have, what is the clinical features of these patients who had muscle involvement? More diffuse scleroderma, shorter disease duration, more lung involvement, and obviously higher CK values. And then after we published our paper around the same time, there was a Canadian scleroderma cohort. They also have a very robust research registry, and 1,145 patients also around the same time as us reported that these patients also had a higher risk of mortality. And so you can see the survival of these patients much shorter than someone who didn't have muscle involvement. And their definition was a little bit looser. Any elevated CK or physician-reported myositis or myopathy, which I think is fine because sometimes it's hard to capture this. And so this is something I've learned over the years, but in patients with scleroderma, if they're male, then they tend to have more severe disease. And this is something we see in the US. I would love to learn about how it's what you guys see in Pakistan. But these patients, you know, if they're men, they tend to have more poor survival or early diffuse scleroderma. And if they have myopathy, certainly look like impacted survival as well. So setting the background of understanding that these patients have really poor outcomes, more severe disability, potentially mortality, we then took a deeper dive into a second study where we looked at, okay, if we know these patients have a muscle disease and these patients have poor outcomes, what is going on in their muscle biopsies? What is the driving force or the pathogenesis of the muscle disease in these patients? So going into it, we thought, oh, we're going to find just like all this fibrosis, and, you know, because scleroderma patients have so much fibrosis in their skin. But actually, we found a spectrum of muscle histopathology. So it's very heterogeneous, which I think makes it very challenging. But as with my myositis hat on, we know that these patients, if we know what their muscle histopathology shows, like, for example, if they have a necrotizing myopathy, we know that something is treatable. And we can do something about it. Now, I know there is some hesitancy about biopsying patients with scleroderma, but for us, our experience has been very good. They heal well. Even in diffuse scleroderma patients, getting a deltoid biopsy is not a big problem for us. But I remember hearing from my European colleagues that they really tend not to do muscle biopsies. But anyways, that's a different story. But as you can see here through panel A through F, this is patient with a lot of perivascular inflammation. This is actually necrosis of the myofiber. So we did see some patients with the necrotizing myopathy. This is primary inflammation, where there's an inflammatory cell, just like polymyositis. This is perifascicular atrophy here, so just like a patient with dermatomyositis. And this is that fibrosing myopathy group that I'll talk about in more detail, where you see endomesial and paramesial fibrosis. And then also here, these are neurogenic changes. So we also saw some patients who had purely a neurogenic process that was going on in their muscles as well. But we did find that there was a subgroup that was quite interesting that I'll go into a little bit more detail about the fibrosing group. Okay, and so I'm going to talk about that. So what is a fibrosing myopathy? So basically, this is a normal muscle tissue where you do a biopsy, and the myofibers are healthy, and then the nuclei are on the outside. But you can see in this patient with a fibrosing myopathy, and we were the first to actually describe this in a manuscript form and describe their phenotype. But what this was actually, you know, Dr. Fred Wigley had always talked about this, but he actually never had a chance to actually report this. So it was really wonderful for me to work with him as a mentor and kind of bring it full circle and be like, look, we really do have these patients, because we knew we had them every time we biopsied it, but we never just kind of collected all these patients together. And with my research interest in the muscle disease cross-section with scleroderma, we started to see this a lot more because we're biopsying these patients more. But you can see that this thick band of connective tissue is in between the myofibers. Like here, you don't see any connective tissue, but this is normal. And you can see this endomesial and then perimesial connective fibrosis here. And which is very interesting is just similar, there's really a paucity of inflammatory cells. You're not going to see a lot of inflammatory cells similar to a necrotizing myopathy, where in necrotizing myopathy, we don't see a lot of inflammatory cells either. But in this case, this fibrosing myopathy is where we see predominant fibrosis. So what is the clinical phenotype of these patients? Not surprisingly, these patients tended to have more diffuse scleroderma, more African American, more deceased patients, so 62.5%. They tended to have higher elevated troponin, 83.3%, compared to those who had an inflammatory myopathy, and these were all statistically significant. So bottom line, these patients do poorly if you find these patients who have a fibrosing myopathy. And these patients, as you can see, their survival is much shorter at 5 years compared to 18 years in patients who have an inflammatory myopathy. So when you're comparing this inflammatory group to the fibrosing group. What about autoantibodies? Because we do extensive autoantibody testing in all of our patients. And you can see, not surprisingly, these patients, but there was not one specific autoantibody that was predominant. But these patients were tended to have SCL70 positivity, U3R positivity, and commonly an ANA nucleolar pattern, which was all statistically significant. So how do we treat these patients with a fibrosing myopathy? We still don't know. We are trying to collect all of our cases. We've certainly collected a lot more in the past 5 years. And we're working on a paper right now to give an update on the patients that we have collected in addition to these 8 patients that were initially reported in 2017. But a lot of these patients unfortunately died, and 5 out of the 8. And all of them tended to die of non-ischemic cardiomyopathy. And the patients who were living were treated with MMF or mycophenolate and IVIG early on in their course. And one patient was just doing well on MMF, and these patients are still doing well at this time. But I think it is very important to, number one, understand that this fibrosing myopathy exists. And this fibrosing myopathy, I always get this question a lot. Does this happen more late in the disease? But no, these patients had, they had maybe scleroderma for 1 or 2 years, and then they got the weakness, and then we do the biopsy. And so the onset of weakness to biopsy was within 3 to 6 months. This is not a patient with end-stage diffuse scleroderma, 15 years, and then we're doing a muscle biopsy on them, because that would be a totally different story, actually, because then you can say maybe it's because they've had scleroderma for a long time and they have fibrosis everywhere. But no, this is really patients early in their disease getting a fibrosing myopathy and requiring treatment. So since then, after our initial publication, there have been multiple publications that have actually really supported what we've also seen. Of course, there are going to be nuances and differences in what we've seen, and actually very cool studies by Dr. Corallo and Cutolo out of Italy. And at Hopkins, we actually don't do a lot of electron microscopy, but they were able to look at 35 patients with muscle biopsies and who had scleroderma muscle disease. And you can see that they were able to show actually microangiopathy with endothelial cell swelling here. And then they also were able to show in this basement membrane, that thick connective tissue was also thickened. And then this is exactly what I was showing you on the H&E in the slide before. They could also see it on the electron microscopy, extreme high power. And they see the extent of the endomesial fibrosis here. So I thought it was very interesting that they were actually able to do more additional studies and look at the fibroblasts in the muscle And they were able to say, I mean, not the actual fibroblasts, but they were able to show that there was higher expression of TGF-beta, which they believe that was secreted by the perimesial myofibroblast, which was very interesting. And then most recently, fast forward now from 2017, 16 to now, in the most, in the past couple years, is there was actually another multi-center study, not in Italy, but now in Spain, where they basically almost kind of did a similar study to ours, where they looked at patients who had a fibrosing pattern, where they had a lot of fibrosis in the endomysial and perimesial fibrosis, and compared them to patients who had dermatomyositis, but also had scleroderma. And you can see similarly that these patients had a poor prognosis and high mortality, just like our study with the fibrosing patients having more poor survival compared to those who had an inflammatory pattern. But one difference would be is that in their patients, they had more mild disease, but less improvement. And maybe that these patients are different in Spain versus the US. But they did have more cardiac involvement, similar to our patient population as well. So with all that data, I hope I didn't bore you too much. But as you can see, we did recently published a review on all the kind of studies that we've looked at over the past 10 years, with a highlight on the more recent studies in the past 5 years about these patients who have scleroderma and muscle involvement. And I think we would really break it down into this fibrosing group, but of course the inflammatory group is like dermatomyositis or necrotizing, that neurogenic group. And I think these two are like something that I actually learned from my scleroderma colleagues, is that some patients don't have inflammation in their muscle fibers, or they may be globally weak, but they're not specifically proximally weak that we would see in the inflammatory fibrosing group. But if they have significant GI involvement and weight loss and diarrhea from small intestinal bacterial overgrowth, they can certainly have weakness and some muscle disease that is more nonspecific and disuse as well. So how do we treat this? As I told you, we still don't know how best to treat the fibrosing group. But right now, we have adopted a treatment algorithm in our scleroderma center and also in our myositis center that if someone has scleroderma and muscle involvement, we tend to give MMF and then IVIG. And we don't know if this is right. I mean, my goal would be one day to really do a small clinical trial in these patients. And then if that doesn't work, we move on to rituximab. But the key point is that we want to avoid high-dose steroids, not more than 20 milligrams per day for a short time, and not an extended time, I'm sorry, because of the risk of renal crisis. All right, so hopefully I was able to kind of distill what we've published on and learned in the past 10 years. And in the past year and a half to 2 years, I also took a deeper dive with one of my fellows by looking at our entire registry with the following questions of understanding the clinical impact of myopathy and scleroderma, and also really getting a better understanding of the risk of mortality. And so what has happened since 2015 to now is that now in our scleroderma registry, we have a distinct definition of what we think is myopathy in our scleroderma database. Before, we did not have this. It was all going by hand. But since we have this, we're able to identify these patients a lot easier now. And so we looked between 1990 and 2021, and now we recently actually looked up to 2023. And I'm looking back in the past year as well now. But this paper, this culmination of this study is being under review and right now as a manuscript. But our definition of myopathy, again, was that they either had physician-reported history of myositis, because going back to 1990, nobody was actually doing a lot of EMGs or muscle biopsies back then. And then proximal weakness, and with one abnormal testing here, as you can see. And we looked at all the clinical variables for scleroderma. And what you can see here is that these patients, again, is this actually pretty similar representation to the meta-analysis, that about 17% of patients had a skeletal myopathy. And again, the same things come back about where most patients were diffuse, subtype, and African-American, and shorter disease duration at first visit. I do want to say, I think we do have a high number of patients who are African-American in Baltimore, Maryland, and so we probably have a little bit of a bias here. And this is just highlighting what I already told you in a table format. But I do want to highlight again interestingly enough, when I showed you just the patients who had the muscle biopsies, you know, the SCL70 seemed to be more prevalent. But now when we're taking a bigger group, we had to go look at 672 patients and see if they had a muscle biopsy ever done, which took a bit of time, and I'll show you that data. But you can see that these patients, that 672 had muscle involvement, and what that association of SCL70 disappeared. It was, I mean, p-value of 0.06. But centromere here, you can see, seem to be protective in some way. So if you were centromere positive, you didn't get a muscle disease. And again, patients tended to have a higher risk of mortality. And overall, for this table, I would say patients had a greater burden of disease, more cardiopulmonary disease, more GI disease was also seen in these patients with myopathy. And when we looked at these 3,000 patients, we also were able to show that these patients, in regression analyses, in Cox regression, we're able to show that there was an independent risk for death if you had myopathy. And you can see the survival estimates here, much lower, which is very statistically significant in those who had a myopathy. All right, I'm going to change a little bit of corners, but I'm going to connect the dots. So why am I now switching gears and talking about troponin elevation? And I think this is something now really dear to my heart, because I have now learned the hard way about how these patients can actually, because heart is muscle, and I think we forget about that a lot of times because we're so focused on a patient's scleroderma skin and their lung and their obviously kidneys and their Raynaud's and the digital gangrene, but what are they actually dying of is a big question. And this has been always on my mind for the past 15 years. And this study that we looked at was gave us initial insights of why this association with the heart and the muscle may be very important. So in this study, what we wanted to know were what we were seeing, and I don't know if you guys see this in Pakistan, but it would be really interesting to know our patients, sometimes we would check troponin. And we've been checking it for years. And we would see that these patients would have elevated troponin levels. And we didn't really know what to do with it. You know, the lab would be flagged and it would be red, saying it was positive. And we would obviously do the echo and everything looks okay. But we were like, they just have a troponin leak and we're not sure why, obviously. But they didn't have high blood pressures. They didn't have atrial fibrillation. They didn't have heart failure. So we always wanted to understand what were the clinical characteristics of those patients who are troponin positive. So we did a study where we looked at patients who are troponin positive versus troponin negative. And you can see the key features I summarized here. They tended to have more diffuse scleroderma, history of muscle disease, and of course, if they had elevated troponin, they tended to be dead, and the history of renal crisis. But I want to highlight here, we wanted to then ask the question, if you had an elevated troponin, what were the risk factors that preceded that elevated troponin? And we clearly saw that for the odds ratios were much higher if you had a lower age of onset, of scleroderma onset. If you obviously had a coronary artery disease, which makes sense because maybe you were going to have a heart attack and that's why the MI, the troponin elevation happened. If you had low ejection fraction because you had a cardiomyopathy, that's why your troponin was elevated. But again, this comes back to the myopathy history. If they had a history of myopathy, they preceding an elevated troponin, before the elevated troponin, they tended to have skeletal myopathy. And if you look at the muscle characteristics of these patients, they were overall weaker, they had higher CK, and if you had troponin elevation, you had muscle edema on MRI. And you can see, obviously not surprisingly, that those who had elevated troponin tended to have more cardiac events and higher mortality. So why is this important? And now I've actually embarked into another research space, which is already kind of related to the scleroderma muscle and myositis, is that if you go back, there's a high risk of sudden cardiac death. And this paper has been highly cited back in 1993 by Dr. Follansbee and Metzger from University of Pittsburgh. But I think it's been forgotten. And I thought, you know, I read this paper more than 10 times probably now because it's always been on my mind why suddenly my patients would suddenly die in their sleep. Or I would get a call from a family member that, you know, she was doing well, but suddenly she had said she had palpitations and she unfortunately died in her sleep. This is unrelated to pulmonary hypertension. This is truly related to the myocardial disease. And he described this highly malignant form of myocardial disease where you get conduction abnormalities, ventricular arrhythmias, and sudden cardiac death. And the highest risk group were the patients who had, muscle involvement, had this highest risk of the sudden cardiac death. And the thought was that there was some myocarditis ongoing. And so now in my mind, doing research, sometimes you feel like two forks in the road are coming together where, I've been studying scleroderma muscle disease, for the past 10 years. And then now I'm understanding the fact that the heart is very important to understand why some of those patients who are so dear to me actually passed away, potentially because maybe there was some myocardial involvement. And so I was quite surprised. We were actually, I don't know if you guys been having this a lot, but you guys in Pakistan, but in our hospital, we were seeing a lot of cases of myocarditis. And we had wondered, is this something viral? But we do all the viral serologies, and these patients are so sick, they're admitted to the hospital. And or was it the COVID vaccine? We're thinking about all these things, but we're seeing all these cases of myocarditis in the hospital. And some of the patients, not all, were patients who had myositis overlap. And interestingly enough, we noticed that these patients were anti-coup positive. And so we reported this, and you can see this is an endomyocardial biopsy of these patients with inflammatory cells. And but the key point in this case series was that these patients had atrial and ventricular tachycardias, just like that 1993 paper. And this subgroup of anti-coup positive patients are patients we really need to be careful about, I think. And I remember when we were writing this case series, I was thinking, oh, we're going to be the first people to report this. This is so important. But actually, out of Italy, it was like a research letter that was just published, like maybe 6 months or a year before our publication, where they also reported that anti-coup positive patients tend to have more cardiac involvement. And now I wonder if back in that 1993 paper, maybe those patients were actually cardiac, maybe were coup positive as well. Anyways, so that's the coup story. And this is a image to highlight that, please don't forget about these myositis-associated autoantibodies, because we always think about the MSAs, myositis specific. But clearly, these patients with overlap myositis have these distinct autoantibodies. And when these are positive, we do really, especially with the scleroderma myositis group, I think we have to be worried about some cardiac involvement. And more to come, because we're doing a lot of exciting work in this area to understand that intersection now between the heart and the muscle. And we have some papers that are being submitted right now, shortly, hopefully, on looking at myocarditis and myositis as well. So conclusions of my talk, sorry, I had to talk your ear off, but this topic is dear to my heart as well. Hopefully I was able to impart to you that overlap myositis can exist with many CTDs or connective tissue diseases, but I think so far the most common is scleroderma. And this fibrosing myopathy is a unique histopathologic subgroup. And don't forget about this high-risk association of cardiac and skeletal muscle disease. And really, I really hope that we'll have more future studies to better classify patients with overlap myositis so that they can qualify for trials to better predict outcomes and a better tailored treatment algorithm and plan for them. So thank you for your attention. And these are my acknowledgements. And if you have any questions, please feel free to ask. Thank you so much.
Give me a short sign when I can start? Okay. So hello, everybody, dear colleagues in Pakistan. It's my great pleasure and an honor to talk today to you on the topic of psoriatic arthritis, the current management strategies and the role of the IL-17 inhibitor secukinumab in psoriatic disease. So my name is Frank Behrens. I'm a rheumatologist by training at the Goethe University in Frankfurt, Germany, and I'm leading drug development and clinical research within the Fraunhofer Institute for Translational Medicine and Pharmacology. So here are my disclosures. Here are a disclaimer from the company who is sponsoring this meeting today. Yeah, I think most of you are familiar with psoriatic arthritis. So we prefer nowadays to talk about a psoriatic disease, not arthritis, taking into account that this kind of a disease is very heterogeneous. So we have different kind of musculoskeletal inflammation, in addition to the skin and nail inflammation, which is illustrated here. Of course, we have in some cases typical peripheral arthritis with a plaque psoriasis, but sometimes we have extra articular musculoskeletal inflammation like dactylitis and enthesitis, but also spinal involvement. And enthesitis is a crucial thing in psoriatic disease for many, many reasons. On the one hand side, for the reason regarding pathophysiological concept, but also to better understand what drives the burden of the disease in an individual patient with psoriatic disease. And it's not only a heterogeneous disease by the phenotype, it's also a disease where we have several therapeutic options available in different countries across the world. I think in your country, you have the conventional DMARDs like methotrexate, you have the etanercept as a TNF inhibitor, you have a tofacitinib as a JAK inhibitor, and you have secukinumab available to treat your patients with psoriatic arthritis. We have several, let's say, recommendations from official organizations how to treat patients with psoriatic disease. And I definitely prefer to use a CRAPA recommendation. CRAPA means Group for Research and Assessment for Psoriasis and Psoriatic Arthritis. This group started to work together as rheums and derms and other healthcare professionals when Philip Meese in US made the first study with etanercept and infliximab in psoriatic arthritis. And we in Germany, for example, made at that time a study with leflunomide in psoriatic arthritis. And then the idea came up to better collaborate across the world on the psoriatic disease to achieve improvement for patients in our routine care. And this was a starting point for the CRAPA. And CRAPA has built up different recommendations for treatment of psoriatic disease in the past. And this is the newest one from Laura Coates, published in 2021 in Nature Review Rheumatology. And the main aspect how these recommendations were built up is that we look for different domains of a disease who might be affected: peripheral arthritis, axial inflammation, enthesitis, dactylitis, skin psoriasis, nail psoriasis, and in addition, so-called associated diseases, which is uveitis and inflammatory bowel diseases, which all might influence the decision what kind of product should be used to treat our patient with psoriatic disease. And you see in all the boxes, the drugs or the mode of actions who have demonstrated evidence that it might work in this individual domains. And I think, of course, most of the patients, as we are rheumatologists, are starting having peripheral arthritis and enthesitis. And when you are in these different domains, then you have to think about whether a product is strongly recommended or only conditionally recommended or strongly against. This slide is also from the CRAPA recommendation in the Nature Review Rheumatology article. And you see that for all the different domains, peripheral arthritis, DMARD naive, peripheral arthritis, inadequate response after DMARD, peripheral arthritis failed a biological DMARD, axial disease, enthesitis, dactylitis, and so on. For all these, you can see in the different rows the different products who had either a strong recommendation or only a conditional one, or a strong recommendation against. For example, there's strong evidence out that conventional DMARDs are not working in axial psoriatic arthritis. So if you have a patient, for example, with an axial involvement, you can clearly see that axial disease shouldn't be treated with a conventional DMARD. You should directly go to a biological based on the study outcome demonstrating that it might not work in this condition. Let's start with the peripheral arthritis to look more deeper into this field, because this is the most common feature active in psoriatic disease in combination with enthesitis, and most of the data were generated in a typical clinical trial focusing on peripheral arthritis. This is why we have very good evidence for this kind of domain. Yeah, I think you are all rheumatologists and you are aware how arthritis might look like. And this is a typical proximal interphalangeal joint arthritis, a PIP arthritis. And of course, normally you see a synovitis proliferating, having a lot of inflammatory cells included and inflammatory cytokines involved, a huge exudation, which means a lot of fluid in the joint, and you see it like this. And this might result in an erosive disease. And this is a typical feature for rheumatoid arthritis. In psoriatic arthritis, it might differ. In rheumatoid arthritis, you have this synovitis, this pannus, where TNF is a crucial cytokine within this pathophysiological process in a typical synovitis arthritis, which is typical for rheumatoid arthritis. It's different in psoriatic arthritis or in spondyloarthritis in general. Here you see it. On the left-hand side in this cartoon, you see a joint again, but you see what is marked here is the enthesial complex. It's not the synovial membrane in the cavum of the arthritic joint. It's the enthesial compartment, the tendons, the ligaments. All these are involved very early in psoriatic disease, in contrast to RA. And synovitis in psoriatic disease is often secondary and followed after enthesitis, tendinitis, etc. And this is also of importance because in this specific kind of musculoskeletal inflammation, not focused on synovitis, but on enthesitis and the ligament parts of the compartment of the joint, TNF is not playing the major role. It's mainly an IL-23 and IL-17 driven process, but not a TNF, because TNF is a typical, let's say, unspecific pro-inflammatory cytokine, which is generated later on, but not from the beginning in the specific conditions of psoriatic disease. And this is important to understand. We believe nowadays that IL-17 and IL-23 inhibitors changing the underlying immune processes, while TNF blockade is only a classical anti-inflammatory cytokine, which, if it is blocked, might not influence the overall underlying immune dysregulation. Yeah, why is enthesitis so important? This is outstanding work from Leeds in the United Kingdom, from Dennis McGonigal's group, understanding that we have an anatomical neighborhood between the nail matrix and the flexor and extensor tendon of the DIP joint. Why is it so important? This helps us to understand why patients with nail psoriasis have a threefold higher risk to developing arthritis. And it also helps us to understand why typically in psoriatic arthritis, DIP joints are involved, while in RA, normally not. How can we understand it based on these findings and the anatomical sections? Yeah, you see that if we believe that enthesial compartments and tendon compartments are very early involved in psoriatic disease, but not synovitis, you can imagine that the DIP joint is heavily characterized by capsularized by tendons, but not by synovial membrane. It's too small for a huge synovial membrane, while MCPs and PLP joints have a huge cavum, a huge space where synovial membrane is of more importance. And this can now understand why DIP joints with PSA are often involved, but not in RA. And you can see here, you can imagine if we have a nail psoriasis illustrated on the left part of the slide, immediately this inflammation can continuously proceed to the anterior compartment at the finger and then making a step forward from a pure skin and nail disease towards to a musculoskeletal inflammation. And this can mimic in mice model as well. So if you have mice with a psoriasis and you induce arthritis in the specific models, immediately they start at the nail compartment and the DIP joints to get inflammation, while in classical collagen-induced arthritis model for rheumatoid arthritis, other joints are involved. And you can also see here, this is an example of fluorescence optical imaging, which is a new technique where you inject indocyanine green, and then you can immediately see this increased fluorescence marker as a sign of inflammation at the DIP joints in the psoriatic patients, typically at the DIPs and later on only at other joint compartments. Having this in mind, the question is, what is the ideal therapeutic approach for our patients with peripheral arthritis and maybe enthesitis in psoriatic disease? And you are fully aware that etanercept with Philip Mees has demonstrated effectiveness in PSA, but also other TNF inhibitors like adalimumab is an ADEPT trial, infliximab, etc. And the problem is, based on the different clinical trials, that we missed in the past direct comparison. So if you ask me what is the best product for my individual patient, the answer is I have no clear answer, based on the fact that in the past we didn't have a clear head-to-head trials. But we had in the past was indirect comparison. Indirect comparison means you make a network meta-analysis like this, where you compare placebo responses to active and the delta, and then compare it to different other products. But of course, this is a challenge because this is not a typical head-to-head approach. But nevertheless, you see on the left-hand side the so-called number needed to treat in this kind of indirect comparison. Number needed to treat means how many patients do I have to treat to achieve at least in once what I want to achieve. And you see the number needed to treat to achieve ACR 20 in secukinumab on the left-hand side is 2.3, means in 2 patients treated with secukinumab, at least in one I achieve what I want to achieve. The same is ATR 50, which is a higher hurdle of response. 3, if I treat 3, at least in 1, I will achieve with secukinumab an ACR 50. And this is a comparable to, for example, a TNF inhibitor like golimumab. You see, it's a little bit better than what I can achieve with etanercept. You see it lower down in the slide with ETN as an apparative. So this gives you a flavor of the effect size of secukinumab Cosentyx in psoriatic disease, with this very impressive number needed to treat demonstrated here. But of course, what we want to ask for is show us a direct comparison between TNF inhibitor and secukinumab or IL-17 inhibitor. So there are several randomized clinical trials, head-to-head trials of different companies listed here: Pfizer, Roche, Sanofi, Abbott, and sometimes people designing clinical trials in a way that they will never fail. For example, Abbott down here, you see 100%, which is a red bubble. They were successful in a head-to-head, means the product of Abbott or AbbVie wins against the comparator. In Novartis in 84%, so in some cases not. So Novartis was so, let's say, motivated to make a head-to-head trial with secukinumab against a TNF inhibitor, which is adalimumab in this case, to show effectiveness of secukinumab in psoriatic arthritis. And this was the EXCEED trial. So in the EXCEED trial, we have a primary endpoint after a year of treatment, be randomized and blinded secukinumab against adalimumab in a monotherapy setting. No one has methotrexate. It's a typical monotherapy. Patients failed a conventional chemotherapy like methotrexate, and then they were randomized to go either to secukinumab or to adalimumab. And to be honest, keep in mind that adalimumab is much stronger with respect to skin disease, for example, compared to etanercept, which is a TNF agent you have available in your country. So, and the primary endpoint was ACR 20, typical arthritis score after 1 year of treatment to see whether this is superior to adalimumab. And this is a primary endpoint. You see the red line is the TNF inhibitors, the blue line is secukinumab, Cosentyx, and you see it is as fast as adalimumab, and you can achieve at least the same range of ACR responses after 1 year. And you see the blue line is a few more percentages. It's above the red line, means there's a trend to have more responses in secukinumab compared to adalimumab for ACR responses in patients with active psoriatic arthritis. But it is not significantly superior, which was planned for the study. You see the p-value is 0.07 and it has to be 0.05 to be significant. But you see here, it is at least as good as adalimumab in psoriatic arthritis, focusing on arthritis. So if you go to ACR 50, it's the same picture. You are at least as good as adalimumab when you treat with secukinumab, with a slightly trend to be superior to adalimumab. And I come back to enthesitis because enthesitis is so crucial in PSA. So there are data out that patients with or without enthesitis are totally different with respect to burden of disease. So if you have a patient with 10 swollen joints and 3 swollen joints, of course, you would immediately recognize that 10 swollen joints is a more severe disease than 3 swollen joints, for sure. That's absolutely the truth for rheumatoid arthritis. In PSA, it's interestingly, if you have a patient with 10 swollen joints but no enthesitis, and a patient with 3 swollen joints but enthesitis, the disease burden is much higher in those patients with 3 joints plus enthesitis compared to 10 joints only without enthesitis. Just illustrating the importance of enthesitis for the well-being of our patient, for function, for burden of disease and loss of life quality. So here we compare different scores for enthesitis, the Leeds enthesitis index, LI, and the Spark index at week 24 and week 52. And you see again in the trend, secukinumab seems to be slightly better. It's not a significant difference, but at least as good as adalimumab. And again, adalimumab is a more powerful product in spondyloarthritis, specifically in patients with psoriatic arthritis compared to etanercept. So let's move forward to the next slide. This is treat to target approach. Of course, we don't want to compare only ACR responses, because ACR responses are a delta, an improvement, which is great, but we want to achieve a specific target, a disease cause which is very low inflammation, very low involvement of musculoskeletal system. And this is MDA, minimal disease activity, or VLDA, which is very low disease activity. So maybe you are aware in MDA, we're looking for swollen joints, for tender joints, for skin disease, for HAC-DI, for function, for patient global, for pain, and for enthesitis. And you have to achieve 5 of these mentioned 7 domains, with only 1 active maximum enthesial site, 1 active tender or swollen joint. And MDA is a very well-controlled disease associated with no risk for structural changes in X-ray and with no risk for cardiovascular events compared to a normal population. VLDA is mainly remission. And you see, again, at least as good as adalimumab, the secukinumab data, and at week 52, slightly higher, 43 MDA percentage patient, compared to 37, which gives you a flavor how it works. And if you look to low disease activity in a joint score and remission, you see that we have more patients in low disease activity and remission in SECO compared to adalimumab. This is only one head-to-head study, Cosentyx, the SECO medium study. But there is another one, the SPIRIT head-to-head, which is ixekizumab. And ixekizumab is an IL-17 inhibitor as well. And they made a different study design. They looked for patients who achieve both PASI 100. PASI is a psoriasis area and severity index, means a skin score, and a PASI of 100 means complete clear skin, plus ACR 50, 50% reduction of the arthritis score. And the patient were asked to have both simultaneously, and a simultaneous response of 50% in the ACR score plus a complete clear skin is more often achieved with the IL-17 inhibitor ixekizumab compared to adalimumab. Of course, mainly due to the fact that they have a much better skin response compared to adalimumab. And keep in mind, etanercept has a much lower skin response compared to adalimumab, which would make these differences much higher. And they met it, though they have more patients, 10% more patients achieving both 50% joint reduction and 100% clear skin when treating secukinumab and adalimumab, or treating ixekizumab and compared to adalimumab. So if you compare both IL-17 inhibitors, on the left you see SPIRIT head-to-head, which is the ixekizumab study, and right it's the EXCEED study with secukinumab. You see different outcomes. If you go clockwise, you have ACR 20, ACR 50, ACR 70 for the arthritis scores. You have the PASI and the MDA and VLDA, the combined scores. And on the left side, you have the enthesitis story. And you see the dark red, purple line is the TNF inhibitor, adalimumab, and the yellow one is the IL-17 inhibitor. And you see clearly that in all domains, the yellow line is at least as good as TNF inhibitor, but in many other domains, it is superior, specifically for skin disease and for other enthesitis domains, a trend to be superior. Gives you confidence that it works out properly. What about the JAK inhibitors? I think the JAK inhibitors, at least for psoriatic arthritis, has demonstrated in mainly two studies. So OPAL studies with tofacitinib and the select PSA studies with upadacitinib. And I think you have TOFA available in your market. There are two limitations with the JAK inhibitors in daily practice. The one is it is only licensed and approved in combination with methotrexate, while the biologics work without. And the other one is that we have recently the information on a tofacitinib study against TNF inhibitors, that we have a higher risk for cardiovascular events and malignancies in the tofa-treated population compared to the biologic-treated patient, in this case, the TNF inhibitors. So this leads to a kind of warning of the European Medical Agency, but also of the FDA, pointing out that these medicines, means JAK inhibitors, all JAK inhibitors, should only be used in the patients without any other suitable treatment alternatives, when they were older, when they had an increased risk for cardiovascular problems, those who were smoking or have smoked for a longer period of time, and those with an increased risk for cancers. Also, JAK inhibitors should not be used in those patients with risk for blood clots, thromboembolism, VTEs, and this gives us now the challenge that those drugs were only recommended for a small proportion of patients based on the fact that they demonstrated an increased risk for adverse events, specifically cardiovascular events and malignancies compared to biologics like TNF inhibitors. This gives us some limitations. And this was also reflected now by the CRAPA recommendation. You see here, JAK inhibitors should only be used with caution in those with elevated risk for cardiovascular events or congestive heart failure, and elevated risk for VTE. You see it on the right-hand side, this JAK inhibitor column here, which is also again listed in the CRAPA recommendation in the Nature Review Rheumatology article. Let's move forward to the axial disease. If you have axial inflammation in psoriatic disease, you have a challenge to choose the right product because, as I mentioned in the beginning, clear evidence that conventional DMARDs are not working in axial disease. And in the past, we believed that all the biologicals will work, but it's not the case. This is an example for an IL-23 inhibitor, risankizumab, and you see different doses of risankizumab and placebo. You see different outcomes, biomarker outcome, imaging outcome, and clinical outcome. And you see in all the domains, red means worsening, blue means improvement. And you see a very, let's say, colorful picture, unorganized, means at the end, we have no effect of the product compared to placebo. This was surprising to us. And then the question raised whether Novartis made a trial with secukinumab specifically in PsA patients with axial involvement. You see here's a study design, very straightforward study design, placebo, 300 and 150 sub-Q secukinumab. And you see here the outcome, which is the ASAS 20 from this so-called maximized trial. And you see a clear available study recommendations. This is a EULAR recommendation from the conventional DMARDs. Go directly to B DMARDs, either TNF or condition is of importance for our patients. And if we as rheumatologists want to achieve a proper response in our patient cohort, we have to take care of the skin as well. Of course, you can argue it doesn't matter whether secukinumab is superior to a TNF inhibitor in skin, because mainly I'm focusing on arthritis, but I will show you why it is of importance. So this is again the head-to-head study of secukinumab Cosentyx against adalimumab as a TNF inhibitor, and this is PASI 100. Remission of the skin, no plaque anywhere. So complete clear skin. And you see that you can achieve it in nearly half of the patient with secukinumab and only 30% in adalimumab treated patients. In psoriatic arthritis patients population. It's not a skin psoriasis study, it's a PsA study. And why is this important? And this is a very interesting slide, a kind of, let's say, flying carpet. I will guide you. We go to the right part of the figure. So this is the improvement in life quality, the EQ5D. So the higher, the better is the life quality. And these are the patients at the starting point at baseline. The DAPSA on the right-hand side, this is a pure arthritis score. PASI is a pure skin score. So, and if you treat a patient with any modality, and you only achieve, in a PsA patient, if you only achieve a proper response in PASI, the life quality increased only by this. That's clear, to be honest. A PsA patient, the skin is great, but arthritis is still there, is not happy for sure. And this is what we have in daily practice in our cohorts. So we have a DAPSA scoring, means a pure arthritis score. And if you have a 100% response on arthritis, this is the increase of life quality you can achieve. It's roughly in the middle only and not at the top. Why? Because the remaining skin, the response which is proper, and the DAPSA arthritis response which is proper. This is why we have to take care about skin revolvement in our PsA patient as well. Yeah, I think in summary, hopefully I have illustrated that IL-17 is a key cytokine in skin disease, in musculoskeletal inflammation, in axial and enthesitis. Why it is so important to target it and gives you some superiority compared to other mode of actions in this specific conditions. Yeah, these are the key inhibitors of different cytokine pathways, demonstrated effectiveness in randomized clinical trial. And I learned that you have available only the TNFs and the secukinumab. All these are 23 or IL-17 inhibitors, the modern biologic treatment approaches. And you see secukinumab has demonstrated efficacy in phase 3 studies for psoriasis, for PsA, for axial SPA. But of course, you have learned in IBD, inflammatory bowel disease, IL-17 will not work properly and should therefore not be used in IBD patients. With this, I really like to thank you for your attention. Sorry that it's only a virtual presentation presented by me. Greetings from Frankfurt in Germany, and I wish you a very great meeting, and I'm happy to answer some questions, and I will check out the chat and will look for the questions and address these questions properly. Yeah, and I immediately see that there is some questions. Yeah, one question is, why should I choose an IL-17 inhibitor over anti-TNFs and TOFA JAKs? Yeah, if you have a pure arthritis with a synovitis, no relevant skin response and enthesitis, it doesn't matter whether you use TNF or secukinumab as an IL-17 inhibitor. But if a patient doesn't look like an RA patient and looks more like a specific PSA patient, then we see immediately that response on skin is crucial, demonstrated at the end, because you can only achieve a proper life quality of your patient if you control both musculoskeletal inflammation and skin. In enthesitis, there is a trend that IL-17 inhibitors or IL-23 inhibitors are superior. We have a head-to-head trial, the EXCEED study with secukinumab, demonstrating a trend of superiority in enthesitis and at least the same effect of like TNFs. And the JAKs are limited right now based on the safety signals shown in the oral surveillance study, with an increased risk for cardiovascular events and malignancies in TOFA-treated patients compared to biologic TNF-treated patients. And the other aspect is that TOFA is only approved in methotrexate combination, and while all the others don't need methotrexate, and you can do it in a monotherapy. So why, next question in the chat, why choose a biologic over biosimilar? Limited biosimilars really effective of biologics. Yeah, of course, a biosimilar is a proper option. But it's a huge difference. At present, we have only the originator to block IL-17. So to be honest, the normal approach is that I check out whether a patient works fine with methotrexate. If not, then I have to think about whether TNF is the right choice to inhibit or IL-17. And as I mentioned in the previous answer to the other chat question, it is clear for me if skin is a major player and enthesitis and extra-articular manifestation, then IL-17 is superior to TNF. And if I decide to go to IL-17, then of course secukinumab is an option, and there's no biosimilars available for this. If this is a pure arthritis patient, looks like RA-like, then of course a biosimilar of etanercept is fine as well. So the next question is, do we have concrete head-to-head studies of IL-17 versus etanercept versus TOFA? So answer is no, but we have, as I mentioned and demonstrated and showed in my presentation, head-to-head of IL-17 against adalimumab. Why not etanercept? Because adalimumab is superior on skin response compared to etanercept. This is why everybody asks the company to compare to adalimumab, the most powerful TNF, and not to etanercept, which is not the most powerful product in this PSA condition. Therefore, you can extrapolate that you might have already a lower effect of etanercept compared to adalimumab, and therefore all the superiority demonstrated of IL-17 inhibitors to TNFs will also be present compared to etanercept. The next question was, do we have a comparison to JAKs? Yes, but only upadacitinib, the JAK inhibitor, upadacitinib, compared to adalimumab again, adalimumab as a reference for TNF. And the JAK inhibitors were in the same range of the effect size like adalimumab. And regarding skin response, far away what you can achieve from the IL-17 inhibitors. So this is an indirect comparison, but the direct comparison is only made with UPA, and TOFA is definitely not more efficacious than upadacitinib. Yeah, so as I don't see any further question in the chat, again, I really like to thank you for the kind invitation, and I wish you a great meeting during the rest of the days. Thank you very much. Greetings from Germany.
Request to all the organizers and the representatives of the pharmaceutical companies to stay in this hall. I would like to invite respectable Dr. Tafazul Haq and Dr. Aflaq to please come on stage. I would like to request Dr. Aflaq to please present the shield of Chief of Organizer to Dr. Tafazul Haq. Now, Dr. Tafazul, please hand over the shield of convener to Dr. Aflaq. Please welcome Dr. Mahjabeen to receive her guest of honor shield. I would like to invite the following organizers to receive their shields as a token of appreciation. Dr. Ali Rukh, Dr. Aftab, Dr. Asad, Dr. Wasif, Dr. Amara, myself, Dr. Komal, Dr. Amin, Dr. Ali Shahbaz, Dr. Kashif Azim, Mrs. Samreen Nadia, Mrs. Sonia Asif, Mrs. Sumaira Khan, Mrs. Aisha Hussain, and our very own Dr. Adnan, who has put a lot of effort for arranging this conference today. Click to print media partners, Muhammad Anas for providing extraordinary IT services, Haseeb Khurram, Rizwan Butt, We are delighted to honor our pharmaceutical partners who have made this conference possible. The representatives of the following pharmaceutical companies, please join us on stage to receive your well-deserved recognition. Hirani Pharmaceutical Company, Hilton Pharmaceuticals, Platinum Pharmaceutical Companies, Mector International Pharmaceutical Companies, Novartis, Matrix Pharmaceutical Companies, Etco Pharmaceutical Companies, Tuzman Pharmaceutical Companies, Feroz Sons, Kaizen Pharmaceutical Companies, Gentech Pharma, High Noon Pharmaceutical Companies, Varick Pharmaceutical Companies, High Noon again. High Noon Pharmaceutical Companies, please. Right. Okay, Varick Pharmaceutical Companies को लेकर हैं. High Noon से बात ना बुलाओ. ठीक है. Med Art Pharmaceutical Companies, Organ Care and Cure Pharmaceutical Companies, Dr. Arman, High Noon वाले कहाँ हैं? MedLife Pharmaceutical Companies, Esta Pharmaceutical Companies, बुलाऊं दोबारा? Faiz Alam Faizi, please come on stage. Is there anyone available here from High Noon Companies? Then please come on stage. उनको बिठा लूँ या ग्रुप फोटो करूँ? Thank you so much, Dr. Aflaq and Dr. Tafazul. We are here now for the group photo. Everyone, all the organizers and participants, please come on stage for a group photo.